Yeah, okay. Then over to me.
Yeah, and I will give over to you. Welcome all delegates for the second day. We had a very successful first day. We had a very successful first day, and almost 12,000 delegates attended, it seems, though we did not see 24 countries participated, and that's a good job that we did yesterday. It was basically because of all the faculties who are renowned throughout national and international. And now we start with the first presentation. I invite Dr. Shiva Shanmugam to present his track US image analysis, followed by Dr. Gopal and Amjad, who will also go on live. So Dr. Shiva Shanmugam, please.
Sir, can you see my screen?
Yes, we can see your screen very well.
Yeah, good morning, everyone. So I'm going to play a video which is sent to me from Sandeep sir yesterday about a brachial plexus block. So which he performed recently, and he had some practical questions. And I'm just going to play it and then try to analyze, how we should be doing it. So this is the video just I'm playing. This has got a question. So I'm going to stop as the question comes. So he is identifying individual nerve root, and then that is the dorsal scapular nerve. C5, C6. That is a pleura. Then the subclavian artery comes to the picture. So I will stop it here. At this level, the question asked is it the right place to block? So now here you can see the pleural line and then the subclavian artery, the brachial plexus elements are grouped together, but this is not the ideal place to block. Why I am saying this is, at this place, the inferior trunk would have not combined with the remaining part of the brachial plexus element. To highlight that, I will play another video so that you can appreciate when the inferior trunk comes into the picture. This is a Amit, are you there to give me a feedback? My screen is visible, and am I all right?
Yeah, yes, your screen is visible, Shiva.
So I'm just playing. You can see this is C5, that is C5. This is C6. This is C7, and this is the C8 from the proximal part of the first rib. Still, you are not seeing the pleura as we come down. Can you see this is C8? This is the T1. I will stop the picture now. If you see it here, this is the subclavian artery, this is the pleura, this is the first rib, this is the upper trunk, this is the middle trunk, this is C8 and T1. Still these two complex, that is a C8 and T1, has not come on top of the first rib. So in this place, if you inject, sometimes you may miss the T1 may not join the inferior trunk. So what we should be doing ideally is you get all the component of the inferior trunk on top of the first rib. So we are to describe this, we are calling this position as an open sign. Open means the rib is not closed. It is halfway rib, halfway pleura. The T1 root will comes from below the rib to come on top. So I will play it again to appreciate it, what happens as I scan down. So now I'm just scanning. Can you see the inferior trunk is, this is a C8. As I scan down, this is C8 on the proximal part of the first rib. C5, C6, C7, that is a C8. T1 is the last one to come. And still it has, now only it has come on top of the first rib. So this we are calling it as a closed sign. This is an open sign. So whenever you wanted to block, you have to inject when the inferior trunk come on top of the first rib so that you will not spare the inferior trunk fascicles. So now, yeah, I'm going back to the video. Is there any other comments from the other experts? Bala sir, Amjad?
Really, nothing to disagree there, Shiva. I think that's yes, perfect.
Sir. Yeah. Now I'm continue to play to the video so that we will look at the other questions. So yes, this depiction is fine. This is the brachial plexus. These are the components. But now we can appreciate even more better and discriminate what are all going. Let us look for the other question, what it is. The color has been activated. And then now I stop. So there is a branch which is crossing between the elements of the brachial plexus. So something on top looks like the upper trunk, or we don't know what it is, but some artery is arising from the subclavian and dissecting the brachial plexus element. Let us look at what is that from the anatomical dissection point of view. The question is it the dorsal scapular artery? Yes, it is a dorsal scapular artery. For that, I will just put up some images for the audience to understand. In the brachial plexus, we are going to see three blood vessels. One is transverse cervical artery, that is from the much higher. It will cross over the brachial plexus element at the interscalene level. The artery will cross over them. But if you look at down, there is a branch which is going behind the elements of the brachial plexus, that is always dorsal scapular artery. If you look at this is a dorsal scapular artery, and one more branch, superficial, the suprascapular artery will go over the plexus. These are all the three arteries that are in relation to our brachial plexus elements. If you look at a little more a better image, if you see an artery over the interscalene groove, that is transverse cervical. If you see any blood vessel that is dissecting the brachial plexus element, especially between the upper and the middle trunk, that is dorsal scapular. If any vessel you are seeing over the brachial plexus element at the level of supraclavicular area, that is suprascapular artery. So even in the video which I showed, we have the same picture. I will just play it again for. So this is the video which I am running. If you look at, so this is C5, C6, C7, C8.
Can you
Can
make
you
it
see
full
the vessel?
screen?
Yeah, I will make it a full screen. So this is an inferior trunk. That is the middle trunk. Can you see that there is a vessel which is crossing in between? I will play it again.
Yes, we saw that.
So from here, it will just open up and then go in between. Can you see that now? So that is the artery which is bisecting the brachial plexus element. That is always the dorsal scapular blood vessel. Yes, that is the dorsal scapular blood vessel, usually dissects the brachial plexus element. So these are all the blood vessels in relationship to the brachial plexus block. So now going back to the presentation, the original video. So now I'll play it again. So that is what we are looking at is a dorsal scapular artery. So we should be careful about it. That can produce a injury to the vessels and can lead to a hematoma. So now, so is the sheath that's separated from the brachial plexus, is it an intrafascial? Yes, it is an intrafascial, because you can see the layer has opened up and the local anesthetic is going inside. Do I need to do this? So I don't know how to stop the video playing. So now then the needle is coming up on top. This is an upper trunk, this is the subclavian artery, and this is the middle trunk. The needle is trying to get inside between the upper and the middle trunk. We are injecting 3 ml of local anesthetic. Because of the hydrostatic pressure, the subclavian artery is getting compressed because the local anesthetic is seeping into the brachial plexus sheath. So this is between upper and the middle, the local anesthetic is getting deposited. Volume is about 3 ml. Yeah, now I will stop the video so that we can discuss upon. So now one of the question is whether this subfacial deposition, is it needed? That is the question that was put forth. Amjad, do you have any answer for that? In the meanwhile, I'll open up the PowerPoint.
Yeah, I think that yes, in my practice, we always do that subfacial sort of injection, but we are extremely careful about the needle trajectory, the needle visualization, and the entry point into that facial entity. The way we do it is we actually point the needle into the hyperechoic areas, which are likely to be connective tissues when we enter, so that the recoil doesn't take the needle into the actual nerve substrate. Uh, the injection into these facial layers holds the local anesthetic very closely within the plexus, and creates quite a decent block. There are some people who actually inject in between the fascicles, making it almost like a true intraneural injection for the supraclavicular block.
Yeah. Now, in this image, I mean, everybody can able to see this is a subclavian artery, and this is the first rib, and this is the pleura. So we got all the complex on top of the first rib. So what we are seeing as a bunch of grapes is this. That is, the upper trunk divides into anterior and posterior division. Just below that is the middle trunk and the at the corner pocket. Corner pocket means between the first rib and the subclavian artery between about 3 o'clock to 6 o'clock. And this point is called as a corner pocket, which harbors the inferior trunk. And in this cadaveric image, you are not able to appreciate a brachial plexus sheath on top. So that is the layer which is covering on top only we are calling as a brachial plexus sheath, because during dissection we have removed all these things to identify the individual elements. Suppose if you put a local anesthetic on top, if you look at the surface area that is required to be soaked is very high. So if you put a local anesthetic all around, how long it is going to soak the innermost core fibers of individual trunks, we don't know. In a study where we compared between the extrafacial and subfacial injection, when we deposit the drug outside the brachial plexus element, it took somewhere around 30 to 40 minutes in some individuals to have a complete conduction blockade of all the brachial plexus nerves. So that is what we are stuck with. Even, I mean, anybody can appreciate whenever you are doing a sciatic nerve block, to get a complete conduction blockade of all the branches when you are depositing in the subperineal compartment, sometimes it may be even at 45 minutes. Even if you start the surgery after 1 hour, when they are drilling the medullary canal, patients will be uncomfortable. That simply indicates the core fibers are not satisfactorily soaked. Here, if you look at the brachial plexus, this is much, much bigger than the sciatic nerve. When you are depositing the local anesthetic all around, how we can ensure that every fascicles are soaked to the complete conduction blockade is a question. So that is why evolution wise, we are forced to go in between these elements and try to deposit the local anesthetic. By when we are trying to do, what we are achieved is our block become more consistent in terms of you get the block about 15-20 minutes consistently with 20 ml of local anesthetic volume. So that is what pushed people to go inside and deposit the local anesthetic between the element. But the danger is you should thoroughly understand the sonoanatomy of these elements. If you go inside and inject, it will become an intrafascicular. So that is where we are stuck now. The going inside is fine to decrease the latency of the onset of block, but the danger is you should not go into the fascicles. So that learning curve is definitely is there, both with the needling skills as well as the understanding where we are injecting. So if that comes up, then we may provide a safe subfacial injection where we get an onset of consistent block without a side effect. So this is what we are looking at the microanatomy. We have clear cut facial elements. Even in this, you see the inferior trunk separately is there, whereas the upper and the middle trunk, the upper is divided into two. This is the middle trunk, whereas the inferior is separate. So unless you get it on top of the first rib, this will not come and join the other group. That is why even at the supraclavicular area, the inferior trunk sparing is quite common if you don't attend to it. So again, I will go back to the video. So that is the reason why we wanted to come to the subfacial. Basically, subfacial injections increases the onset by 10 to 15 minutes, and the block has become more consistent. You will not see
the onset.
Sir, TVS sir, is there anything that you wanted to add?
Siva, I mean, when you inadvertently place the needle
Yes.
and do an intravascular injection,
Yeah.
I mean, once a while, the patient does complain of a shooting pain.
Yes.
And sometimes the person who is doing the injection will tell you that there is quite a bit of additional
Resistance.
pressure. So what other safeguard would you want to tell the viewers?
Yeah. So now the thing what we have is to detect intraneural injection is one is the patient, the second one is the injection pressure with your perception, and third thing is the nerve swelling that what you see. These are all the three things we have right now at our hand. So the patient being a monitor to us depends on how judiciously you are sedating them. You can give a sedation so that they will accept the procedure well. At the same time, you should be able to maintain a reliable communication with them. So that is an end point of sedation. The patient should be comfortable, but at the same time, when you call them, they should be able to tell their name. They can able to appreciate if there is a paresthesia, so that you should not have a high sedation. That is Ramsay sedation score of 3 or 4. You should not go. You should target between 2 and 3, so that you will maintain a reliable communication with the patient. That is the first thing. Second thing is you practice with a constant syringe and the needle, so that you will appreciate. Suppose if you use a 20 ml with a nerve block needle, the resistance produced by the system itself is very high. The injector may not perceive the change in the pressure. So you always choose your own syringe and then the needle. For example, you all the time use 10 ml and 22 gauge nerve block needle. You know what is the resistance offered by the system, and if there is anything else that you can easily perceive and communicate to the performer. If you keep on changing your volume of the syringe, size of the needle, then it is logically not difficult to pick up in the real time the change in the pressures. And the third thing is how vigilant you are in locating your needle tip. All the time you should try to see where is your needle tip before injecting, and then you should pay attention how whether the any of the neural elements are swelling. That is the hypoechoic circles, are they swelling or not, is what you should look for. So these are all the three things that we will have in a real time to have a check on the intraneural injections.
Shiva, we have just 1 minute left.
May I, with
So
the
now,
permission of the moderators, just put one perspective to what Shiva has just said?
yeah,
I guess the other way to look at the advantage of what you have just said is the rib actually can shield the pleura when we really
very
go with this approach, so that we don't damage the pleura.
That is another safety guard. If you have a rib at the bottom, you are safe that you are not going to inject onto the pleura. Even in this image, what moving underneath is the pleura. So Sandeep sir is careful enough to stop the needle on top. So he has already put it up. This is the rib, this is the pleura. When you are going to the inferior trunk, there is very high chance that if you are not careful enough, you will breach it. So you should keeping the rib. Another advantage is it is safeguard on the posterior aspect. So these are all the elements. So subfacial injection increases our latency and consistency of the block, but at the expense of chance of intraneural placement. That should be with the performer. He should be aware of that and be careful while he is performing.
Thank you very much, Shiva, for those very nice inputs and insight into the supraclavicular block. Can I share with just one slide?
Yeah.
You'll have to stop sharing, Shiva.
I'm stop sharing. Yeah.
Okay. So this is just one slide. I don't have to. I have to say much. I don't have to say much on this. So this is a cross section that we performed in Graz in Austria. So what you can see is basically, as Shiva has mentioned, this is the first strip on which is placed the subclavian artery, and these are the brachial nerves. Now, you can see there's a fine sheath which goes around the brachial nerves, and this is made up of the perimysium of these muscles in anterior and the middle scalene. And the brachial plexus is sandwiched between this subclavian artery and the vein and the muscle on the other side. Now, this is what he has explained, the corner pocket. What you see here is the non-neural tissues and the neural tissues which are more dark. So there is definitely a place. Now this might act as a buffer where if you insert your needle during a subfacial, you see that sometimes the trunks or the divisions, they rotate themselves, and this could be a protective phenomenon. This is also called as the gliding phenomenon by the neurophysicians. The corner pocket is one which we have. I just wanted to have one small word with Shiva or the panel. Whether do you do the corner pocket first or you do the superior and the middle trunk? Just one sentence.
I would always target the corner pocket first, Sandeep.
Okay.
Because when you target the corner pocket first, it tends to lift the plexus up. And I see that there is a better definition of the inferior trunk and the middle trunk when I have targeted the corner pocket. And because this is the area that we most often tend to miss, I would always start with the corner pocket. Shiva, do you differ with that?
Yeah, I mean, sir, that's fine. That is definitely one logical way of doing it. But as we evolved on identifying individual component, now the upper and the middle trunk is quite easy to identify. As you said, the inferior trunk is the one is commonly spared, whereas upper and the middle trunk easy to identify. We deposit the drug there so that those things are getting eliminated, and then inferior trunk is quite visible. So we were doing that way also. But the other way looking at it, if you deposit the local anesthetic inferior trunk, that the onset of action is much higher at the core fibers.
So what volumes you use, Shiva?
So the maximum is 20 ml, sir. We never more than that.
Amjad, your answers to this? What volumes you use at the corner pocket, middle, and the superior trunk?
I'm exactly for what Dr. Gopal said. I will target the corner pocket first. Again, as Shiva also said, that for most blocks, we do not exceed 20 ml now, not just the supraclavicular, but 20 ml is pretty much the end point for most blocks. So definitely not over 20 ml, probably around 15 ml for the supraclavicular in a smaller looking plexus or a middle-sized plexus. That would be how much we would use.
Yes. And one more thing, when you locate the brachial plexus and you know that the brachial plexus moves away when you start injecting, so do you immobilize the needle or you chase those nerves? What do you do?
Yeah, so when you create a fill, what we like to have that sort of donut circumferential fill in most nerves. So when you do make a small pocket of injection, you move the needle tip towards the corner between the plexus and the fill. And this actually peels the sheet open and creates a very circumferential fill. So yes, I do move my needle around, but when you move your needle around and you're within a sheet, you need to move it into areas where the local anesthetic has already been injected.
Yes.
Rather, try not to pop things when you're inside a sheath.
Yes. Thank you very much, Dr. Shiva, Dr. Amjad, Dr. Gopal. Shall we move to the next image?
Thank you very much.
Yes, please.
So this is the one that is the sciatic one. And shall I start playing, Gopal, Amjad?
Yes.
Please.
You let me know when to stop.
Please. So I think before you start, Sandeep, this seems to be the subgluteal sciatic. As you've labeled here, that's the greater trochanter. This muscle here is the quadratus femoris. This is the sciatic nerve there. That is the gluteus maximus. So that should be the skin and subcut tissue over there. So this definitely seems to be a subgluteal sciatic nerve. So please carry on playing. Yes. So here you have depicted this greater trochanter, which casts an acoustic shadow there. And again, if you come from the top, that would be the gluteus maximus, and that would be the sciatic nerve, and that would be the quadratus femoris. And this will show you your projected path of the needle from lateral to medial in plane with the ultrasound beam. You're using a low frequency transducer. The depth is set at 9.2, and the sciatic nerve is visible at approximately halfway mark. So this is approximately 4.5 centimeters from the skin. Anything else, Amjad?
Really, that should be the the prologue of it. What you can actually look for in this screen, I'm just going to try to draw it here on here, is this little area over there. Okay, so this
It's
like
not.
We are not seeing. We are
Yeah,
not
we see,
seeing.
we see that.
Yeah.
Yeah.
Now it's
that,
wrong.
yeah. So that is that little dark spot that you see here, maybe the separation of these two muscles, the little space called the subgluteal space. The nerve is sandwiched between these two muscles, the gluteus maximus and the quadratus femoris. So that also is one likely target. I think as we go through the video, the viewers can keep their eye on that area if it becomes more distinct.
Amjad, is that subgluteal space a continuous one or is it just a pocket on the lateral aspect?
It should be as continuous as the muscles are. So it's just like, you know, a sandwich that we are seeing here. And it's a potential space where we can actually target to get to the right spot to inject onto the sciatic nerve.
As
Okay.
Amjad said, Sandeep, it should extend across the nerve because the subgluteal space has been defined as the space that exists between the perimysium of the gluteus maximus and the perimysium of the quadratus femoris. So it should actually go around the nerve.
So probably this area and this area, we should see the initial parts of it.
Yeah. So shall I run it forward?
Please.
Yes. Yeah, I stopped it.
So you came in plane from lateral to medial, and you placed the needle approximately at the midpoint of the sciatic nerve. And that's where you made your preliminary injection of 10 mils without any resistance. So that would be the greater trochanter there. And you can see the spread of local anesthetic that is beginning to appear in this area. And there seems to be some sort of a hyperechoic line there that could probably be the perimysium of the gluteus maximus, and you're probably opening up the subgluteus space beneath. Anything to add to that, Amjad?
I'm also quite interested in this area over here. You see, this is one layer and you've seen the local anesthetic fill here, but I'm also seeing another little line over here. So I'm a little curious whether this second area is the true subgluteal space. Let's see when the video plays whether the injection is
So
in the...
now, Gopal, you mentioned that the subgluteal space has been opened up. Now, I just wanted to ask both of you whether it's a potential space which opens up after injection or you can visualize it before injection.
In thin individuals, I think Manoj Karmakar has published a couple of articles in which he believes you can pick it up before injection, but I'm not too sure. Amjad, would you like to add on that?
Yeah, as my practice has evolved, the subgluteal space is something that I intentionally look for, and it's a very reassuring sign when you do see it. Of course, if the image is not very good and the patient is quite large, then you may not be able to pick it up, but it's something that I look forward to seeing when we're scanning the sciatic nerve in the subgluteal area.
Now, Gopal, I'm using neurostimulation as well because it's a deep block and I do it quite certainly all the time. So do you use it all the time or you just do it just with the ultrasound?
I tend to agree with you, Sandeep. When we are dealing with a deep block, I always tend to combine neurostimulation with ultrasound. It's quite reassuring before we make the injection.
Amjad, what about you?
I do not use neurostimulation at all.
And the reason will be?
I feel, I mean, if you have quite a good image of the sciatic nerve or any nerve for that matter, I think I'm quite comfortable going without neurostimulation, not looking for two endpoints. I tend to be quite confident with that. So I tend to not use neurostimulation in my practice, except probably for an ultra deep, but for a subgluteal sciatic, no, I don't think I would be using.
What would be your suggestions to the beginners? To start with the neurostimulation or no?
Yeah, definitely. When you're learning and when you have a little bit of gray zones as to where the nerve is, then yes, I would definitely suggest that a beginner use a combined technique. But as your practice evolves, you find certain zones where you can work in comfortably. So probably I am in a zone where I tend to feel comfortable using the ultrasound. But again, there's nothing wrong with using or combining a nerve stimulator, just as long as you look at a solitary endpoint. You don't look for having your needle next to the nerve as well as getting the twitch. You look for the first endpoint, which is either a twitch or your imaging where you have the needle tip in close proximity to the nerve.
Okay.
Sandeep and Shiva, just as a point of discussion, when you combine both neurostimulation and ultrasound, would you rather turn the PNS machine off, put your needle as per the ultrasound guidance in the correct perineural position, and then turn on the PNS to see whether you have the twitch? Or would you have your PNS machine all the time?
It's quite logic to place it where you wanted to place it and then use the stimulation only to confirm. I would do like that only. I will not switch it on from the beginning. I will go to the target near and to confirm it. Then at the deeper level, whether I don't know whether I'm inside, outside, what I am seeing as a white is the nerve or not, I will go to the target and then stimulate and then see, so that I will avoid all the other bias stimulations.
What about you, Sandeep?
What I would do for a brachial plexus is I turn the neurostimulation on at 0.4 and I try to see that there are no nerves which come in the needle path. But for the ultrasound of the lumbar plexus and the sacral plexus or the sciatic, I place it close to the, as Shiva mentioned, the nerve, and then we make it on. So that's what.
All right. Yeah.
So shall we?
Could I just add or rather ask one point here? Sandeep, if you have really gone to the dual modality, how many times have you not got a neurostimulation in spite of actually touching the sciatic nerve very, very visibly?
Yeah, I agree with you.
So many times I haven't got it, and I have finally kept the neurostimulation aside and given it only with ultrasound, even in this situation.
Yes, I agree with you, Shali. So if the needle is in the proper place, and if there are no stimulation, but if you hydrodissect in the just below the membrane, then we can just inject the local anesthetic. You don't have to hunt for the endpoints.
Absolutely, yes. So so it decreases the needle passes.
Yes.
One more point that we seem to have perhaps not dwelled into, especially when Amjad points out the subgluteal, the space as such. I guess there is a nerve there, the posterior cutaneous nerve of the thigh. So could that small little thing that he just spoke, could that be the posterior cutaneous nerve of the thigh, which is very, very close to the sciatic nerve itself here in this situation?
It could be.
Yes.
Shall we move on?
And a small artery and the vein, which is always with the sciatic nerve there.
Yeah, that's on the medial side.
Yes.
That's right. The inferior gluteal artery and vein would lie towards the medial side.
So shall we move on?
Please.
So we were at this point. So now we have injected around 10 ml of local anesthetic at this point. I would like to know whether you would go for a longitudinal view and why.
I personally don't do that, Sandeep. I always go for a longitudinal view after I've finished the entire injection of local anesthetic. And I see it more as a reassuring teaching tool to identify the spread along the sciatic nerve. But midway through my injection, I tend not to go for a longitudinal view. I mean, Amjad, do you do anything different?
No, same thing as you said. At the end of the procedure, you can look to see if your injection is showing any other information. But I would be very stable with my probe at this point, and look at getting more of a circumferential kind of fill at this point, rather than turn the probe around while injecting.
Sandeep, I'm sure you will have a different take on this because I've seen you perform blocks live, even when you did a QL block in SGPGI some time ago when you and I were together in the theater. You tend to always reconfirm with a longitudinal view midway through your injection. Any particular reason? Could you please tell us?
No, Gopal, actually, I just want to confirm after injecting 10 ml with a single needle position without making it move around. I'm not sure whether you really, as Amjad said, you can really fill up the whole of the nerve around it. So what I tend to do is I make it longitudinal and I try to see the small things like if you see here, if you make it more longitudinal, and I hope you must have seen these too. In your video clips. Yes, so can you see a small, the needle tip which is hypoechoic here, and that's the volume of local anesthetic which has filled up this space. Now the small space which is between this sheath and the nerve itself, isn't it? So what I thought was whether it's necessary to pierce this space. If you pierce this sheath and come into this space and inject your local anesthetic, I need to know what exactly happens. And is it really necessary in your clinical practice?
I believe it does make a difference, Sandeep, that there could be the paraneurium and you could be injecting subparaneurally here. If you are opening up that space. And if you continue to inject without any additional resistance, then I'm sure you should not have any issues in terms of nerve injury. And you should have, as Siva said during his presentation on the supraclavicular plexus block, this should reduce the latency and enhance the block onset.
Amjad, your take on this?
Yeah. Now, if you really want to improve the onset as well as the quality of a subgluteal sciatic, you must go into the sheath. But only if if you're able to image this very clearly, and if you're able to guide your needle very precisely and you have the competency to do that, then yes, it's a good idea to actually enter. This is probably the paraneural sheath that you're seeing there. It will definitely enhance the spread, the latency, the quality of the block.
Now, both of you, Gopal and Amjad and Siva also. So at this point, the current was around 0.4 milliamperes. So this is at this point which I injected my local anesthetic. Now we all know that we cannot go below 0.4. So if the needle goes beyond this, would have the current decreased? I mean, would have the contractions would be there with very low currents, less than 0.3?
Hopefully not, because by then, I mean, Siva, go ahead.
Sir, can I share one image? If you stop sharing, then I can share one of the images to highlight these controversies. So I am sharing my screen. Can everybody see this?
Yes, yes.
So now this is the image that from the Raynaud's functional anatomy. If you look at the needle is a 22 gauge nerve stimulating needle, and this is the tibial nerves. And if you look at these are all the fascicles, and if you see the amount of intraneural epineurium, the epineurium is divided into external epineurium and internal epineurium. These are all the fascicles. When you touch them only, you are going to get the motor action potential. Whereas if your needle is within these internal epineurium, you are not going to stimulate anything. So it is well within the nerve, but you will not get any stimulation. If you inject entire local anesthetic, is going to blow out all the fascicles. Yes. This is not intrafascicular, but it is extrafascicular. Yes. Because in the sciatic nerve, such a high amount of internal epineurium is there. So, as
Siva,
Rushalim, yes, sir.
Siva, if I can interrupt.
Yeah.
At the popliteal sciatic level, it is said that
Yes.
the sciatic nerve is 70% connective tissue and 30% neural tissue.
True.
But at subgluteal level, I mean,
It may
does
not
that
be the
still
same.
hold?
Yes, yes.
Yes. No, it still may not be the same. Maybe the amount might vary, but the explanation for I am inside the nerve, but still I am not stimulating, getting the twitch, this could be one of the
So I
mechanisms.
agree with
Even if you,
Gopal. What Gopal mentioned was a quantitative architecture of the sciatic nerve. I think you were referring that article by Moyeri from Netherlands. So he has clearly mentioned about the ratio of the connective tissue between the neural as well as the non-neural in the sciatic nerve, and the same has been depicted, Shiva, in the supraclavicular area too, in the brachial plexus.
yeah, I'll just show that also. Now, this is what the article which you are referring, isn't it, Sir Sandeep, sir?
Yes, yes, yes.
At the cut section, the dark ones are the neural elements. This is at the brachial plexus. All these white substance are connective tissue. So essentially, the brachial plexus elements are going through the jelly kind of substance. So there are so much of connective tissues are there. So if your needle is within these connective tissue, we are not going to stimulate anything, but you are well within the subfacial compartment. So if you look at still more zoom in picture, if this is the median nerve, these jelly substance are connective tissues. If a needle is anywhere here, you will not stimulate it unless you pierce this. And there is a clear point of cleavage where this is the epineurium, this is the connective tissue. If you get your local here, that is the subparaneural compartment, which is the safe or sweet spot.
Can we finish with this thing, because I think we have exceeded time.
Done.
So we'll just finish with this. Shall we just finish with that?
Yeah.
Yes, please.
Okay. Can you see this slide again?
No, not yet, Sandeep.
No, not yet.
Please share your screen. Yes.
So that is where I pierce the sheath, and then I start injecting my local anesthetic, and then now you can see the spread. So it's totally different from what the spread was initially in the paraneural, and this looks like it is below the paraneural sheath. And you can also see the hyperechoic needle, which is very close to the sciatic nerve. So is this fine, or I shouldn't have done this?
Fine. This is a master class.
Yeah, that's absolutely fine.
Amjad, your comments on this?
Yeah, I think the fill that you showed, the second part, when you have crossed the sheath and you've injected it, it looks beautiful, doesn't it? It's traveling along the entire length of the sciatic nerve, and as you trace forward. So this is a more reassuring fill. And definitely when you see these sort of fills, you know that your block is pretty much going to work.
Yeah.
And if you see the previous fill, you see the previous fill, there's a lot of spillover in areas that aren't in contact with the nerve. So in the second fill, it's much more reassuring.
Okay. So now I just wanted to know from you, does it make sense to go from a transverse to the longitudinal view halfway to injecting the volume of local anesthetic?
Okay, so if you're in a cross-sectional view and you feel that this sort of fill is happening, you will see that when you're injecting in a cross-sectional view, a transverse view, that every aliquot that you inject, after a while you see that the fill regresses. This is the phenomenon that you have just depicted in the longitudinal view. So again, it's how you look at it. If you want to turn over, I don't see a harm in turning over. It's just the preference. But I don't see if it offers any specific benefit apart from looking at the nerve in a different angle.
Gopal, your concluding comments?
Sandeep, just one small point. What you showed is one of the classic background scenarios for a sciatic catheter insertion, the longitudinal view and the hydrodissection that you just caused. So I guess I would always go for a longitudinal view while I'm placing a catheter.
I agree with you, Rushali, that for catheter placements, I use a longitudinal view. Gopal, your concluding comments?
Yes, Sandeep. So when I do a subgluteal sciatic, I definitely try to place the patient in lateral position. I start by identifying the greater trochanter, and then I swing my probe towards the ischial tuberosity. And at some point, I'll have both the bony landmarks in view, and then it becomes much easier to identify the structures, the gluteus maximus, the sciatic nerve, which oftentimes does not lie exactly at the midpoint between the greater trochanter and the ischial tuberosity. It is closer to the ischial tuberosity. And the third thing I always try to look for is the pulsation of the inferior gluteal artery, which lies on the medial aspect of the sciatic nerve. And then I tend to do what you just did, inject by placing the needle in plane with the ultrasound bead from lateral to medial direction. And most often for subgluteal sciatic, if I have a fairly thin patient, I tend not to use nerve stimulation. But when I have a big patient, I do tend to combine. And as we discussed, I keep the nerve stimulator off. And when I know that the needle is in the correct perineural position with ultrasound, then I turn my PNS machine on. I go up to 0.6, and Rushari rightly said there are times when even with the needle abutting the nerve, as you see on ultrasound, you do not get a twitch, and we continue to go ahead and inject. So that is one. And I do not actually change to longitudinal plane midway during my block. I inject the entire local anesthetic with the short axis view. And then after I finish that, I try to do a long axis scan.
Thank you, Dr. Gopal, Dr. Shiva Shanmugam, and Dr. Amjad Manier. Now, what I do is we have our first lecture of day 2, Dr. Malti Panchwag on continuous spinal. And after this, Dr. Amjad is going to comment on the and give his insights and inputs. I also welcome Dr. Ganesh. Dr. Ganesh, are you here on the screen?
So, yes, sir, I'm here.
Okay, fine. So he's going to moderate the session. Dr. Ganesh Bohm is a consultant anesthesiologist from our hospital.
Okay. Thank you, Diwan sir. Good morning. Good morning, everybody. The continuous spinal anesthesia is an underutilized anesthetic technique, and origin of this technique can be backtraced to 1907, which is described by a British surgeon Dean. So I'm sure very few of us are practicing this technique, and Dr. Panchwag is one of these few anesthesiologists practicing it. So I request Madam to enlighten us about this technique. Over to you, Madam.
Good morning, everybody. So, welcome to all of you, bright and early on this Sunday morning, to this webinar from Prague. And let's start off this Sunday with this topic on continuous spinal anesthesia. One of the greatest challenges of a single dose spinal anesthetic is ability to control the spread and to block the segments that are necessary for surgery and avoid those segments that are not necessary for surgery. All this while giving the right amount of dose which prevents hypotension and gives greater hemodynamic stability to the patient. And if the surgery should get prolonged, to prolong the duration of the spinal anesthetic as well. But a single dose has the major problem of not accounting for interpatient variability, and therefore you find varying effects of similar volumes or similar doses of drug in different patients. If you consider all these different patient profiles, they're all elderly with multiple comorbidities coming for either neck femur fractures which have high perioperative mortality rates, or for prostate surgery, lower abdominal pelvic surgeries with varying durations. It becomes clear that having a technique that is versatile enough to cater to any of these surgeries, at the same time providing hemodynamic stability, is a very attractive technique. Similarly, if you have a young patient with comorbid conditions like maybe a cardiac disease or other respiratory diseases or muscular dystrophy or something like that, who comes for emergency or planned surgery where you are not very comfortable using other regional anesthetic techniques, or you don't want to give general anesthesia, then after considering multiple points, one would decide on what techniques to use, and most of us would tend to gravitate towards using either an epidural technique or a single dose spinal anesthetic technique. But the problem with a continuous epidural technique is that the muscle relaxation is not that good, and a single dose spinal anesthetic technique is what it is. You cannot prolong the effect. You cannot change the effect once you have the drug has gone into the patient's body, and it's very difficult to control. So there are multiple roads which lead to a safe patient, and a continuous spinal anesthetic is one such extremely attractive technique which addresses the problems that are there with a continuous epidural. So it gives excellent muscle relaxation even to the very end, and it can be prolonged for as long as is necessary. Where there are multiple factors that affect spinal blockade, at least 20 of them, the most important are the varicity of the drug that are used and the volume that is injected. And in the elderly, there are multiple problems along with comorbid conditions because of their unique changes that happen within the neuraxial system as they age. You will realize that smaller doses of drugs are necessary to get the same kind of effect. But when you use a single dose catheter, it's very difficult to titrate and to assess. And if you do not have adequate experience, or even inexperienced people, you can have different effects for the same volume. One of the most important things that determines the block height in the elderly is the varicity of the drug that is used. We know that isobaric and hyperbaric both are available, and the beauty of isobaric medication is that the effect of age is only very marginal on these drugs, so you can still have a greater predictability of the effect when you use isobaric as compared to hyperbaric. And because the elderly nerves and the spinal cord are more sensitive, using hyperbaric gives a higher sensory block, a quicker onset of motor block, and more hemodynamic consequences. So to decrease the hemodynamic consequences, if we go down on the volume that we inject, there are certain problems that can be associated. Most important of all is that you might have complete failure of action, or you might have a good sensory level but no to poor motor action. And if you do get a good block, it's likely to be of a short duration of time. So if you tend to increase the volume that you use, you can have adverse outcomes. There are multiple papers, huge studies, more than 10,000 patients in each study. Systematic reviews have been conducted, all to show that perioperative and intraoperative hypotension can lead to adverse postoperative outcomes, increased 5-day and 30-day mortality in these patients. And if you prevent hypotension or decrease the duration of hypotension or decrease the degree of hypotension, you can still have better postoperative results and prevent organ injury. This is a paper from Israel where they studied 20 patients, 10 in each group. One received only 4 milligram of bupivacaine and the other receiving 10 milligram of bupivacaine. Both were for fracture neck femur patients, and they found that 4 milligram was a good enough dose. The ASAP2 study from UK made this cutoff of 1.5 ml for a positive correlation to or hypotension. But it's very difficult to give either 4 milligram or 1.5 ml and expect that everything is going to work out fine. Your backside is on fire till the case gets over, and you're not even sure how the case would go. The greatest attractive feature of the continuous spinal anesthetic is that you can start off with very small doses, give exactly what is required for the surgery. These titratable doses have predictable action, and you can prolong it for as long as is necessary. And this gives excellent hemodynamic stability intraoperatively and excellent muscle relaxation. So in whom do we use the continuous spinal anesthetic? Especially in sick elderly patients, people who are morbidly obese, in whom it's difficult to assess what volume to inject, in patients who have had previous spinal surgery where the effect may not be that predictable, Laparotomies where GA may be less preferable when you want postoperative analgesia, or obstetric patients who have cardiac disease, or younger patients who have other comorbid conditions. And there are multiple ways in which the continuous spinal anesthetic can be given is when you have an unintentional dural puncture and you have converted the epidural anesthetic into a spinal anesthetic. It's certainly a very good way to start if you don't have the requisite sets available to you at that moment. But intentional continuous spinal anesthesia can be with either microbore or microbore catheters. It's not anything new. Till the early part of the 1980s, huge size catheters, 18 gauge and 20 gauge catheters were used, and needless to say, they had higher incidence of PDPH. Nearly 1 in 3 patients had PDPH. In 1991, there were reports with microbore catheters of 14 cases of Cauda equina syndrome, because of which the US FDA banned all the microcatheters, that is, catheters of the size of 25 gauge and above. But an analysis of all those cases came to show that the lidocaine may have been the cause, primarily because when microbore catheters were used, higher pressures of injection needed to be given, and there was maldistribution of local anesthetic and pooling of the local anesthetic around the nerve roots, and lidocaine itself has about 7 times more proclivity to be neurotoxic as compared to bupivacaine and other drugs. So there have been changes that have been made in the technology and the technique that is used. The Quincke needles are replaced by Sprott. The end holes in the intrathecal catheters are replaced by side holes. The catheters are placed in the cephalad direction rather than towards the caudal direction. Less than 5 centimeters threaded in situ, preferably only 2 to 3 centimeters. Lidocaine is no longer used. And we are all better aware of the complications and we monitor better. So the advantages, like we just enumerated, are that you are able to titrate and you can give excellent hemodynamic stability, and it is more predictable, and you can prolong it for as long as you want. The main disadvantages of using continuous spinal are the post-dural puncture headache. If you use it in younger patient and if you use bigger bore catheters, you tend to have higher incidence of PDPH, whereas the more elderly your patients are, and if you sort of use 24, 25 gauge catheters, the incidence of PDPH is nearly not there. It can be technically difficult to introduce, especially depending on the kind of sets that you're going to use and your own level of experience, because of which there can be a failure to insert, or if you have not fixed it well, then there can be a failure of action intraoperatively, and you might need to resort to giving an alternative anesthetic technique, perhaps a GA. Infection is not as common as with epidurals. Neurologic symptoms are also no longer seen because primarily lidocaine is not used, and the catheter size that we use is bigger than what was implicated in 1991. There are different sets that are available. Let's see, this is the Wiley system, where the catheter is threaded over the needle. The epidural space is first identified, the spinal goes in through the epidural needle, and the catheter is threaded over this. It's not as simple. People who have used it have called it a nightmare to use. B. Brown is another company which has the SpinoCath, which is similar to the Wiley system. Again, this is catheter over the needle. Both of them have higher technical failures. Payung is a catheter through the needle, and this is very easy to use. This is much like what we use for the CVP line. We'll show you a video of how we use it. This is the set that is there, and this is what we lay this out on the tray at the beginning so that everything is very clear. This is the Sprott needle, and you can see that this is a pencil tip 22 gauge needle through which a 25 gauge catheter is introduced. It has an inclined ramp at the edge so that the catheter comes out very gently from the opening. I think there seems to be a lag in the audio. Anyway, we fill up the bupivacaine or whatever drug we intend to use in tuberculin syringes or 1 cc syringes. And that's the cassette that comes with the set, which contains the catheter, and the guide wire is present within the catheter. The guide wire cannot be removed and the catheter cannot be flushed prior. So we just have to lay it out and keep it before we start the procedure. Because the Sprott needle is a blunt needle, it comes with a small scalpel to make a puncture in the skin to ease the introduction of the needle. So typically what I do is I give a local anesthetic, use the scalpel, and then introduce the spinal needle. Now this is a connector that is attached to the catheter. We'll see how this is used in the end. So this is the Sprott needle. This is a patient in whom we had a technical failure. The CSF was easily identified, the intrathecal space, but in the midline we had difficulty in introducing the catheter. And this can happen in many studies have said about 6% of patients in whom we try that you might identify the intrathecal space, but you may have difficulty in threading. So what you can do is then change the level, withdraw the needle a little bit or advance the needle a little bit depending on where you are. Continue to get good CSF flow and try and reintroduce the catheter. One very important thing not to do is don't withdraw the catheter through the needle. The needle and catheter assembly have to be withdrawn together. So this is the same patient in whom we did a paramedian approach. Sure enough, we got the intrathecal space identified quite easily. And this time it was more easy to insert the intrathecal catheter. What I have found is that paramedian approaches give a better success rate for catheter insertion. And truthfully speaking, I have used paramedian approach almost exclusively for the last 20 odd years for every anesthetic of mine, neuraxial anesthetic of mine, be it epidural or spinal. I'm very comfortable with it. And I tend to be more prejudiced towards using paramedian approach. And the catheter walked in quite easily in this patient. So this video is just to show that not every case needs to be technically difficult, which I showed just now. This is how the catheter typically walks in. It's very easy to introduce, and at the end of introduction, you can measure the depth of the space. You can measure how much of your catheter is inside. All of these are graduations, and it's very easy to measure all this. Once your catheter is in the intrathecal space, you remove the guide wire from the cassette and check for that reassuring drop of CSF that trickles at the end of your catheter. You see it quite often, but it's possible that if the CSF volume or pressure is very low in very elderly patients, you might not get this drop of catheter. There are different ways in which to fix it. One way is to use this fix-it or lock-it device that is available with the Portex epidural. And I use this for fixing. This gives me a little more reassurance that it's not likely to migrate, but paying attention and spending a little time in catheter fixation goes a long way in ensuring success intraoperatively. This is an alternative method of fixing. Especially if you're using midline approach, this tends to kink. And once you have positioned the patient, you might need to go back and check so that there is no kink seen. So this is a video to show how the catheter can be removed. Again, Sometimes there may be difficulty in removing the catheter. Flexing the hips and the knees to open up the spine actually helps if you have difficulty. Don't yank and pull on the catheter. Catheter breakage can occur. Especially the 25 gauge and the smaller bore catheters have poor tensile strength. And look for the tip, which should be intact. So this is a video to show that the holes are at the side of the catheters these days, and it's not an end hole catheter. This shows that these catheters are quite distensible before they break. So don't keep on pulling, though they do give you and they forgive you for doing that. But if there is catheter breakage, you'll probably have to do surgery to get it out. Typically, we tend to use the spinal anesthetic at the level of the lumbar spine. But there has been a paper which was published in March 2020 in Minerva, an Italian journal, about thoracic continuous spinal being used. This is Dr. Sternari who used it in a place called Ancona. And they have been doing this for abdominal surgeries for many years now. And they just recently decided to publish their results. The setup in which they work has no ICU backup. And so they have come up with this, that even for laparotomies, they don't use general anesthesia. And they have found very few complications by using continuous thoracic spinal anesthetic. Typically, so this particular paper was a retrospective analysis of 90 patients who underwent major abdominal surgery. Level of insertion was between T6-7 and T10-11. And bupivacaine with fentanyl were used as the doses. They found that out of 90, only one case required general anesthetic, and no direct complications were reported, though hospital mortality was about 5.6%. So we have all seen how to go about giving a continuous spinal, but there are certain things that you should not do. First of all is do not withdraw the catheter through the needle shaft, because you may damage the catheter, you may cause catheter breakage, and you'll end up in greater problem. Do not insert the catheter more than 2 centimeters inside, certainly less than 5 centimeters, but preferably not more than 2 to 3 centimeters. And if you need to keep on giving doses, you must think that your catheter may not be in place, and you might need to stop and reassess and see if you have to reinsert the catheter. Insert the catheter at the midpoint of the dermatomes that you want covered, so that you don't need to use too high doses to get either a caudal level or a capillite level, and try to. So all this is to restrict the volume and the dose of the drugs that we use. Do not exceed a maximum recommended dose of anesthetic. Typically, we advise not more than 3 or 4 ml in about a 4-hour fiber period. What we have used typically are 0.8 to 1.2 ml as the first loading dose, and after that our boluses which are needed for increment, which we use incrementally, are 0.5 ml, and most of our surgeries get over at 2.2 or 2.5 ml dosages. So how you can start is, if you have an unintentional dural puncture while trying to place an epidural catheter, convert that into a continuous spinal, put it into the intrathecal space. If life has given you lemons, convert it into lemonade and try and give the best possible anesthetic to the patient, and you will yourself realize that it's wonderful. This also may have the advantage of decreasing the incidence of PDPH. If you keep the catheter in situ for about 24 hours, go ahead and give it a try, and do come back and let us know how you have fared. And I think Dr. Amjad Maniar will give his concluding comments, and then we'll have the question answer session. Thank you. Good morning, everybody.
Dr. Amjad, your comments, please.
Yeah, thank you, Dr. Malti, for showing your deep insight onto this topic. Continuous spinal is something like what I always say, the dark arts of regional anesthesia. Not too many people do it. You raised some important, little tips over there, and I just want to add some comments. The main reason why one should do a continuous spinal anesthetic is for the hemodynamic stability that it provides. Phenomenal, the kind of stability that is provided by a continuous spinal. Another major point is that the catheter needs to be micro-dosed. You mentioned that you start off with about zero 0.8 to 1.2 ml. In very unstable patients, you can even drop that down to about 0.5 ml boluses and evaluate the stability and then progressively give subsequent doses.
Can I say one thing, Amjad, here? That the dead space of the filter and the catheter itself together is about 0.5. So if you give just the 0.5 initially, it tends to remain within the catheter.
Yeah, so that was my next point. What is the dead space of the filter and the catheter? Can you tell us for that particular set that you use?
Yeah, it's about 0.5.
Yeah, it's usually most of the sets you see it's somewhere around 0.3 to 0.5. So you have to overcome the dead space and then deliver that 0.5. So if it's 0.5 mils dead space, you need to give 0.5 plus 0.5, and then you're probably starting to be within the delivering the dose into the intrathecal space. Do you use it on younger patients? Have you ever used it on younger patients?
No, I have never used it because we tend to favor general anesthetic or other techniques when we use it because we want to avoid the PDPH. And I have only used it in 60 years and above.
Yeah, so that's another major point. We tend to use this only in people who are elderly and high risk. This is not something you should use every day in your practice for your regular, say, an ACL repair or something like that. Try to avoid it because the incidence of PDPH is quite high. I think it goes as high as 25% if you use it in the susceptible population. About the choice of local anesthetic. When continuous spinal ran into that major episode in 1991, the incriminated drug was lignocaine, and it was also the hyperbaric solutions that caused a problem. The reason being that because these catheters are really small, the rate of flow when it comes out of the orifice at the end is very slow. And if you use hyperbaric solutions and this catheter is wedged into the nerve roots or in the Cauda equina, the drug could constantly trickle onto the nerve roots and cause what was the Cauda equina pandemic, if you might say, if it comes to the catheters. So again, it's very important that you use either an isobaric solution or a hypobaric solution. In India, I think the only isobaric solution that is available is the chlorprocaine. And what we get, the bupivacaine, the normal bupivacaine without the dextrose, has a baricity of about 0.99. So it is actually hypobaric. If you want to make it isobaric, one method would be to add normal saline to it, which will push the baricity to about 1.004, which is close to the 1.006 of CSF. So then again, it's more convenient to use either a ropivacaine that is available, which is preservative free, or the bupivacaine that we normally use for nerve blocks. Again, the important thing here being the non-preservative solutions. Do you remove the catheter immediately after the surgery or do you leave it there?
Almost always. On two occasions where the patient was extremely finicky and very, very afraid of pain, on two occasions we left it for about 12 hours, but I had her under my observation in the recovery room, never sent the catheter to the ward.
Yeah, that's something that even I'm very, very worried about. I use the catheter only for intra-op surgery. Post-op, you can do a whole lot of different things. You can give a nerve block or something like that and get rid of the catheter. Though people have described the use of it for a post-operative analgesia regimen, I tend to not do it because any inadvertent injection there could be absolutely devastating.
one more thing, there was one case report of an inadvertent, very high spinal that developed when they flushed the catheter in the recovery room. So the catheter had the anesthetic in place at the end of surgery, and that was not flushed. And when the patient was shifted to the recovery room, I think they wanted to give an analgesic, and before removing the catheter, they wanted to just flush it and remove it. And the entire surgery went uneventfully, but postoperatively, the patient had severe hypotension because almost 0.5 went in, and they were least expecting it at that time. So you have to be very careful about these things.
So the question I will ask you is, should we be flushing these catheters?
So I don't. So which is why when I said that my initial volume is 0.8, this 0.8 includes the 0.5 dead space. That means what actually goes in intrathecally is 0.3. And I might increase that in increments, maybe 0.2, 0.5. And so the doses that we talk about are the doses that you're injecting, but you should always remember that 0.5 remains within the catheter system.
I think we should be careful about not flushing these catheters. And if they do get blocked, I think you should just go ahead and take it out sometimes. It usually will not get blocked unless it gets kinked. Because they're very fine, they may get kinked. So like you said, you have to meticulously tape these catheters at the back. And if you remove it by the end of the surgery, I don't think you should have too many issues about the catheter getting blocked. Have you ever...
Amjad, we are running short of time. Can you just conclude with your last statement?
Yeah, okay. So pretty much that's it. I think there was an elaborate talk about this. This is something that all of us should study. Putting the continuous spinal is actually an intentional act, though you might do it when you have an inadvertent puncture. But it's something that all of you should explore and see if you could bring it into your practice using the correct catheters.
Yeah. Both of you, thank you very much. But I just wanted to ask you one single question. Do you exclude difficult neuroaxial techniques with X-ray prior to incorporating this block, particularly in geriatric patients?
I have used ultrasound on occasion to identify which space I could use, but X-rays are generally there. Sometimes, with the hip, the lower part of the spine is also available. And since I never generally go above L2, a part of the spine is also seen. So I don't take a special X-ray separately to examine the spine, but I use a neuraxial ultrasound to check.
For example, in this kind of patient, would it be possible like?
The continuous spinal itself is a difficult technique.
Yeah.
Having an extremely difficult spine and a difficult technique could lead to probable difficulty, but depending again on comorbidities and the level of experience that you have, you may try it, certainly, why not?
Amjad, your views?
Yeah, if it's a difficult spine, and we are commonly using this in the elderly, so you are going to encounter the difficult spine commonly. You can use ultrasound. We don't usually use fluoroscopy, definitely, probably not on the spine that you're showing us right now. It looks quite difficult here, probably not.
No, because I failed in these two occasions, I failed with a routine spinal to even the 23 gauge. So would it be mandatory to perform a normal X-ray AP and lateral view before you implement this technique? Is just one just the question.
Not really. I've never used a radiograph as my reasoning for doing a spinal. I think clinically we can probably make out something whether it's going to be difficult or not. Otherwise, use an ultrasound, which is a lot more quicker.
Okay. Thank you very much, both Dr. Malti and Dr. Amjad. Dr. Malti, I just failed to introduce you before the start of this lecture. She is a senior consultant anesthesiologist in Lokmanya Hospital, Pune. She is a speaker at national and several international conferences, a DNB teacher since 2006, and she has special interests in regional anesthesia and neuroanesthesia as well. So thank you very much, both of you. You have to be here till the end of the our conference. Shall we move ahead?
Yeah.
So I see Dr. Bala Venkat. Hi, Bala.
Hi, good morning.
Yeah.
Good morning, Sandeep.
Yes. So we move ahead with the panel discussion very urgently. I just want to start with the panel. This is the prac panel, and this is the prac panel. So we have our expert panelists. Nayana? Are you able to see the screen or no? Are you able to see the screen, Dr. Bala?
Yes, yes, Sandeep. Now I can see. Yeah.
Dr. Shiva and Dr. Amjad, Dr. Abhijit, and all the moderators, Dr. Javed, Ritesh, and Harshal. You can also comment whenever you would like to. So the first case is a post-epidural respiratory arrest after a first bolus. She is a female with undergoing a complex total lip under epidural at the level of L1 and 2. The initial bolus was 8 ml of 0.5% bupivacaine. She was stable. The top up at 1.5 hours. The first bolus was 5 ml of 1.5% xalocaine and 0.5% bupivacaine. And 10 to 12 minutes later, the saturation dropped from 98 to 72. She became apneic, mask ventilated, intubated and ventilated. The cords were totally paralyzed. There was no hypotension. ECG pattern was normal, and the pupils were reacting to light. What would have gone wrong? Dr. Bala, Dr. Gopal.
Yeah. So first, Gopal, you want to go ahead?
Yeah. See, the first bolus after the epidural was placed was fine. The patient was stable up to the bolus that took place about 1.5 hours later. So it's quite likely that there is a migration of the catheter into the subarachnoid space. And the subsequent bolus of 5 mils of 1.5% lignocaine mixed with 0.5% bupivacaine went all the way up, and it probably caused a total spinal. Bala, would you differ with that, or?
No, I think the first foremost way you think is like this. But I also wanted to, especially in geriatric age group, this is a 60-year-old female. One of the points which I would wanted to add is the strength of the respiratory muscles. It's a good idea, because we do a lot of these geriatric cases where it's a good idea to see the respiratory efforts and muscles. So not only for general anesthesia, even for regional, a breath holding time and cervical myelopathy, which is present in plenty of them, which is going unnoticed. The reason I'm speaking about it is, if the muscles get compromised even a bit, if they are younger patients with good respiratory efforts, they tolerate this and they do not produce the apnea that happens. So this is one more additional point I would probably try to bring in, which would be of very great relevance for all the youngsters who are doing a pre-anesthetic assessment of a patient in whom you're planning to do a procedure like this. Just an additional point. But I think what you're saying is important. And my point is just to say that always the efforts of the breath holding time and the hand grip to see if there is a pre-existing cervical myelopathy in Indian population is very important.
Very right, Bob. But I based my opinion that it was probably a subarachnoid migration of the catheter, because Sandeep said that at the time of intubation, the cords were absolutely relaxed. So I assume that the patient did not require any sort of muscle relaxation. Is that right, Sandeep?
Yes, correct.
Yeah, so that clearly states that this was a total spinal.
Total spinal, yeah.
The drug went right up to the brainstem.
True.
Any other comments from?
Yeah, what it looks a lot like intrathecal spread of the drug, because 8 ml is where you're very unlikely to cause a total neuraxial blockade with 8 ml. But what's interesting to notice, you mentioned that there has been no hypotension with that sort of a dosage in the intrathecal space. But yes, relaxation of the vocal cords is probably likely to be a spinal anesthetic here.
So do you still believe that you get a total spinal after 10 to 12 minutes, because that's the lifetime after injection?
So can I ask one question?
Just wait 1 minute.
Sir.
Harshal.
Yeah, I understand. I mean, these are all the unanswered area. I mean, but I wanted to propose another mechanism which we all should aware, the mechanism of respiratory arrest following the epidural anesthesia. Sandeep sir, if I just wanted to share one of the article from my screen, can you just, is it okay? Shall I share now?
Yeah.
So I'm just sharing from the desktop. So can you see my screen?
You need to take it up. Full screen.
Yeah, can you see now?
Yeah.
So now this article clearly talks about hypoxia causes apnea during epidural anesthesia in rabbits that exactly fit your case. What exactly this is done is, if you look at under two graphs that I wanted to show, if you look at under epidural anesthesia when apnea happens, this is before epidural. Sorry. Can you see the screen now?
Yeah. Yes. But we don't see the graph. Yeah, now we can see.
Yeah, I just 1 minute. I will just minimize this. Yeah. Now I will zoom in. Can you see it now?
Yes, yes.
This is before epidural anesthesia. If you look at, these are all in the rabbits. They have done an epidural and they have produced an hypoxia. If you look at an FiO2 curve, they have stopped oxygen supply for about 40 seconds. Without an epidural anesthesia, if you look at the tidal volume increases because hypoxia stimulates the respiratory center, and then the tidal volume increases. Towards the end of 40 seconds only, there is a drop in heart rate. It becomes bradycardia. Whereas during the hypoxia time, there is an increased ventilatory response in the shape of increasing in tidal volume, and the BPS went up. Only towards the end of the hypoxia, there is a bradycardia. This is what is the normal response without a central neuraxial blockade. So after that, what they did, they given epidural anesthesia to these rabbits exactly at lumbothoracal. I mean, that is at L1, L2 level. Yeah. If you look at it, during the hypoxia, there is no increase in the ventilation. Suddenly there is apnea without any tachycardia or tachypnea. There is a sudden apnea. So there are various mechanisms they proposed. What they finally told is hypoxia and hypotension following your second epidural dose. Suppose if the patient is nicely sedated and your top up, if it reduces the BP little less, that will produce a CNS hypoxia. That can produce, instead of stimulating the respiratory system, without any response, patient can go into sudden apnea. This is one of the well-proposed mechanism for unexplained cardiac arrest under central neuraxial blockade, especially under sedation. So this I wanted to propose. You can just think about this in this particular case.
Yeah.
Sandeep, can I add to this?
Yes, please.
See, one of the mechanism is, as you had mentioned, hypoxia. And I also wanted the initial thing which I suggested about seeing the respiratory muscle is also related to this. Even a small decrease in the motor activity results in hypoxia, number one. And number two, hypercarpia as a cause of apnea, which we have seen again in the geriatric age group. With a second bolus, suddenly the respiratory muscle weakness, and it typically happens like this 10 to 12 minutes later. And it is when you see the PCO2, it's very high. It's retention of carbon dioxide, also producing an apnea, to be considered this additional point.
Yes.
So, I just wanted to ask you about this examination of cervical myelopathy. Do you do it in all the patients? The strength of
You see, because actually, if you see the musculoskeletal problems, especially the patients who come with total hip replacements and knee replacements, majority of them have degeneration of the spine too. And most of them have issues with spine. So in this specific group, I think it's a great idea to see this.
And what about the GPS analysis? Do you do it in all the patients?
Yeah, all the patients coming for as I said, degenerative, you have to do it, and hand grip and breath holding time, an additional feature that you would see in your pre-op assessment.
Okay, Shiva, your point is very well taken about the unexplained cardiac arrest in this patient. Probably in this patient, it was not an arrest; it was a hypotension.
Yes, it is a respiratory arrest. Yeah.
Yeah. So, anything else to be added here? So you
Can I ask one question?
Yes, please.
Was this patient sedated, Sandeep?
No. None of my patients are sedated.
Okay.
Yeah.
Sorry, this may not be exactly fitting in the pattern, but is there a small possibility that it might be inadvertent subdural spread? Because the amount of local anesthetic, if it is an inadvertent subdural spread, the amount of local anesthetic required sometimes is lesser, and the neurological signs take a little time to come. Is that something which we should be thinking at the back of our head? It may not fit exactly in this case, but
so what made you, Harshal? What made you think that it could be a subdural?
So, I mean, we have had maybe just one-off case where in a labor analgesia where we were putting an epidural, and this was in the UK, and very small amount of local anesthetic caused a similar sort of neurological thing, and much later after the bolus was given. So it did not fit into the picture of a direct spinal migration, because the effect would have been straight away, and the volume was far less to cause larger epidural complications in terms of a spread that way. So it didn't fit into the picture of either a spinal or a big bolus of an epidural. So the epidural injection was much smaller. So then the question came on whether it could be a subdural spread where it fits into a delayed action of a neurological symptom for a much smaller volume. So
what did you do with the catheter then? Did you remove it, or what did you do then?
We removed it. It was very long ago. Yeah, but we removed the catheter.
Okay, you should have done a contrast study at that point of time.
Yeah, we have done a contrast.
Time,
the subdural placement of catheters is definitely existing, where it will not look like a spinal, it will not look like an epidural, but it in between the two. In the sense, with a less volume, you will get an unpredictable higher spread. When we did it, we found even with 3 ml, there was a spread up to T2, T3 level in an elderly patients. When you're doing it for thoracotomy. So those times we used it very meticulously and removed at the end. So subdural placement is a fact, but it will happen at the first time itself. But I have not seen as a migraine component.
Sir, can I add something?
Yes,
can I say something, Shiva?
Yes, sir.
When you do a subdural, I mean, when you have a subdural catheter placement, would you not also have a patchy block?
Yeah, true. When it has become very, very segmental, when we put it for a thoracic level in that particular lady, even with 3 ml, the sensory block was extending from T2 to T10 with just 3 ml of local anesthetic. We were wondering how this is possible. But we maintained the catheter even in the post-op to clearly assess them. Even with 2 ml, she had got a complete pain relief. And when we shifted her back to the cath lab and injected and seen the spread was the tram track appearance was from the T2 to T10, even with a small volume. So that is how we confirmed that it is an subdural placement.
So it's a catheter migration, you mean?
Well, that is the first time itself it was like that. Fortunately, we did it awake and we confirmed that it is like a subdural placement. So we utilized only 2 to 3 ml local anesthetic throughout the procedure.
You wanted to say something?
Yeah, sir. Basically, if you are seeing by your case history, sir, we got the respiratory arrest after 10 to 12 minutes.
Yes.
So you have given a 5 ml bolus.
Yes.
So if it would have been an intrathecal, why you are having that respiratory arrest after 10 to 12 minutes?
Yes. That's the question.
Sir, basically, what Harshal was telling, it might be a subdural.
Yeah.
Because you cannot have that respiratory arrest after 10-12 minutes if it's an intrathecal migration of the catheter.
Yes, yes, that's what we are trying to sort this thing out, Ritesh. Thanks for your comments.
Right,
now, doing the
Sandeep, was an ABG done at this time?
no, Bala, I was all alone. This was when I was in Miraj, so it was not possible to do all these things.
And the first 8 ml, one more question, the first 8 ml that you gave, in which position was it given?
So this was in sitting position, Bala.
Okay, and then, so the first 8 ml bolus was given in sitting position?
Yes, no, the first bolus in the lateral position. When the patient was during the surgery, the first bolus was given. Now, my question is, do all of you, give a test dose, administer a test dose before giving the first bolus? Do you still do that?
Yes.
Okay, and is it pertinent enough?
I actually don't give any more intermittent boluses. I start an infusion.
Yeah.
I mean, that I think is what all of us would do at this point of time. So once we give the initial bolus, we start off an infusion.
Dr. PBS, one small question. When you start the infusion, do you start immediately or 30 to 60 minutes later after seeing 2-segment regression?
I wait for 60 minutes before I start the infusion, and maybe even longer if we do a CSC, which is the usual protocol these days. But let's get back to this particular case.
So the reason is, the reason is only just to, because you said it's an infusion, just as a take-home message for them not to start immediately, to see that the level has worn off, and then,
Absolutely. That I agree.
Sandeep,
But in this case, Sandeep, I think it makes sense to aspirate before you inject.
Yes. So that's what my question is, Gopal. When you start an infusion pump at 60 minutes, do you still perform a test dose and then attach the infusion pump?
No, I don't.
Because
I generally start the infusion at, say, 4 to 6 mils per hour of 0.25% bupivacaine. And if there is a precipitous drop in blood pressure, or if the patient starts to have breathing difficulty, I have ample time to detect it and address it.
Sandeep sir, just one small point. Azam here. If you go back to that case, what you had mentioned, you said there was no hypotension at whatsoever, no hypotension, ECG pattern normal. If it had to be intrathecal, at least there should be a little bit of drop in the blood pressure, I feel. That's in my opinion.
Right. Sandeep, can I just add one more point?
Yes, please.
What stage was the surgery on when this was done, and whether any cement was used?
The cement was not used. So this was an uncemented bipolar. And
no, I'm just thinking whether this respiratory arrest could be completely different from the neuraxial, the technique itself, because we also know that bone marrow implantation syndrome which happens, which can also produce an apnea and respiratory arrest.
So this was a top-up just before he wanted to introduce the prosthesis in. He wanted some relaxation. It was during that time.
So which means, what I'm trying to tell is whether the respiratory apnea had nothing to do with the epidural itself, and it could have just been because of the drilling that they do in the acetabulum and the femur side before your particular stage had come, whether that could itself had produced a hypoxia and a respiratory arrest?
So that's why you wanted me to, you need to know the blood gas. Whether I did it.
No, just I'm putting the other point that could have caused this.
Yeah. So we have a
if you see in the context of COVID, 72% is something a lot of people live with. There is happy hypoxia. So
no, that is only if you are fortunate to have COVID. But otherwise, hypoxic become you have apnea even before. So some advantages of COVID.
I have a couple of points here.
Yes, please.
Yeah, Dr. Malti.
So the first thing is that hypoxia, many of us can actually tolerate quite a bit of hypoxia if we are already hypoxic, in the sense that when you go for, this chronic accommodation that occurs when you go up in altitude, even over a period of 2 to 3 days, you can still tolerate even 80-85% hypoxia without actually becoming breathless. So in patients who already have pre-existing diseases, probably other comorbid conditions where saturations are already low, a drop in 5% may not manifest too much in them. Second thing is, if we were thinking in terms of pulmonary embolism because of cementing, should the hypotension not be more evident first?
Madam, not necessarily. If you see the grading of how it happens, and here the cement was not used. So this is not related to the cement. It is just because of the increase in the pressure in the medullary region, which pushes the fat globules inside. And this can present purely with ventilation perfusion mismatch without producing the hemodynamic changes. So it is just the ventilation perfusion mismatch which happens.
Okay. So Bala, we have just 5 minutes left. We can just run through this. You know all the tests to confirm the epidural catheter tip in position. Now, this is one of the patients in whom I had a total spinal. I kept the catheter in place and I did a contrast study. You could see the contrast study. This is not this patient actually. I just want you to differentiate between what happens when you inject contrast in a total spinal. It goes right up to the lowest part of the spinal column. But when I did these cases, I had 2 cases in fact. Now you can see what has been mentioned in the literature as well as in by Harshal and by Dr. Shiva. So this is the contrast. I mean, at the level of L3, L4, and the level of L1, L2. The catheter tip is positioned, and the contrast, you see a very thin streak, and then you still see that it bubbles and it gets dilated over here, and then it goes very high up, right into the cervical area. So this was as according to the radiologist, I confirmed with the radiologist, a thin stream like that, a very like what happens here is this is in the subdural space. This is not in the epidural space, neither it is in the intrathecal space. You have seen it earlier. So this was a classical subdural placement of the catheter, and it might have migrated. I don't know when did it migrate, because the first bolus of 8 ml was good enough, but probably during introduction of the catheter, it must have gone into the subdural space, or maybe when we position the patient, because the patients are thin and fragile, we don't know about the quality of the membranes which surround the dura. So this is a possibility. So this was a classical subdural placement of the catheter. Here you can see the contrast in the lateral view, the thick one here, and then the thin one. It thins out as you go low down. Here we can see the contrast, which is now, which you can see that it is in the thoracic area. So basically, it was at the level of L1, L2, and there was migration of this contrast and the local anesthetic solution at this point, in very high up in this area. So this has been very nicely laid down by Miguel Reina. The subdural space, they call it as a dural arachnoid interface between the arachnoid and the dural lamina. And what happens is the predisposing factors are excessive manipulation, like multiple punctures, prior back surgery, and a recent lumbar puncture. So these are some of the predisposing factors. This is a suite test where he mentions that there is a diffuse motor response if you are using a catheter through which you can neurostimulate the epidural space. So this is what they call as the suite test, and this is the onset time by Lubenow. This is one of his articles which mentions the concentrations, the volumes, and these are the various variables. Look at the onset times anywhere from 5 to 30 minutes. The recovery time anywhere from 3.5 to 6 hours, and they have come out with some major and minor criteria. Like this is the Lubenow's major criteria and minor criteria, and Hoffman has mentioned about a 4-step diagnostic: the tactile feel of epidural or subarachnoid space, the diametrable spread, excessive, restricted, or neither, and the minor criteria. There's a delayed onset by 10 minutes and a variable motor block. So this is how it was. This was basically a subdural. I had 3 cases in last 20 years. And I have, to back up, I have this contrast studies in these particular cases. So I need to know your responses so that we can move on to the second case.
Congratulations, Harshal, for bringing the possibility of subdural up.
Shall we start with the second case, Gopal?
I went through one, so that's why it came to my mind.
I know that. Shiva, your comments?
Yeah, yes. Dr. Gedo.
Shiva?
Can I come?
Yes, please. Gedu, sir.
I'm sorry.
Can be brief.
I'm sorry, just very brief. I don't think the subdural catheter can go up to that much extent what you've shown in the picture, or rather spine, because subdural space, they are so fused that it's what you call subarachnoid and
Yes.
dura, they are arachnoid. So they are so fused they cannot open up to that extent. Only your drug, whatever we inject, can be remaining over there, which can migrate because we are putting it forcibly. But if you try to push the catheter so forcibly, it basically punctures the dura. It doesn't go and migrate to that extent.
Yeah.
Putting the transducer to check over.
Yes, sir. It is not the catheter migration, it is the drug which is diffused to that high level. What you said.
But if you have seen the X-ray that have been shown, it is going in a beautiful linear fashion like a catheter. I believe it must be the...
It is the dye only is going to that.
It's the contrast. It's going right up to the thoracic area. It's not the catheter.
Catheter. Yeah, that's what he meant.
So can we move on to the second case?
Yeah.
Yes, please.
So catheter that did not work. This is an infusion. Now this is a 45 years female with bilateral multiple rib fractures from T1 to T8. She was given a cervical epidural catheter, which was placed with the needle directed caudal. So I rotate the needle when I insert at a level of T1 and T2. The initial bolus was 5 ml of 0.25% bupivacaine. The hemodynamics and respiratory pattern were stable. This was done in a sitting position. And the catheter insertion was still 7 centimeters. Post-operative, she was placed on 0.1% ropivacaine at 6 ml per hour, and there was no pain relief at all. So what could have gone wrong in this case?
The catheter probably left the epidural space through the intervertebral foramen.
Okay.
And
so what makes you think this, Gopal?
I mean, the very fact that there is absolutely no pain relief.
Yes.
So it is quite likely that the tip of the catheter is not within the epidural space any further. I mean, that is the first conclusion I would like to make.
Yes.
Sandeep, I wanted to ask who loaded this drug?
Myself.
Okay. Because injection errors are so common nowadays that whether you did place the local anesthetic or not itself is a question. So.
Right. So I did it myself, Bala.
Okay.
Shiva, Amjad, any or Rushali?
She had absolutely no pain relief, even after the
catheter went in smoothly.
Yeah, it went very smooth. It went so smooth that I never anticipated it would go that smooth.
Sir, I mean, once we placed the catheter which was there in the retrolaminar space, when we look at it, it has got an easy giveaway.
Yes.
We thought it is an epidural placement, but similarly there was no pain relief. When I did a dye injection at the end of the procedure on the table itself, we found the spread was only onto the one side.
I agree.
Above superficial to the epidural space. Then we confirmed that it is a retrolaminar placement of the catheter. Maybe it would have been that, because in that place, once you sometimes the catheter go very easily and your local anesthetic also the injection feels exactly. This is one experience I had.
Yeah, I agree with you that this is a possibility. False giveaway are quite possible in these particular areas. So nobody asked me.
Is that the epidural was put at T1, T2? Is it?
Yes.
And the catheter went in very smoothly.
Yeah. So the level was T1, T2, and the bevel was rotated to 90 degrees, and then I inserted a catheter from cephalad to caudate.
Any possibility it went sort of in the, well, it might be a long shot again, in the sort of pleural space? Is that possible?
Pleural space, there are some articles which mention interscalene catheters in the pleural space.
Mine, I'll tell you, we were putting a thoracic epidural, and while putting it, though it was not that high, while putting it, actually, I realized that the catheter is going in far too smoothly for epidural space. And when the surgeon put the thoracoscope, you could see the epidural catheter lying in the sort of intrathoracic level. There's a publication of mine on that, because the mention of it going very smoothly is something which is, very classical. It goes in so smoothly.
So in this case,
Sandeep sir?
In this case, Harshal, at least on the side in which it entered the pleura, patient should have had good analgesia.
Somebody is talking.
Sandeep sir?
Abhijit, can you just...
Yes. Sandeep, just one point that I just wanted to add here. If our intention is to rotate the bevel caudad and direct it that way, I'm not too sure if you would agree with me that may as well have the bevel directed towards whichever direction you want prior to the skin puncture, rather than going right near the dura and rotating it 90 degrees.
I agree with you, Roshali, totally, but I'm not comfortable with that.
And Sandeep, I wanted to ask you another question. Are we sure, just based on the bubble, that the catheter migrates the way you want? Until you use a stimulating catheter, I don't think we can conclude saying just because the bubble faced down, the catheter went down, bubble faced up, the catheter went up. I don't think that also it's a dictum that we can take into.
Correct. Perfect, Bala. I agree with you. So these are some of the articles, the effect of needle bevel orientation. Doing epidural.
Sir, what Bala sir was saying was perfectly bang on target. If you make sure you turn the bevel to the caudal and you try to say that my catheter is going to go down, 99.9% will still go up. That is what has been mentioned.
Azam, these are some of the articles which mention the effect of bevel rotation, which enhances the latency of block and the efficacy of the block. And these are for effect of rotation of epidural needle. Now, these are some of the surgeries that I did from 94 to 2014, mastectomy in my old place. I always turned the bevel of the, rotated the bevel of the needle, and you can see the placement of the catheter. And you can see that it goes right into the epidural space and delineation of both roots on both the sides. But I would like to point out here one thing. Now, this was always with needle length, catheter length of 5 centimeters, but here the length is more than 7 centimeters. So what actually happened was the catheter. Abhijit,
please keep on mute mode.
Keep on mute mode, please. So what had happened actually is what Gopal mentioned about the migration of epidural catheter. You can see this is the, can you see the dot there? That is the epidural catheter in the epidural space on the lateral side. Then you can see that it is coming from the intervertebral foramen. And it is, this is where the vertebral artery and the vertebral vein will be located here. And it's coming on this side in the coronal plane through the intervertebral foramen. And then it goes right into the brachiocephalic vein and the superior vena cava. You can see that this is also in the coronal plane and the sagittal plane. So the thing was, even with aspiration, there was no blood initially. But when we did that, Dr. Madhuri was with me. So when we did that in the when we brought the patient back from the CT suite back to the recovery room, we saw that we could aspirate the blood. Now, if you see this, the whole scenario here, this is the epidural needle tip rotation, which I usually perform. This is the same patient. So that's the rotation of the bevel. And then I insert the catheter to a distance of even more than 7 centimeters so that I get it very effectively in the epidural space. So this is 10, which is going into, then that's 15 mark, which goes into, and then that's the 20 mark. So at this point, then I place my tip of the catheter. And then now you can see this is you can see the catheter which came from the dorsal aspect there, and then it goes right into the epidural space, and then comes out through the intervertebral foramen, and then into the brachiocephalic vein, and then it goes right up to into the superior vena cava. So when the staff said that there's no pain relief, I asked her to stop the infusion, and we did this particular thing the next day. You can see the catheter which goes right there into the brachiocephalic and the superior vena cava, and this was 0.1% ropivacaine, which was running at around 6 ml per hour. It goes right up to there. You can see the tip which is located at this point, and this is the coronal image. You can see the catheter tip there, close to the spinous process, and then into the epidural space, and then comes out to the intervertebral foramen, and then goes into the brachiocephalic vein as well as into the superior vena cava. So at the first time when we injected contrast, I wanted to see the spread, whether, as Shiva said, it is in the retrolaminar area, but we could not find the catheter. So the radiologist suspected that if you don't find it, it must be in the intravascular compartment. So he asked me to give just the dead space amount, which is around maybe just 2 marks of the 2 ml syringe. So when we did that, we could get that. And then when we got the patient back into the recovery, we could frankly aspirate the blood from the, you can see that, there's a frank aspiration of blood. This is the same patient. So the catheter located at that position in the same patient. This is from a different angle. So this is how it is. So you have any comments on this?
Dr. Sandeep, how deep was the catheter inside the patient, and what was the initial insertion distance? Because for it to reach that distance, I think a lot of the catheter has gone in.
Yeah. So I positioned the catheter around more than 7 centimeters. I should admit that the length was a bit more than what I had anticipated. Usually I don't keep it. I keep it less than 5 centimeters because that is what has been mentioned in the literature. 3 to 5 centimeters in epidural space, anywhere from cervical to the sacral. So this was a bit more. I agree with that, and this is the reason why the rotation of bevel of the needle, as well as a very smooth insertion, as Harshal said and Roshali said. These are some of the criteria that you should keep in mind when you do this technique, and not more than Amjad, as you say, not more than 5 centimeters in the epidural space.
Sandeep, actually, I quite agree with your thought process. In the sense, I would use the direction of the bevel to direct the catheters, knowing it very well that it may not actually do what I wanted to do. But in many caudal regression syndromes, and when there are anomalies, we do scan the highest possible space, which has a very, very good bony architecture, and we do that and we put it towards the caudal area. So it has worked, at least clinically, for us, although we haven't done any contrasts as you have.
Okay. So this is
Sandeep, just a small addition. Whenever we deal with cases where you definitely need to get a good block, I think it's best to use a stimulating catheter,
yes,
so that we will be really guided by where the tip is.
I absolutely
agree. We would love to, but it is a very, very, very not that cost effective is what I would put it as. I would then rather take an ultrasound probe, which I already have in the OT. No, but of course, the most logical one would be go for a stimulating catheter. But then you need to have that kind of a nerve stimulator, which would go to the highest level of, say, 10 of the current strengths.
Gopal, yes.
Sandeep, I would like to offer a simple, different perspective.
Okay.
Instead of choosing T1, T2 as the insertion point,
yes,
and moving your catheter caudad,
yes,
would it not be easier to choose T7, T8 as your insertion point and direct your catheter cephalad?
Okay.
Sandeep, I want to add a few things. Sandeep, can I add a few things?
Yes, please.
One, there are 2-3 things which I want to tell. One thing that is been already discussed a long back also, that never rotate the needle in the epidural space wherever you are.
Right.
Because there have been, I still remember that Narendra Rao has written the articles where he said initially denied that you can rotate, but thereafter he has also agreed. I do have a couple of slides, not now, I can show you, or I can send it to you later, that you should never rotate the needle. Because see, when you are putting the needle inside the epidural space, you may find a very good that you are in the epidural space. But when you rotate the needle, you must have gone into the vessel or
Yes.
there is a very high chance you may go also in the intrathecal space.
Yes,
So
sir.
never rotate the needle. What I do normally is maybe at the most I can go up to the what you call muscle layers and all those things. Thereafter, whichever whether I'm going caudal direction or I'm going what you call cephallar direction, I put the needle in that direction only. Never rotate the needle. One. And second thing, it is a very rare complication, but it's really admirable that you have done such a lot of imaging and you try to find out. Only thing I believe there should have been a small test dose that could have been given, because when
Agreed.
you are inserting the catheter inside,
Yes.
actually it must have at the tip must have got blocked, so you may not be able to aspirate the blood. But
Yes,
the
sir.
minute you inject the drug, you got the blood back
Yeah.
because you flushed the catheter.
Yes.
That these are my opinions.
Yes, sir. Thank you very much, sir. Gopal, you want to add just the last thing because I want to show one, and Amit also wants to add something.
No, please go ahead.
So this is what I agree with you, Gopal, not to rotate the BVL. I agree with you, Gedu sir. And then this must have left the epidural space to the vertebral foramen. And the catheter distance not more than 5 centimeters. Amjad mentions that. Bala mentions stimulating catheters. Yes. So this is what I use many a times for the, again, I rotate the, so that I get the needle in the right, catheter in the right position. So you can see the, this is a Payung catheter or an arrow catheter, whichever you have. So it can stimulate, you can see the contractions of the latissimus, then you can see the triceps and biceps. Roshali, you can get even at a current of around 2 milliamperes, it has to be always more than 1 milliamperes. So this is the final placement of the catheter. Then you can see that I make him sleep, and it is a unilateral placement of the catheter, not on the left side, only on the right side where the surgery is going to be performed. Then I give a bolus of around maybe not more than 5 ml of 0.5% bupivacaine. I always see that I involve imaging technique. You can see the catheter placement. This is going to be on the dorsal side of the epidural space, correctly positioned. And then you give around 5 ml of 0.5% bupivacaine that will enhance the posterior epidural space. It goes along the epidural space anteriorly, and some trickles on the other side. So this is a perfect placement of the catheter with the volume of local anesthetic. And with just 5 ml of local anesthetic, you can actually perform a proximal humor surgery. That is the surgery which is being performed. And this is the patient in the intraoperative period. I just have to give one small bolus. That was what was required. Post-operative, we can see that he had intact lower limb, no neurological dysfunction there. You can see the catheter is still in place in the post-operative period, and you can put him on infusion pump, which you require less than 4 ml per hour of 0.25% bupivacaine. So with this, we end the. I would like to stop sharing here. Amit wants to show something from his side, and then we move on to Rushali's presentation. Dr. Avinash Gaikwad has to be here.
Yeah, I just want to add one small comment here. I'm sharing this slide. Yeah, so when we are doing thoracic epidural, we have to confirm whether our epidural is in place when we are doing it. So most of us either depend on test dose, or the person who is actually doing it, either with loss of resistance to saline or loss of resistance to air, they themselves know, they have that clinical judgment whether my catheter is in place or not. The most common method of confirming is what we have mentioned is test dose. Other is if we are putting an epidural for a bigger case like a onco case, and we are putting an ard line as well, it is very good idea to transduce it, and you can have a good tray. A well placed catheter will have a nice tray. The only thing is we need to use loss of resistance to saline to have a to diagnose a correctly placed catheter. Most of us do not have that SUI test set to confirm that. In my practice, what I do is, if I use a test dose, I check with hot and cold saline how much is the sensory level which I have achieved, and I confirm whether my epidural tip is congruously placed. In my opinion, turning bevel up or down may not do the trick. My idea is to use a congruous placement and keep the catheter bare minimum inside. put a test dose and check with hot and cold how much is the sensory level. So this is how we confirm it. And I think if we have a transducer in place, it is good idea to just transduce it. That was a small addition. Thank you, sir. Yep. Yep.
Thank you, Amit, for that. Roshali, are you prepared for this?
Yes.
Roshali?
Sandeep, yes, yes, well, yes. Sandeep,
Yeah.
just one thing. I'm sure there are many juniors also watching this with quite an awe with what you have just shown, and it's amazing. But just one small caution. Look, this is Sandeep performing an epidural in a very high, I mean, a cervical or a higher thoracic area for an upper extremity surgery. Let that be encouraging, but not a take-home message for you all, because we need to first go towards the most acceptable peripheral block and then come to the central neuro axis till you get an expertise of having both in hands with equal dexterity is what I would put it as.
Thank you, Roshali.
Sandeep sir, before you conclude, can I ask you one thing?
Can we discuss later, because we are running short of time, Arun? Okay. Thank you. So this is Roshali Pondal. Everybody knows her. She is our beloved president, managing trustee and founder of AORA. She owns AORA in short. She is the director of Anesthesia Services, program head of WFSA Children Anesthesia Services, Pediatric Regional Fellowship in Mumbai. And she has her third edition of illustrated manual book on regional anesthesia, ultrasound. She has been a speaker and faculty to several workshops, national and international, as well as conducting workshops in all these areas. So, Roshali, it's up to you. Can you share your screen now and you can go. 20 minutes, 25 minutes, sorry.
Yes, Sandeep. I think I have taken you on a detour here. Anyway, welcome to the world of pediatric regional anesthesia. Am I heard as well as seen? Am I heard as well as seen, Amit?
Yes, madam. Yes, madam.
All right. So welcome to the world of pediatric regional anesthesia, and namaste to all of you. You know that I really love this quote. I'm full of fears and I avoid difficulties, and I see not have any complications, but for that I see to it that everything around me is absolutely crystal clear and calm. Now this quote, we do not have this luxury of being in fear, neither we have our surroundings always very calm, and yet we need to calm we need to do. So here is complications of pediatric regional anesthesia. In a very short span of 25 minutes, I shall try to give you the perspective and the gist of all that can be thought of and rather practiced in everyday work. This is kind of a continuation from what we just saw yesterday with Dr. Luke elaborating on that in adults. I'm only going to give you the pediatric perspective of it. So first in this, the paradigm is as such, we are going to look at the safety profile of pediatric regional anesthesia. We're going to see the causes of complications as such. Why do they happen in the first place? We are going to best deal with these as case scenarios. We are going to look at the treatment of LAST and finally see how it really differs from adults, because this is where the subtle differences lie, which indeed are very few, but worthwhile to note. We all agree that we either give heavy sedation or general anesthesia to pediatric age group. Again, I take back to what Dr. Luke said yesterday to all of us, an awake patient who keeps telling you, who keeps talking to you. Even Shiva in the morning said that yes, sedate them, but have them awake enough to tell you about paresthesia or tell you about tingling, numbness. So that goes a long way if you have an awake patient. A sentence spoken by Sandeep keeps ringing to my ears. He had once said that an awake patient is a best monitor when you give regional anesthesia. This luxury is not going to be available to you for pediatric regional anesthesia as such. But the good news here, and it appalls me at that time, sometimes, is still we do not have much complications in pediatrics. So I don't know where is the guardian angel. The guardian angel is perhaps because we just are more cautious now, since we know that we do not have the best monitor with us. So causes of PRA, let me tell you, let's always not blame LA. It's not always the LA. There are many other aspects, such as needle and its trajectory itself can harm. Then the complications, of course, due to RA, and the patient's factors here, especially in prematures, neonates, or any concomitant factors such as maybe sepsis or such as a liver disease or such as renal dysfunction. The needle and its trajectories, it would be maybe here is a child who's fallen down and has a right elbow fracture. We planned a general anesthesia with intraclavicular block with a PNS and with a pristine saturation of 100%. We just found that it's falling down to 50%. If that is so, then definitely this is a pneumothorax, doesn't need much to think about this. So how do we avoid it? Is, of course, if possible, always use ultrasound for this. Stay lateral if we are doing it with PNS or ultrasound, either ways. See to it that you first visualize the pleura. You really don't need to go a little medial for this. Pleura in children will be even seen while you are at the coracoid process. Now, another complication, 8-year-old girl again, for a fracture ankle, we give a popliteal block under general anesthesia, and the surgeon doesn't have toe movements for quite some time, even after 24 hours. Well, it doesn't happen for 7 to 8 days, in fact, much of it, but it doesn't concern because she's a sister. But as an anesthesiologist, we know what we are dealing with. We discuss with the surgeons, and it came around, yes, because perhaps sciatic nerve is pretty forgiving here. So even if you have an ultrasound, we need to be not so reckless with the nerves that we look at, and rather not really make them swell, even in children. And in children, of course, here, everything is very, very supple. So stay a little away from the nerve and see to it that the nerve gets bathed and rather looks a little smaller than, and even better, more echoic rather than swelling the nerve up. Well, another complication is a 14-year obese teenager comes to us with bilateral femur plate removal, but they insist on a continuous epidural or being done in a single shot femoral block, either ways as well. But this is because previously they had a very good analgesia due to continuous lumbar epidural for the same procedure when the plates were inserted. What we actually find with this case is we give an epidural with sedation and it goes on very well, but then the child in the postoperative period did complain of heaviness in the upper extremity. We stopped the infusion and the heaviness kind of disappeared, but we kept the child on floors, did not activate the infusion. When he started complaining of pain, we went, gave a small bolus, only to see that there was a sudden decrease in pain, or rather disappearance of pain, and again heaviness in the upper extremity and heaviness in the lower extremity as well. So this was a lumbar epidural catheter which actually went into the subaqueous, went into intrathecal. This can happen. The catheter was removed, obviously, but since this was a plate removal, the patient was sent home and we got a call of PDPH later on. We owned it up. We went, followed up the child at home, and we obviously dispensed all the treatment that was required, but it took its own time for recovery. So this can happen and we need to be very careful about such things. Now, one thing that actually is a boon for all of us when it comes to pediatric regional anesthesia is caudals, and that too in infants, prematures, and neonates. This is a 4 kilogram premature or preterm rather who comes for bilateral inguinal hernia. We just give a whiff of sevoflurane, give a good caudal block with a volume of say 1 ml per kilogram, aspirate, give it with the traditional method. The babies turn supine to form to become apneic. We hastily put in a tube, take control, and well, yes, the surgery in fact does proceed also. Now, what must have gone wrong? Let's really meditate on the scan here. If this is the area there where one never should be venturing, this is the dural sac. So all that was calculated for an epidural, if it punctures inside through, and if we deposit all the drug here, we are going to get a total spinal in a baby. And if we do that, we are not going to get any catastrophic decreases in blood pressure. We are going to get hypoxias, and we are going to get decrease in heart rate, and we are going to get arrests and apneas, which are more due to the respiratory aspect rather than the cardiovascular aspect as such, especially in this. Remember, not everything in children is local anesthetic systemic toxicity. After having said that, this particular block, which fits in 1,000 indications in pediatric population, can have many complications which are worth noting. One complication is you could have a subcutaneous injection of all that you have calculated, and you would see this particular aspect bloating up. Then what you would see is you can just have an intraosseous injection here. Remember, intraosseous injection can always lead to pain later on, yes, but a child may not tell you that, or may lead to infections, osteomyelitis. What we are probably not considering here at all is intraosseous injections are as good as intravascular injections in at least this age group for caudal. Hence, remember, the gives and the feels that you get while you give a caudal block may not always suffice unless you are a hardened pediatric anesthesiologist, because in neonates, it's very, very easy to go through the floor of the sacrum and yet not realize it. So better have ultrasound with you, or if not better, if you don't have ultrasound, see to it that you have mastered this block in grown-ups and then come to neonates. If you encounter cysts, or you might just have some telltale signs such as tuft of hair or discoloration or a little dimple here and there, pick up ultrasound, see what it is. If you do not do that, don't give the caudal epidural block ever. If we have operated cases of meningomyelocele and they come back to you, do not venture into their central neural axis. If you have to, then make sure that you understand it ultrasonographically and then go ahead. Now let's come to last as such. Now what do we have in store here? We can anchor the entire concept here towards prevention. I guess nothing else is more important than prevention of last year. Well, how do we really prevent it is take a good choice of local anesthetic. See to it that dosages are very, very well understood. See to it that we understand the fine tuning of dosages and volumes. See to it that our rate of injections are good, just as per the recommendations. And what are our concepts about test dose and which is the best test dose that we would pick up, if at all we do. So these are the local anesthetics that are used, and this is one of the most easiest tables that I could think of to put to all of you. Now, if you ever want to extract more volume than what is given to you here, then please simply add normal saline and increase the volume, but do not increase, or rather do not take the same concentration and simply increase the volume. Is bupivacaine really unsafe? Is ropivacaine really very safe? Let's look at this concept first of all. Look, the Tmax of ropivacaine, but not bupivacaine, is delayed in children. So if everything is status quo, but if we have a very small surgery, I think both are quite fine. But bupivacaine has an edge over the fact that it is going to surge in the plasma earlier than the ropivacaine. But ropivacaine will have a fantastic hemodynamics for a catheter. So for a longer procedure, for catheters, go to ropivacaine, insist on it. If you have bupivacaine for shorter procedures, remember that this is one of its advantage. And literature has shown bupivacaine and ropivacaine causing cardiac arrests any which ways. I'm no way trying to tell you that bupivacaine is better than ropivacaine. I'm simply showing you what are the advantages of both by this. Coming to test dose, I think we need to rest on this particular aspect for a change. Literature is swaying towards both here and there. But in my practice, what I would suggest through my practice, whatever little I have seen, I would suggest that there is absolutely no harm in using a simple test dose such as lignocaine and adrenaline, and we shall soon see why. Well, what is required as a standard test dose and which can actually give us the scenario that we need to see, or the consequences that we need to see as a test for a test dose, is simple: 0.1 ml per kilogram of 1% lignocaine adrenaline, which is 0.5 micrograms of kilogram. Having known this, come to the operation theater. If you pick up 2% lignocaine adrenaline and use it in a dose of even 4 to 5 milligram per kilogram, you give more than enough of adrenaline to see the results of the test dose. So there is nothing additional that you need to do in small kids. All you need to do is aspirate the dose that you require in milligram per kilogram of 2% lignocaine adrenaline. It's as simple as that. So what patterns do we see, if at all we do? T wave amplitude is the specific one, ST changes, heart rate, but the most specific one is heart rate slowing, in fact, rather than an increase in it, or nodal rhythm, and which is uncommon actually, but very specific. Please give a lag period of at least 1 to 1.5, or rather 60 to 90 seconds to manifest the response. Hence, it is always a good habit to take your time while you inject, which is actually go in aliquots of the quantity that I am just going to share with you. So the aliquots should be 0.1 to 0.2 ml per kilogram, and go very easy while you inject. Another feature that I have always seen is, in spontaneously breathing children, it is always good to give a test dose or any regional anesthetic for that matter, because if something has to go wrong, they first stop breathing. Maybe since morning, whatever we have discussed about the muscles and about what the respiratory system really gives a response to epidural injection, or in intrathecal injection, maybe works here as well. But this is a simple clinical finding that I would want to share with you. So this is how we inject a drug. Evidence B4 level is given to test dose, but I see there is no harm in using a test dose. In fact, the lignocaine adrenaline that you have used in children would hasten the block action as well, because for very small surgeries, your surgeon is going to just wait till you give injection, and he would be there to simply take an incision in a while. Unlike complicated orthopedic surgeries where they'll take a time in scrubbing, draping, and give you those 20 to 25 minutes for your block to act. This doesn't happen in simpler hernias and circumcisions. Well, coming to complications due to local anesthetic per se, the allergic reactions are given by preservatives, but very, very, very rarely seen. So now let us come to the main area of what LA per se does to children and how does it differ here. All the previous signs, such as numbness, such as lightheadedness, such as all other, whatever the patient would have told you, there are no patient factors here. Simply, you might see convulsions if you have not used a muscle relaxant. Practical point of view, again, veins in children are difficult. I have seen children convulsing, not too many though for my luck, but if they start convulsing, see to it that you hold the hand which has a vein, because if you lose a vein, it gets very, very difficult to have convulsions controlled. So steady the hand first, control the convulsions, go to 100% oxygen, intubate the baby. and then think whether you want to ever proceed with surgery. That comes at the end. But then this is one practical tip I want to share. Midazolam, thiopentone, or even scoline for that matter, would be really a good alternative. Scoline has no place in today's modern pediatric anesthesia as such, but we do not start a case without scoline because it is one of the best emergency drugs that one can use in such situations, and laryngospasms as well. Coming to cardiac toxicity as such, CNS I've already discussed with you. So coming to cardiac toxicity, what can happen if whatever we calculated for a nerve plexus block goes in the intravenous compartment? Here is a professor, loves to teach. Now, 2 hands are atria and 2 limbs are the ventricles. Here he goes. Atria, ventricle, inject bupivacaine intravascularly and see what happens to the atria and the ventricles. Now, again, atria, ventricles, shuts down with bupivacaine, goes bizarre. All possible arrhythmias, the arrhythmias, the nodal arrhythmias, the fibrillations, whatever you say. Go standard management of epinephrine and defibrillation. Your patient's heart is not going to come back, and so is yours. So now what we do here is, having known that this is last, and I agree with every speaker before who said that at the suspicion of last, pick up lipids because there's nothing to lose. So this is what we would do in children as well. But what are the differences here? If in adults we give it at 1.5 ml per kilogram, 20% lipid emulsions, in children, we really do not hesitate going to 2 to 2.5 ml per kilogram. I shall soon give you references for this. And of course, the infusions remain the same. The first is, of course, call for help. See to it that the airway is handled well. See to it that there is no added acidosis because of hypoxia itself, or rather ventilation itself. So all the basics, we see to it that the compressions have started, and then of course call for lipids. Again, be very, very watchful for the IV lines here. Very, very watchful. Coming to certain cases that I would like to elaborate in front of you, which will give you the entire perspective of this subject. I'm going to give you cases which are actually reported. So 5 weeks old, 4 kilogram sevoflurane GA, single shot caudal, something that we usually do. Now, see what has happened here. Our first prevention, the drug and the dosage, and see what has happened. 4 ml of 1% ropivacaine instead of 4 ml of 0.2% ropivacaine. There we go. Respiratory arrest, in fact, chest compression started, and here they have actually revived with epinephrine, and they got the baby back, and serum ropivacaine concentrations were very, very high. But they have revived this particular case, luckily, with epinephrine itself, and these are the ECGs that they really have documented and shown us. Okay, now coming to another case. 5 kilogram baby, same sevoflurane, and 22 gauge short bevel needle. A good gauge, in fact. When I read 25 or 24, what concerns me is a very small gauge needle might make the vein actually compress or rather collapse while you aspirate. So you do not get a test dose, or rather the aspiration that you really look forward to see. Hence, a 22 gauge is a good gauge needle. So negative test and bupivacaine properly calculated with the test dose of epinephrine is given. And still you go ahead with the toxicity, which is heart increase in ST segment elevation, T-wave inversions, and so on. And 2 microgram per kilogram of epinephrine is given. ECG persists. And then finally, we come to 10 ml of 20% intralipid given at 5 minutes. Now he's 5 kilograms and we have given 10 ml. Dose is 2 ml per kilogram of intralipid, and ECG comes back to normal. There are many studies which are showing us that ultrasound is reducing volume and ultrasound is helping us. There are RCTs which have told us, and there are case reports which have actually here and there cautioned us that no matter what modality you use, in spite of ultrasound, we have had issues in pediatric regional anesthesia. Here is one classical case report, which I would want you to take a note. I wonder at times when people talk of big RCTs, the case reports also tell you a lot because it's a day-to-day practical work which simply comes up here and there randomly. And when it comes to local anesthetic systemic toxicity, remember what Dr. Luke also said, there cannot be RCTs. So case reports are our saviors, and hence watch out. 2 days old, 3.2 kilogram neonate, ultrasound confirmation of space expansion, and still we get last. The treatment remains the same, but the thought process is, take a note, you're never too sure that you won't get a last. Now, the thought process of intralipid or versus epinephrine, of course it's intralipid and not epinephrine. Conclusion is simple, prevention is better than treatment. Follow maximum allowable dosing guidelines. Nobody is going to tell you that when it comes to children and when you want to mix two drugs such as lignocaine, adrenaline and ropivacaine or bupivacaine, what is their maximum dose? In such a case, go to their lowest possible dose in the range that is given by literature. Use ultrasound when possible. Consider test dosing. Slow incremental injection should be your norm. And of course, come to education, recognize intravascular injections, recognize systemic absorption and no treatment algorithms. So please keep on attending many regional anesthesia seminars and workshops. Keep intralipids and protocols ready. Dosages are not difficult at all in children. Now, one complication that hurts the anesthesiologist the most, especially in children when they are in the wards, is a failed block. Under general anesthesia, nobody else will know, but you at the head end will know what is giving the operability. Is it your general anesthesia? Is it the fentanyl rescues that you keep giving? Or is it a well-placed block which lets you take sevoflurane concentration to even less than 1%? So if your needle placement is correct, but the dose is wrong, classic example, caudal. If you haven't given enough volume, no matter how well your needle is, pristinely seen and ultrasound, still you will get a block which is not acting. Correct dose, wrong needle has to fail, and both are wrong, well, you get block failures. So this is how I would say that see to it that you have your needle as well as your drug very well calculated and placed. So thank you very much, and this is how I would like to end my lecture. And this is the family of mine of Academy of Regional Anesthesia. We were pretty young, very long ago, and now this is how we were in 2019. Thank you very much, Sandeep, and thank you for giving this opportunity to me. Thank you. I'm obliged.
Yeah, thank you very much, Vrushali madam. That was a very elaborate presentation. We have one question for you. Dr. Surjit Giri from Assam is asking this question. Kids have less soft tissues and nerves are much more superficial as compared to adults. Whether there is any chance of more neurological injury with PNS?
Yes. I have practiced PNS in children a very long time ago. And even today I do practice when I don't get ultrasound in certain nursing homes. What I would say, Surajit, to what you have just said is, we really do not chase a number in children. We really do not see to it that we have to get a twitch at 0.5. Even if we get a twitch at 1, we are pretty happy with it because the sheets are supple, as you say, and the local anesthetic percolates far easier. So don't insist on a magic figure. If you get a very good response, even at 1, go ahead and inject. You're going to get the block, is how I would answer your question. Is that okay?
Yes. Thank you, madam. One more question is there from Harshal. For some of us, who do not do kids very regularly, would it be safe to do peripheral blocks instead of neuroaxial block with ultrasound?
Well, Harshal, it's lovely to have your question. What I would say is do the block that fits the best and you are most comfortable with. Otherwise, there is no point in having the best described block, but if we aren't comfortable with. I totally get your point.
Thank you.
But I guess still the central nervous, the caudals are the ones which are taught the most right in the beginning of our residency as well, is what I would
No, that's true. The only point what I was making is traditionally we have been doing caudals for say hernias and for most of the things for unilateral limbs. But if now do we have the option of an ultrasound where we can sort of selectively do just that one side, especially pediatrics?
Why not?
Yeah. So would
No,
that?
it's a lovely thing because yes, this is all about going away from central neuroaxis. But if you know a sciatic, you've mastered it in children, you have to go that way. That's absolutely fine. But for hernias in a very small baby, I really do not think a hernia block is a good option because their tissues and their layers get disturbed, and in a neonate, the surgeon is going to struggle a lot to get the sac if you have given a hernia block or even an ilioinguinal iliohypogastric, no matter how small volume you give. And an uncomfortable surgeon is a very bad idea. So I would still go to the central neuroaxis.
Ma'am, one question from Ritesh here.
Yes, Ritesh.
Ma'am, how frequent is the incidence of PDPH in children and any difference in the management of PDPH in children?
Very interesting question. But I want you to know that we practice very, very little spinal in pediatric age group as such. Very few times. Hence, the incidence is not so well documented as far as my knowledge goes. And the treatment almost is the same as adults. We just ask them to drink a lot of coffee. We ask them to lie in bed, play with video games or read books. Yes, that's all we do. Give them more fluids. I don't see it anything different. I haven't seen anybody writing off a blood patch for a pediatric PDPH. And very, very small babies, they may not just tell you that they are in PDPH at all. And we do not give spinal for one simple reason, that spinal wears off very fast in very small children. Unless we are dealing with adolescents, then it's almost the same as adults. Hence, we like epidurals or caudal epidurals, which give a lingering analgesia in the postoperative period.
Thank you, ma'am. Thank you.
Thank you very much. Now we are all set for inaugural function. Yeah. So you want to...
Hello, can you hear us?
Unmute.
क्या बेटा ना कांदा काट के रख आती हूँ आलू कुछ नहीं काटेगा नहीं बेटा
Madam, mute your mic. President ma'am.
Hello. Dr. Diwan, are you there?
Can you hear us?
Yes, we can hear.
Yeah, okay. So we start with the inaugural function right now, and then we go to the main program later on. So we have Dr. Madhuri Dadke with us. She is a consulting anesthesiologist in Sanchali Hospital, and she is going to take over.
We warmly welcome our delegates, national and international faculty, dignitaries on the dais, and distinguished guests. This year, we conduct the conference in a novel way and create a virtual experience to interact with faculty across the continents. The PRAC has now become an unmissable event every year where we share innovative ideas, enhance knowledge, and reassess safety standards in regional anesthesia techniques. We hope you relish this opportunity to listen to stalwarts and update your skills. We now light the auspicious lamp. I invite Dr. Bharati Adde, Chief Anesthesiologist, Sancheti Hospital, to introduce Dr. K.S. Sancheti, sir, Founder President of Sancheti Hospital.
Good morning, all. It's a most difficult job to introduce Dr. Sancheti in 2 minutes. Born on 24 July 1936 in a small trader's family, Dr. K.S. Sancheti worked very hard to become an orthopedic surgeon and progressed to become a medical icon of the nation. He completed his MBBS from BJ Medical College in Pune and MS in orthopedics from KEM Hospital, Mumbai. When Dr. Sancheti started his practice in 1965, polio was rampant in India. He focused his practice on the treatment of handicapped polio children. He has conducted more than 400 free polio camps all over India and treated more than 1 lakh disabled children. More than 12,000 surgeries were carried out for deformity corrections and more than 20,000 calibers were provided. He established Sancheti Institute for Orthopedics and Rehabilitation in Pune in the year 1972, which is today a state-of-the-art 200-bedded orthopedics and trauma hospital and is ranked as one of the 3 best hospitals in India. Dr. Sancheti is the only surgeon in India with the unique distinction of designing indigenous processes for hip and knee replacement surgeries. Dr. K. Sancheti is an excellent teacher who has trained over more than 600 orthopedic surgeons during the last 50 years. He is an outstanding role model for punctuality, discipline, and patient care. His services to the society have been recognized by the Government of India. He has been bestowed with some of the highest civilian honors in the country for his outstanding services, humility, and dedication. These include Padma Shri in 1991, the Padma Bhushan in 2003, the Padma Vibhushan in 2012, and the Dr. B.C. Roy Award, the most prestigious award in the field of medicine in 2017. Ladies and gentlemen, it's my privilege to welcome our founder chairman, Dr. K. Sancheti, for this first ever Pune Regional Anesthesia webinar. We welcome you, sir. Thank you.
Thank you very much, madam. I invite Dr. Sandeep Diwan, Academic Director, Sancheti Hospital and Parag Chief, to introduce Dr. Parag Sancheti, Dean and Chairman of Sancheti Hospital.
Good morning, good afternoon, everybody. It gives me a great pleasure to introduce you, Professor and Dean of Sancheti Institute for Orthopedics, Dr. P.K. Sancheti. He has been of a great help and a great who has pushed us forward into academics. He is a visiting faculty in Dundee and has been awarded the FRCS of Edinburgh, several academic and social awards to his credit. He has been a consistent traveler to several national and international conferences and has given a number of orations, and he has been a speaker and faculty to in workshops as well as conferences. He has several publications and he has written a couple of books, and one particular book which has inspired me was with Mohit Bhandari from Toronto, and this is regarding the research areas. He likes to travel a lot and he socializes until the COVID has tied him down. I welcome Dr. Parag Sancheti.
Thank you, sir. I now take the opportunity to introduce Dr. Raghbir Singh Gedu. we are conferring the lifetime achievement upon Dr. Gedu. Dr. Raghbir Singh Gedu started his academic career by doing DA in 1984, MD in 1986 from VMMC Solapur. He has been conferred fellowships FICA and FIAPM. Earlier, he was professor of anesthesia in Tata Memorial Hospital, Mumbai. And now he is professor and head of department, D.Y. Patil Medical College, Navi Mumbai. He has 392 presentations and 62 live demonstrations of nerve blocks in workshops to his credit. He is the editor of 7 pain books, has chapters in 14 books. He is an international faculty in Beirut, Cairo, Dhaka, Bangkok, Sri Lanka, and Cambodia. He has been ISSP secretary for 6 years and former chairman of IAPM course. He is on the editorial board of IJA and IJP. He is the only Indian to represent in the formulations of neuropathic pain guidelines at Asia Pacific Meet Cambodia 2007. And his main interests are acute and chronic pain, difficult airways, and teaching. I request Dr. K.S. Sancheti sir to confer the Lifetime Achievement Award to Raghbir Singh sir Gedu. Thank you, Dr. Gedu, for accepting the award. I request you to share your experiences with us.
Congratulations, Dr. Raghbir Singh Gedu. We are indeed honored to have you to accept this award. Thank you very much.
Thank you very much, sir. To begin with, I start with a very well said, that is the respected founder, president, patron of the Sancheti Hospital, Dr. K. Sancheti, sir. Then respected dean and chairman of the Sancheti Hospital also, Dr. Parag Sancheti. Then Prague chief, Dr. Sandeep Diwan. Then Prague academic coordinator, Dr. Amit Dikshit. And then Dr. Bharti Alde, madam, HOD Anesthesia at Sancheti Hospital. And all the organizers of the Prague courses as well as today's webinar. I know this is the first time I'm getting such an award on the webinar actually. It's a little something unique. What is this? Start my video.
Yeah, you have to share the screen, sir.
Yeah, it's already.
Now we can see. Yeah.
Okay, I'm so sorry. Because I thought I was on the screen. Doesn't matter. Anyway, at the outset, a very much heartful thanks to all of you for honoring me with the prestigious Lifetime Prestigious Award for the Prague. Prague, all I can say, has already been a reputed and renowned course doing a noble and well-needed job or training to the novices in the pain management, both in acute and chronic pain. Dr. Bala Venkat, Dr. TVS Gopal, Sandeep Diwan, Vrushali Ponde, they are all already a well-known faculties, both nationally as well as internationally. And also very much proud to say that Sandeep Diwan has been my student from VM Medical College, Sholapur. That's a very proud moment for me. Well, if you ask me, I also remember my good old days when I performed my first gastric ganglion block, way block in 1983 at VM Medical College under the guidance of my mentor, Dr. Jehurkar madam, and that block was given blindly without any imaging. Well, today's things have changed a lot. Today it has come on the advancement of lot of imaging techniques like CT scan or C-arms, USG, etc. because this has got a lot of legal as well as what you call documentation levels that is being needed. So this is being added nowadays. And for this, we need a proper technique under the expertise that has become a very much compulsory and necessary. And I think Sancheti Hospital and Prague courses are doing a wonderful job for that. Anyway, I once again thank you all for the Prague organizers for honoring me with such a coveted award of lifetime achievement. Thank you all again, sir. Thank you so much.
Thank you, Gedu sir.
A round of applause.
A round of applause for Gedu sir, please.
Thank you, everybody.
I request Dr. K. Sancheti sir to announce PRAC 2020 open to the house and share his experiences with us.
Please unmute. Please unmute Dr. Sancheti.
Unmute, kara.
Sir, K. Sancheti sir.
Yeah.
Yes, can you hear me?
Yes, sir.
Yeah. Yes, good morning, I should say, and very happy to join this webinar and the PRA conference, sixth one. Dr. Sandeep Patwardhan, Dr. Dikshit, Dr. Bharati, all of you deserve a good compliment for doing hard work and getting all the people together. Regional anesthesia is advancing and advancing like all other cases in all other subjects, even automobile. Now, to keep space, not only we should develop the skill, but should also have modern knowledge and so that we can develop our skill better, do the things better. And for such thing, such conferences, even though through webinar, are very, very useful. The advantage of this webinar, more people are able to hear and more people can get the advantage of the speaker. I congratulate Dadbar Singh for getting Lifetime Achievement Award and a wonderful person as you are. I don't take much of time. I don't take much time, and I declare the conference open. Thank you.
Thank you, sir.
Thank you, sir. I request
Thank
Dr.
you.
Sancheti sir to address and inspire the audience.
Good morning, everybody, and welcome to the sixth PRAC meeting. On the outset, let me congratulate Dr. Raghubir Singh Gedev for having accepted this award.
Thank you, sir. Thank
and
you, sir.
In fact, sir, you have made us proud by accepting it. And the kind words you spoke have overwhelmed us. So
Thank you,
congratulations. I've always heard about you from Dr. Sandeep Diwan, and the work you have done is exemplary and is very trend-setting and inspiring for the new generation, which is also on this platform. So thank you, sir. And I wish to meet you in person at some point of time and learn more from you and get more inspired.
Definitely, sir.
We are in different specialities, but I think there is always a strong connection with the anesthetist, what we have. It's like a love-hate relationship. So there is more love now than hate. And I can tell you that during this conference. So I look forward to an opportunity to meet you in person, and congratulations to you.
Thank
and
you,
please, we were hoping to give you this in person because last year itself Sandeep had strongly recommended, and we were hoping to meet your family, but I'm sure we'll have more opportunities in the future once this pandemic is behind us and the gray clouds are swayed away and the blue clouds come again. Then we will meet. So congratulations, and we are
Thank you,
very,
sir.
very happy, sir, today that you have accepted this award and this has been given. This PRAC conference was started 6 years ago, and it was the brainchild of Dr. Sandeep Diwan. And he has really worked very hard to get this course to the current level. And I congratulate him and his entire team who have put the sixth PRAC conference together. Special mention to Dr. Amit from Ruby Hall Clinic, Pune, who has really worked hard, and he has taken a lot of efforts to for this conference to see the light of the day. So thank you, Dr. Amit. We are very happy to see you take these efforts. And of course, thanks to Dr. Bharti and the entire anesthesia team at Sancheti Hospital, who have been helpful and working under Dr. Sandeep's guidance and leadership to see the light of the day today. This time, when we were discussing about 2-3 months ago that how this conference will happen, I told Sandeep that please, you have to do this, may it be virtual, and we will see how it goes. And that time, Dr. Sandeep was a little skeptical, nice, sir, noko apan bagu. But today, I'm so happy that he has done this because it was record-breaking attendance yesterday. I'm told there were more than 10,000 viewers who were on this meeting yesterday, and 2,000 officially registered delegates. So I think Sandeep and the whole team, Amit, Bharti madam, it's indeed a great moment and a proud privilege for PRAC to see this. I want to thank all the international faculty who have joined, and the Indian faculty. Dr. Bala Venkat is here, and I hold him in high esteem. I've read his book he has written on a colleague, and every time I meet him, it's really, I feel very happy, and thanks Dr. Bala Venkat to be here. My regards to all at Ganga Hospital and to your entire anesthesia team. It's so nice to see you. Also, we have Dr. T.V. Gopal, Dr. Bhushali, and I heard some lectures, part of the lecture, and it's indeed really the kind of progress the regional anesthesia has made in specific, and overall the anesthesia is amazing. We only thought that orthopedics is only making progress, but that's not true. And there's so much to learn and so much deliberations. And I think in general, the lockdown has, done some good. I think people have got more time for academics, and I can tell you for myself that I find more time to read. Yesterday there was one webinar on PG teaching, and I was a faculty, and my lecture got over, but I waited the entire 4 hours from 6 to 10 p.m. and I learned a lot myself in the PG teaching program of IOA, Indian Orthopedic Association. So I think definitely this lockdown has helped all of us, and even though this has become a new normal, I think once things get back, this will still stay in some way, and this will continue further in a different way, but I think that has become the new normal. And I compliment once again the entire team for having put this together. I also want to thank the entire Indian faculty. There are so many names, but I can see so many big personalities here, and I want to really thank all of them: Dr. Hitesh Singh, Dr. Sachin, Dr. Amjad, Dr. Javed, Dr. Azam, Dr. Neha. All these people have really done so well in their own fields, and I feel privileged to be a part of the inauguration program, and want to thank Sandeep Diwan, Amit Bharti madam, and the entire team for making me a part. Before I end, just one special mention to Dr. Ashok Sham. So the Dr. Ashok Sham is the man behind the scenes, and he's the one who has worked single-handedly to put the whole conference together. And he started the Anesthesia TV. It is in Ortho TV. He has more than 25,000 followers. In Anesthesia TV also now he has 25. Yesterday 12,000 people nearly. So congratulations, Ashok Sham. And I also want to mention Mr. Rahul Chobe, who has helped with the logistics. With this, I don't want to take much time. There are more lectures left, but congratulations, Dr. Sandeep, Dr. Amit, and the entire faculty for spending your valuable time. And this is the new normal. Thank you, Dr. Bala Venkat, and all the Indian faculty. And lastly, Raghbir Singh, sir, I'm so happy to see you today and accept this award. And thank you, everybody. Have a great learning ahead. And I'm sure this prac will add a lot of value for you today, and which will help you in your practice and ultimately help your patients for a better outcome. Thank you very much.
Thank you, Bharat sir, for the inspiring talk. I request Dr. Amit Dikshit, Consultant Anesthesiologist, Ruby Hall Clinic, and Prague Academic Coordinator, to express his vote of thanks.
Thank you, Dr. Madhuri. Good morning to one and all. Today we are having 6th annual Prague conference. First of all, I wish to express our gratitude to Dr. Sandeep Diwan, the pioneer and chief of Prague. He has brought regional anesthesia at the center stage, not only in Pune, but across India. It won't be an exaggeration if one calls him the Sushruta of regional anesthesia. Prague has been successful thanks to the blessings of Dr. K.H. Sancheti and loving support of Dr. Parag Sancheti. Special thanks to Dr. R.B.S. Gedu for accepting Lifetime Achievement Award. Thank you, sir, for your words of inspiration and gracious presence. Department of Anesthesia at Sancheti Hospital, led by Dr. Bharti Adhye, kept no stone unturned for the success of this Prague academic extravaganza over last 6 years. We are really grateful to all consultant anesthetists of Sancheti for their invaluable contribution over all these years. I am extremely grateful to Dr. Rafael Blanco from Abu Dhabi and Dr. Luc Serumus from Belgium for accepting Prague invitation on such a short notice. We are extremely grateful to both of you, sir, for your great contributions. I wish to extend my sincere gratitude to the core committee of AORA which includes some of the doyens of regional anesthesia, namely Dr. Brushali Ponde, Dr. TVS Gopal, and Dr. Bala Venkat, for their gracious presence and contributions. Dr. Shiva Shanmugam and Dr. Amjad Maniyar, who represents the dynamic upcoming leadership of Team AORA. Thank you, Dr. Shiva and Dr. Amjad. I am extremely grateful to Dr. Abhijit, who is a research mentor to many young regional enthusiasts. You will be shortly listening to him, and I'm sure you will enjoy that. I am grateful to Dr. Malti Panchevak, who is a very active member of PRAC team. Thank you, madam. Special thanks to our esteemed moderators from different cities of India. Yesterday, we had Dr. Azam from Bangalore, Dr. Arunangshu from Kolkata, Dr. Hetal from Rajkot, and Dr. Himjyoti from Shillong. Today, we have Dr. Javed Khan from Indore, Dr. Ritesh Roy from Bhubaneswar, Dr. Surjit Giri from Assam, and Dr. Harshal Vrak from Mumbai. I would like to thank Dr. Ashok, Dr. Rahul Chaube, and whole team for providing us excellent audio-visual support. I am very much grateful to Ms. Savita and her team of Sonosite Fujifilm. Last but not the least, I am grateful from bottom of my heart to all 12,000 delegates and a team of PRAC Studio, which includes Dr. Diwan, Dr. Madhuri, you can see here on video, we have Dr. Sachin Arbi. So all of us, we are here, and we thank from the bottom of our heart to all 12,000 delegates from 24 different countries for your faith in PRAC team, for your unbounded support, patience, enthusiasm, and encouragement. It is only because of your best wishes that we are able to organize this spectacular and scholarly scientific symposium. Thank you indeed, everyone. Thank you.
Thank you very much.
I'm sorry.
Thank you very much, Parag sir, KHS sir, for joining us here. Shall we proceed with our program?
Yes.
Yes, go ahead.
Yeah.
All the best. Thank you.
Thanks a lot.
Thank you.
Thank you, sir.
Bharati छान दिसतेस.
Thank you.
So, Roshali, are you still there?
Yes,
Roshali?
I'm here.
Yeah, so I just have one question to you before we start with our next lecture. Dr. Bala will be definitely doing the next lecture. But before that, I thought whether it's possible to share the screen with you. Okay, so they do. So, Roshali, can you see this?
Yes.
So I just wanted to know what sort of post-analgesia you would prefer in this patient who's who's going to undergo a hip surgery. He's a pediatric patient, age of 10 years, and he has got severe deformities, as you can see, the lumbar spine as well as the placement of the hip. You can see those things. So how exactly you would proceed with this particular patient?
Well, it's an excellent case to put up to anybody. Let me tell you that. To
Yes.
begin with, I have had such situations before in which I had no choice but to go for a central neuroaxis block because the patient also had some other anomalies, especially those which can make them very susceptible for orphan syndrome, I mean, is what I'm talking about. They are very, very susceptible to malignant hyperpyrexia. So, and we had to somehow give a block and get going with it. And then there was another case again of the same kind, where we had the luxury of giving general anesthesia. So if we could get a luxury of giving general anesthesia, then probably that would be my first choice. Go ahead with it and put a single shot fascia iliaca compartment block, especially the suprainguinal one, and let the surgeon proceed. This will give a fairly good amount of hypovascular feel to them, because one of the reasons for pediatric regional anesthesia in such a situation is also a decrease in blood loss. And then after the surgery, I wouldn't put the catheter before, because it is going to come in their way and work, and they wouldn't like it. After the surgery, before they put a hip spiker, I shall again go in and put a catheter there. So this is what my plan is, if it is if general anesthesia is a feasible choice.
Yeah, it's a
At
general.
the same time, this is not a nursing home case. This would be in a place where we have sufficient backup in case we need any other support in the PICU. But generally, no matter how deformed they are, they do come out well of general anesthesia, because what you need is very, very little with them. If the block is well placed, and the local infiltration along the skin as well would help. If we need a central neuroaxis block, for sure, first scan the spine, because I can see only one view. I can't comment much on another, but usually the lower spine does give you an opening to get inside in such cases. So do that, or have an ultrasound, or have an X-ray. I'm not an extremely big fan of having X-rays, but I always ask my surgeons to be around for me to pick up a very good space, just in case I missed something in the X-rays. So these two aspects have helped, but ultrasound has helped me to pick up a good spine. I do not go for lumbar plexus in this, for sure.
Okay, that's fine. Roshali, I just wanted to know if anybody have an ultrasound. I mean, if anybody doesn't have an ultrasound, we can see the anatomical landmarks. This is the ASIS there, and that is the pivot tubercle. That is one which we join, and on this line, at this point, we inject our local anesthetic. So that isn't going to be a problem for anatomical landmarks.
I would even go for an epidural.
That would be very difficult. You can see the caudal space and the problem with this. It's quite difficult. There's rotation of spine here. You can see the pedicles in the AP view. In fact, you can see the whole vertebra which has been rotated.
Yes, I agree. But if you have an ultrasound, you can understand how. I mean, you do get your way through if we try a little. Yes, but
Okay.
I know it's difficult. But we have done this.
Okay, fine. Thank you very much, Dr. Roshali. So what we do is we will have Dr. Bala. Are you there? Yeah, he is there. So I will just introduce you to him. Dr. Bala Venkat?
Yes, sir.
Yeah, are you there?
Yeah, I'm there, very much ready.
Oh, okay, just let me introduce you very shortly, since I requested you a couple of times. So I requested you a couple of times, but I know that you do not need any introduction. He is currently the president of AOSRA, and this is the one which is internationally recognized. He's as well as the chairman of AORA and the ex-president of AORA. He has several orations to his credit, as well as he features in all the national and international conferences throughout the world. Dr. Bala Venkat, it's up to you.
Thank you, Sandeep, for the kind words of introduction. Respected and esteemed Sancheti sir, Parag Sancheti sir, all the anesthesiologists of the Department of Anesthesiology at Sancheti Hospital and Team Prague, led by the dynamic Sandeep Diwan, Amit Dikshit, Sachin Arabi, Madhuri, and the entire Prague team. Sincere thanks for giving an opportunity to be a part of the scientific deliberations, which is enriching about 12,000 people across the globe. And at a time when we are facing the pandemic with several unparalleled challenges that we are facing today, in every case that comes inside, whether to do, not to do, and to avoid aerosol generating procedure, one of the best things that can happen to this 12,000 people who are watching it is to enrich themselves in regional anesthetic technique, which would prevent them from using general anesthesia in several of those cases, which they may have to do otherwise. But I'm also convinced the wisdom of the human being and the brilliance in them would soon result in saying a goodbye to this pandemic. And also, I think you all agree with me, this extraordinary challenge posed by the virus can be won by doing ordinary things with extraordinary discipline. The ordinary things which all of us know is the social distancing, the face mask that you wear, and the hand hygiene that you would follow. If we do this in our workplace religiously, not just inside the operating room, when you are in the dining room, in the canteen, when we do this ordinary things with extraordinary discipline, I think we will win over. And sincere thanks to Sandeep for doing wonderfully well with this Prague for the last 6 years. Now I have designed and devised the next few minutes, which I'm going to speak on 4 basic blocks. I am aware that of the 24 countries which are present today here, many of them may not have an access to ultrasound. So I decided to have 2 blocks, 2 basic blocks, which is ultrasound based, and 2 basic blocks, which are based on peripheral nerve stimulator. And I also took into consideration when I decided which blocks to show today, I decided that something which is of great clinical relevance, especially when you wanted to avoid a general anesthesia in this pandemic. So first block, which I'm 100% fascinated, is the new infraclavicular approach called the costoclavicular approach to brachial plexus block. Seems to be a great concept when it was conceptualized in 2015, and enormous work has been done since 2017. So it's a relatively new block, but it's a block which has added tremendous value to the clinical results because of the fact whenever you need to do a procedure in the shoulder, always we used to go for an interscalene block or a subclavian perivascular block. But we also know that there is an involvement of the diaphragm, and there could be a respiratory compromise, especially in the geriatric age group. So it is a block which I thought I should take today, because whenever you're confronted with a geriatric shoulder dislocation, or you're having a patient with a proximal humerus fracture, henceforth, don't go for interscalene or subclavian. Go for this infraclavicular approach with excellent results without a phrenic nerve involvement, and no need to use oropharyngeal airways and aerosol generating procedures in the perioperative period. And it's of the infraclavicular block. This is far superior to the described and well-written articles on the lateral infraclavicular blocks, because here you will see that the cords have got definitive relationship with each other, least anatomical variation, highly superficial, a catheter can be placed successfully. And so I think this is a great block to learn. Just to show you, where does this costoclavicular space lie? This costoclavicular space lies between the clavicle above and the second rib below. On top of this, you see the pectoralis major muscle, the subclavius muscle anteriorly, and then you see the serratus anterior and the second rib posteriorly. So then
I would want you, all of you who are new to this block, just to focus on this picture. You see the axillary artery. This is the first part of the axillary artery. Lateral to that, you see this three cords. The lateral cord above, just below that is the medial cord, and then you see the posterior cord. So this is a beautiful configuration that you can see, and this is a block which can be done by every newcomer. And in this picture, I also would want you to visualize a small thin line of tissue which goes between the lateral cord and the posterior and medial cord. This is very important to know. That's why double injection technique have become important when you do a costoclavicular block. How do you stand? Where you keep the machine? This picture enumerates it. It's an excellent work done by Dr. Manoj Kumar Karmakar. And you see where you will place the ultrasound machine. One of the limitations of this block is you need to abduct the upper limb on ipsilateral side to 90 degrees to visualize the costoclavicular space. So that is important. You see where you stand at the end, and this is the ergonomics that you need to follow. And I'm going to run through you how you will start doing the scanning procedure. First, you will keep on the clavicle. Then you will slip down, come to the inferior surface of the clavicle. Then you will actually go into optimizing your view. So when you keep the probe on the clavicle, this is what you see. Most of the waves return back, and this is exactly the acoustic shadow. This is what you will see when you keep on the clavicle. Now you slowly move the probe down caudally, and now you see the pictures coming in. This is the just when you slipped in to the inferior part of the clavicle. First, try to visualize the axillary artery, after which you will see the structures. They're lateral to the axillary artery. You see the cord, and just above that you will see the subclavius thin muscle and the pectoralis major, quite a huge one. Down just below that you will see the serratus anterior muscle and the second rib. And you wanted to optimize this. This is immediately after you go inferior to the clavicle. If you want to optimize it, you just tilt the probe, slightly shuffle it to go into the space and see, and then you optimize your image. And this is how you would see. And having done that, this is how you will keep the probe. And this is a small video recording of, you see the picture, and now it's the needling technique. So it's actually in the mid part of the clavicle. And now you're all set. I would want all of you to go with an in-plane technique, and you can use a 100 millimeter needle, a stimuplex needle. And you see lateral to medial, you see the needle going inside, and you go between the lateral cord and the posterior cord, and then you inject the drug. The volume is between 15 to 20 ml of the drug that you choose. Either it could be bupivacaine or ropivacaine. So this slide, I'm just trying to show you, which clearly indicates that you have to initially put your needle between the lateral cord and the posterior cord, and after which you will, once the drug dissipates inside, you will see there is a small, in the picture C, you will see that there is a small hyperechoic line. You need to pierce this and to go and inject the drug, so the drug spreads well for the medial and the posterior cord. So it's called the placement of the drug in two places to make sure that it spreads uniformly for the entire cord. A note of caution when you do this block is several times you notice an aberrant artery coming inside, and usually this originates from the axillary artery. So if you confront this situation, if you are an expert, you will be able to negotiate it in such a way that you don't injure the vessel and don't produce a local anesthetic toxicity. But if not, if you are a newcomer, then I would wish that you will abandon this costoclavicular procedure itself, and then you go in for an intraclavicular block more laterally. Next, so this block is very useful to summarize. It's very easy, very superficial, can be performed by even the newcomers. The only limitation will be if you cannot abduct the arm by 90 degrees, then the space is not seen well. If you can do this, this is an excellent block, produces excellent analgesia for shoulder procedures. Many of the patients, geriatric patients with chronic obstructive pulmonary disease, one of the common things that you see is a proximal humerus fracture. You are afraid to give an interscalene block because of phrenic nerve involvement, and then you can choose the costoclavicular because the incidence of phrenic is hardly there, and you get an excellent analgesia, and you can do the whole procedure under the block. Next, I go to the next block I thought I should share with you is these are the days when you have prevalence of lot of diabetic patients in this country and across the globe, and patients come with for procedures in the foot. And they have multiple comorbids. They are on antiplatelets, they're on anticoagulants, they have neuropathies associated, and many of them come septic. So the next basic block, which I thought will enrich this population of diabetic, is a simple block, a superficial block, which can be done effectively in spite of the other clinical scenario in the patient. They may be say grade 3 or grade 4, but might really be happy to have an excellent quality of surgical anesthesia with a popliteal sciatic block. So I just wanted, and also the foot surgeries, they are becoming more popular now, and foot surgeries are extremely painful, and these blocks are such a boon to this patients. And the block can be performed in 3 different positions. One, it can be performed with the patient in the lateral position. It could be performed with the patient in the center picture. You see that the patient is in the prone position, or it could be done in a supine position with a flexion at the knee. And then you see how the operator sits on the side and holds the high frequency linear probe and the needle going in plane. So different positions can be done, and each one can decide which one would suit them. And what is that you would see? This is popliteal. The sciatic nerve is such a wonderful nerve that it has got it lies in a perineural compartment right from the parasacral region to the popliteal region, beautifully bounded by that. And you also know with the availability of high definition ultrasound, we have started seeing another layer, the paraneural layer, which is present here, making this sciatic block something very unique and different from other kinds of block. So when you deposit the drug, either you can deposit, you will either deposit between the epimysium of the muscle and the paraneurium. This is called as a subepimysial block. Even here you will get a good block, but the onset will take a longer time. But suppose you identify the paraneural sheath and you go and place it subparaneural, then the rate of onset of the block and the duration of the block is excellent. This is something which is very special about the sciatic block. And this paraneural sheath, this continues towards even the common peroneal and the tibial. So you can, when you scan it, you can use high frequency linear array probe, and you start your scanning either from top to bottom, or in the sense you start from the mid-thigh level, go down towards the apex of the popliteal fossa, and go down towards the popliteal crease, or some of them have got the idea of coming in from the popliteal crease and move saphlid, find out the vessel, and then try to get into the 2 nerves, the common peroneal nerve and the tibial nerve. So this is the way the body ergonomics is when you keep the probe, and you move it from top to bottom towards the popliteal fossa. And as in this particular thing, the needle can go in plane from lateral to medial. You can come from medial to lateral, or you can opt for an out of plane technique. If you are an expert, you can really do an out of plane technique with least tissue damage. And also because you have this paraneurium, which is an additional layer which makes it excellently demarcated. When you cross the epimysium, you start injecting, so you create an anechoic zone between the epimysium and the paraneurium, and then you can pierce the paraneurium and go inside, which makes the block perfectly work. So this is an out-of-plane technique that you would like to do. So the high frequency probe, it's kept, and you have chosen a 100 millimeter stimuplex needle. Now you see the drug spread. That's beautiful. So now you've gone below the paraneurium. You see the epimysium, then you see the paraneurium, and you see the drug spread. Laterally is the common peroneal nerve, and then you see the tibial nerve, which is much more larger. So it's a very, very simple block. You just have to go to 2 to 3 centimeters inside most of the time to have this done. You can also prefer to go in the in-plane technique. When a patient in lateral position, you're going in plane. And when you go in plane technique, lateral to medial, one of the points that I would want to keep you in mind is not to injure the common peroneal nerve. So that's because it's very superficial. You can see the needle so very well. And there is the epimysium. You're trying to negotiate it and just going below the paraneurium, and then you will inject your drug. So this is an in-plane technique that you would use. Wherever you do it, I would advocate all of you to go for a scout scan before you place the needle inside, because there are so much of anatomical variations, and you see aberrant vessels which are coming in, which could actually potentially result in a local anesthetic systemic toxicity. So for all the beginners and those who are using ultrasound initially, like in the first few months of using ultrasound, before you push in your needle, make sure you do a scout scan to see if there are any vessels which will be in the path of the needle that you're going to insert. So next, these are the 2 blocks which I thought of great relevance and help for people, because these 2 basic blocks will look after and take care of 2 essential clinical challenges that you will face day to day in your practice. Now, the next 2 blocks which I chose was based on the peripheral nerve stimulator. Again, I chose this because many of the places where you don't have ultrasound, but you have too many geriatric patients coming with hip fractures, which form a huge number of surgical population these days. And then if you want them to make pain-free on arrival, even if you don't have ultrasound in the emergency room or in late in the evening in several units, the machines are not available. So you can go for a simple peripheral nerve stimulator guided femoral nerve block in these patients. So I just want all of you to focus, especially the postgraduates who are listening this talk. There are 2 fascias, the fascia lata and fascia iliaca, and you have to see that on the iliacus muscle lies the femoral nerve on the bed of the iliacus muscle, and the fascia iliaca splits into 2 and engulfs the femoral nerve. And the femoral nerve is actually 2. There are anterior and posterior divisions are present if you go slightly below the inguinal crease. The point that you need to remember that there are 2 fascias, and that's why many of them, when the proponents of the fascia iliaca blind block, they say that you have to have 2 pops. But what I wanted you to visualize here is the distance between the femoral artery and the femoral nerve. The distance is roughly about 1 centimeter between these 2. This is what I would want all the people who are going to use a PNS to understand. And it's a very, very superficial procedure. So now that is the landmark that I would want to see. So you can choose the inguinal crease, just go beneath the inguinal crease, palpate the femoral artery. And now I use my thumb to palpate the femoral artery. The thumb will be at the lateralmost margin of the femoral artery. This point is very important because the artery is a very big artery. Until you know which is the lateralmost part, there are possibilities that when you insert the needle, you may injure the vessel. So you have to keep the tip of your thumb at the lateral most margin of the femoral artery and go 1 centimeter lateral to the artery, which will be the point of insertion of your needle. You can choose a 50 millimeters stimuplex needle and you go perpendicularly inside. Within about 1.5 to 2 centimeters, you keep looking for the contraction of the quadriceps, which will result in movement of the patella called as a patella dance. This is what is required. And so you connected the positive electrode to the ECG electrode. The negative electrode is attached to the stimuplex needle from 1 centimeter lateral to the lateral most margin of the femoral artery. You push your 50 millimeter stimuplex needle inside, start with a current of about 2 milliamps, and then you will see a patellar dance. A point to note, sometimes you see a sartorius contraction, which is because of stimulation of the anterior division of the femoral. If you get it, a majority of the times, the relationship between the anterior and the posterior is the posterior division is posterolateral. So you need to push your needle slightly posterolaterally when you get a sartorius contraction. And the end point is you should get a quadriceps contraction at 0.4 milliamps, and then you can inject the drugs. It's a wonderful block to learn, which will make a tremendous change in clinical outcomes and the kind of pain relief that you can provide to your patients who come with hip fractures. And finally, I will end with a very quick talk on one of the blocks which many people are concerned to give, interscalene block. I've done this talk several times, but I decided to include this block because even today, I find many of them are very concerned about it because everyone thinks there is lot of complications that is associated with an interscalene block. So I will quickly go through this. When you have a peripheral nerve stimulator, I think this is a block for all the dislocations, shoulder dislocations. It's a very, very superficial block, and you're going to push your needle between the scalenus anticus and scalenus medius. And let me explain this with a video, a short video. So this is a patient. You see the sternal notch, you see the sternocleidomastoid, and that's the sternal notch. So that's the sternocleidomastoid, the sternal head, and then you see the clavicle head. Then you see that's the clavicle, and that's the head of the humerus. And you see the external jugular vein nicely. Majority of the time, the external jugular vein crosses the apex of the scalene triangle. So now I want you to see the lateral head of the sternocleidomastoid, and now you start going up from the sternal notch, go and palpate the cricoid cartilage. From the cricoid cartilage, you come laterally. So now you are palpating the sternal head. You further go lateral and palpating the clavicular head. And at this point, you see, this is a very important step. You decipher this point very well. And then from here, you go 1 centimeter further lateral. And that is the place where you will see and palpate both the scalenus anticus and medius and the apex. As I said, the EJB crosses the apex. Just do not bother about that. And you push your needle in such a way just below the apex of the scalene triangle towards the opposite nipple, and look for the contraction of the pectoralis major and the deltoid. And you start with a current of about 1.5, and then you can go down to 0.4 before you inject the drug. So it's a very superficial block. You should not go too deep inside. It's just that you will get it within 1 to 1.5 centimeters. So the end point would be, you see, for a pec major or a deltoid or a biceps. So that will complete an interscalene block. I think in my allotted time of 20 minutes, I wanted to show you 4 blocks of clear clinical relevance to you, more so in this pandemic, to make sure you avoid aerosol generating procedure and you give excellent quality of surgical anesthesia without the need for sedating the patient, losing the airway, and manipulating the airway. I thank all the organizing committee for giving me an opportunity to share my thoughts. Thank you, Sandeep, and thanks, Amit.
Thank you, Bala. Thank you very much for that very informative and just 4 blocks to be done, particularly in this pandemic area. The thing I just wanted to know, and also from the the faculties here, did you mention, if I'm not mistaken, the costoclavicular block for shoulder surgery?
Yes, proximal humerus fractures, I said. So, and also for analgesia purposes in shoulder surgery, we find it extremely useful. A good quality of surgical analgesia is there. But for proximal humerus fractures, we have done it with costoclavicular block with equal efficacy.
Any comments from Gopal, Shiva Sharmagam, Amjad, Rushali?
Can I ask one thing? I have practiced what you have said, the costoclavicular, but especially in the humerus or the elbow fractures, they are so painful to give the position that is ideal for this particular block. What I have landed up hence doing was give 5 ml in the subclavian perivascular area, so that at least the position can be more humane to the patients. And then, having said this, there is a huge concern about why give 2 blocks when there could be done in 1. Now, what is your take? What does the house think about this?
See, it depends. You're right. It all depends upon your ability to slightly abduct, and you're seeing the space. Majority of the time, you're able to see that. If you're able to visualize the space well, I think you can still go ahead and do it.
Because one of the limitations that you mentioned, Bala, was you have to abduct the hand for a costoclavicular block.
Yeah, truly so.
That's what I meant.
No, that's what I. But what I would wanted to convey to you is, if there is a mild discomfort that is present, but still you could abduct in a proximal humerus until you see the space very well. You may not actually do it up to 90 degrees, but most of the times you will. This is a kind of bargain. You do it for preventing and avoiding giving a interscalene block, especially in geriatric population.
Considering the anatomy of the shoulder joint, Gopal and Shiva, you can also comment on this. The joint is supplied 70% times by the suprascapular nerve, which comes from the superior trunk. Do you feel that the costoclavicular block, the solution can reach at that point?
No, actually, not for anesthesia, but for analgesia purposes.
Yes.
Yeah, not for anesthesia. The anesthesia was only for the proximal humerus fracture fixations. And usually it is an anterior approach, proximal humerus fracture. But for shoulder, where you can't use it, then you go for a costoclavicular with good analgesia.
Okay. I'd like to make 2 observations, Sandeep.
Yes.
If I may. One, see, abducting the shoulder, as Rushali said, is a problem in patients with proximal humeral fractures. The second more important aspect is the edema in the vicinity. So when you put your probe there, and you're supposed to be putting your needle in plane with the ultrasound beam, just medial to the coracoid process, I think edema in the vicinity will limit access to the needle. That is one problem. And the second aspect I would like to talk about is the advantage of a costoclavicular block in terms of phrenic nerve palsy is that it is less than 5% or so. And if the phrenic nerve is not being involved, that means the capillary spread or the rostral spread of local anesthetic is not too much. So if the phrenic nerve is not going to be involved, I would imagine that even the suprascapular nerve would not be anesthetized by a costoclavicular approach.
Okay, Shiva, do you have any comments?
Yeah. The abduction is a problem. What we do is we put 3 to 4 ml of local anesthetic in the upper trunk and provide complete shoulder analgesia and abducted and did a costoclavicular in out of plane technique. in a high-risk patients who are obese, short-statured, OSA, where I can't afford to give GA or full interscalene block. So with that, as Bala sir told, the proximal humerus, where they make a delta pectoral incision and put up plates and screws. We did about 10 to 20 cases like this, exclusively under block. We will use an upper trunk injection only to provide analgesia and facilitate positioning. When we have all these precision and objectivity, we can tailor-made our injections. So we put 5 ml there and remaining 15 ml into the costoclavicular. We could provide satisfactorily surgical anesthesia for proximal head humerus. We have done more than 30 to 50 cases in the last 3-4 years.
Excellent, Shiva. That is the point I was trying to make. But
Yeah.
sometimes it's looked upon very skeptically that you're giving 2 blocks to one procedure,
Not at all.
which
Not at
actually
all.
is in favor of the patient's comfort.
Those days have gone. We know where to put it, what we are targeting. We are
Exactly.
utilizing it.
That's the
That's
point.
what. And as TVS sir said, it is a Cornish triangle where the costoclavicular is the neck of an hourglass. So if you inject local anesthetic at the neck, the predominant spread is towards the distal aspect. The proximal spread above the clavicle is less, so the the phrenic nerve involvement is less. But it do extend because both the supraclavicular and the costoclavicular space are in continuity. It is about less than a centimeter above. It still soaks the suprascapular nerve and provide complete shoulder anesthesia. But with 5% incidence of phrenic nerve involvements, the phrenic nerve, I will not say that it is 100% escapes, but the intensity and the duration is not severe enough to produce a clinical manifestation. Maybe if our assessment tool is so precise, we may see that the phrenic nerve is involved in every single injection, but it is not clinically significant enough. That is what I would say.
Sir, can I add something?
Yeah, Ritesh, can you be brief? We have to move on to
Yes, sir. 1 minute. Sir, we have done few cases, high-risk cases with costoclavicular and giving subomohyoid suprascapular block.
Right.
The major problem in this costoclavicular approach is the needling. The visualization, you can do visualization very nicely, but for optimization, since you are tilting the procephalate, so in plane needling becomes a challenge. And for a newcomers, the outplane needling is not recommended because obviously you have got the pleura just below down. So the only maximum problem which I have faced, that's why I am not very keen on doing costoclavicular because the in-plane needling becomes an issue. And I'm not very good in out-of-plane needling. That's why I don't do much of costoclavicular.
Oh, thank you very much, Dr. Ritesh. Bala Venkat, thank you very much for that wonderful presentation on just 4 blocks, which are really mandatory for everybody to learn. You divided into 2 ultrasound and 2 PNS. Wonderful, Bala. Thank you very much.
Thanks, Sandeep. Thank you so much.
Yeah, be here with us till the end. Don't move. Can I have Dr. Gopal? He has to begin with his lecture. Abhijit, are you there?
Yeah.
So Abhijit will be the next. This will be relayed from Prague studio. Dr. Gopal, please. Thank you very much.
Belated good morning to all of you, and again a belated welcome to proceedings on day 2. Gaston Labat wrote the first textbook which was dedicated to regional anesthesia, and this was published in 1923. In this book, Gaston Labat wrote, "Regional anesthesia is an art, remembering that even experts may fail, we should try often and again, observing scrupulously its principles until we succeed." To paraphrase Alon P. Winnie, an in-depth knowledge of clinical neuroanatomy is essential for performing a successful perineural block. But then we do know that the more important variable is a knowledge of individualized anatomy. And there are certain variations in human anatomy from patient to patient and within the same patient from the right side to the left side. Alon Winnie was known for several witty aphorisms, and one of these is, whenever there is a failed nerve block, look for the cause of failure first at the proximal end of the needle. In 1953, Daniel Moore said this: no paresthesia, no anesthesia. And this particular dictum held sway for several years. Then came the era of peripheral nerve stimulation, which is a very important tool even in today's practice. Though it was Lagrange and colleagues in 1978 who first published their work on an ultrasound-guided supraclavicular brachial plexus block, it was not until 1994 when Stefan Cabral and colleagues published their study, a case series of 40 patients who underwent supraclavicular brachial plexus block with ultrasound in real-time motion, that interest in ultrasound-guided nerve blocks began to grow. And by 2007, it was accepted the world over that ultrasound was indeed the gold standard in regional anesthesia. It was not a passing fad, and it was here to stay. The ubiquity of ultrasound has placed core competence with nerve block techniques in the reach of many anesthetists across the world. Yet, despite the popularity of ultrasound, I've been asked to speak on block failures with ultrasound. What next? As I see it, there are broadly two issues. One, modern ultrasound machines do not depict images of that great clarity and resolution wherein we can be able to demarcate the epineurium in all instances. So, with respect to the epineurium, if the needle is placed a little distant, then we risk a block failure. And if the needle is placed within the nerve sheath, we risk nerve injury. The second aspect is that ultrasound machines display two-dimensional images of three-dimensional structures in the human body. Experience will help us bridge the gap between what the eye sees and what the mind perceives. Before we talk of failures, I think we should first define what constitutes success. A successful block, I would say, is one that produces anesthesia sufficient for surgery without the need for supplementation with additional nerve blocks or GA. This is a fairly straitjacketed definition of success as far as nerve blocks is concerned. So for an anesthetist, before we talk of success, we need to talk of the indication which actually defines success for that particular block. Is the block to alleviate pain on arrival in the emergency? Is it to produce surgical anesthesia, which is most often the case? Is it for perioperative analgesia in conjunction with general anesthesia? Or is it solely for postoperative analgesia? So for an anesthetist, a success would include all or most of the following: a good sensory and motor block, a reduced block procedure time, rapid onset, therefore rapid readiness for surgery, no supplemental injections, no unplanned conversions to GA, a sufficiently good block duration, and minimal immediate or delayed block-related complications. So to summarize, the advantages of ultrasound-guided nerve blocking: the block performance time is reduced in experienced hands, there is rapid onset, there is reduced incidence of vascular puncture, reduced local anesthetic volumes need to be injected to produce an effective block, reduces the rate of certain complications, and most importantly, this is an effective teaching tool, and thereby it is reproducible as a science. Today, there is really not much left to be understood as far as the anatomy of the brachial plexus is concerned. So with regard to blocks above the clavicle, blocks below the clavicle, blocks in the axillary region, or when you're targeting individual branches of the brachial plexus, most anesthetists who are regional anesthesia enthusiasts know the neuroanatomy of the brachial plexus quite well. Bala just spoke about this. When the costoclavicular brachial plexus block was introduced in 2016, it was received with a bit of disbelief and consternation. But in the past few years, this block has gained great acceptance, and it definitely translates into success. This was again a landmark publication by Manoj Karmakar and colleagues, which left no one in doubt as to any mysteries with regard to neural elements of the brachial plexus above the clavicle. It is because of this sort of an understanding that today we are able to perform intertruncal approach to supraclavicular brachial plexus. Siva spoke about it this morning, and we can now target the trunks in the supraclavicular area individually without risking nerve injury. Therefore, it is reasonable to claim that we have a near 100% success with ultrasound-guided blocks in the upper extremity when performed by an experienced operator. As far as peripheral blocks of the lower limb are concerned, ultrasound guidance translates into a near 100% success when you're talking of superficial blocks such as the femoral nerve block or the popliteal sciatic nerve block. But when we talk of deeper blocks of the lower limb, such as say the lumbar plexus or the sacral plexus, images of such great clarity, what we call textbook images, will not often be seen in clinical practice. That is why, in an effort to curtail failure rates and improve success, we go for a dual modality. That is, we combine ultrasound with peripheral nerve stimulation. The dictum of an ultrasound-guided nerve block is to place under vision a needle in the vicinity of a nerve or plexus so that transmission from the nociceptor to the dorsal root ganglion, the dorsal column, the spinothalamic tract, and thereupon the sensory cortex is blocked. The patient is rendered insensate along the distribution of the targeted nerve. Interfascial plane blocks challenge this very dictum. With these plane blocks, we are asked to place large volumes of local anesthetics into interfascial planes. These could exist between contiguous muscles, a muscle and bone, or a bone and ligament. On the left is the classical tap block, which was the first plane block that became popular with the advent of ultrasound. So the needle is placed here in between the internal oblique and transversus abdominis muscles. We place about 20 mils of local anesthetic in adult patients here with the knowledge that certain lateral cutaneous branches of intercostal nerves that course in this plane will be blocked. On the right is an image which depicts the PEX block. This is the PEX1. So we place the needle here in the plane between the pec major and the pec minor in the vicinity of the pectoral branch of the thoracoacromial artery, knowing that the lateral pectoral nerve and the medial pectoral nerve course in these planes. So as far as these two blocks are concerned, the understanding is crystal clear. Now, in the picture on the left, you have the PEX2. You have a needle here which injects local anesthetic between the pec minor and serratus anterior. And with this particular approach, analgesia breaks through the axillary door. This is because the clavipectoral fascia communicates with the suspensory ligament of the axilla, which is also called the Gerdy's fascia. So here, the site of injection is not the actual site of action. Now, on the right is the quadratus lumborum muscle, and depicted are various approaches to the quadratus lumborum block. Now, here too, when you perform the block in the lumbar region, the drug ascends rostrally along the thoracolumbar fascia and makes its way into the thoracic paravertebral space. So here again, the site of injection is not the actual site of action. And as you can see this very busy slide, as Rafa spoke yesterday, there are so many different approaches to the chest wall block. So life has become very, very complex with the introduction of interfascial plane blocks. And now this is the darling block and the flavor of the season. And this is the erector spinae block that was introduced into clinical practice in 2016. As shown here, the needle makes contact with the transverse process and the drug is injected so that this sort of spread is seen in between the erector spinae muscle and the intertransverse ligament. Today, as I said, the ESP has become the flavor of the season, and it is being offered as a panacea for all surgeries extending from the neck to the knee. But then again, if you ask anybody, do you know exactly how the erector spinae block works? No. There are several hypotheses, but then the exact mechanism of action when you deposit drug in that location, nobody really knows to date. So I dare say, at the risk of incurring Rafael Blanco's wrath, that most disappointments or failures are with interfacial plane blocks, which are not meant for surgical anesthesia anyway. What is the optimal target site for injection? Not too clear when it comes to blocks such as quadratus lumborum, where there are so many approaches. And with certain of these blocks, for example, the quadratus lumborum block, the drug spreads from point A to point C through point B. But there are so many factors that govern the spread of local anesthetic. And even assuming that the local anesthetic has spread from point A to point C, that may not translate always into a good analgesic block. And what is the optimal injection endpoint? We do not know. That is why we have so many different types of chest wall blocks, all to block one intercostal nerve or a series of intercostal nerves. And correct me if I'm wrong, Abhijit, as far as I know, there is no definition of a failed plane block in literature to date. This was an article that was published in 2010 by Peter Mahafer and colleagues in the BJA. And in this article, the authors predicted that in the next 15 years, there would be rapid strides made in ultrasound technology. Over the next few slides, we will look at how we can harness this technological advance to curtail block failures and improve success. From highly pixelated images with poor feature discrimination, ultrasound machines have moved on to presenting high quality, high resolution images such as this. Now here you can see that this is C5. These two hypoechoic rings are C6. This is a muscular slip that is between C6 and C7. And C7 lies close to the vertebral artery, and this is the posterior tubercle of C7. So with such high definition images, there is little left to imagination, and this would definitely translate into higher success rates and lesser failures. The ultrasound grayscale image is generated when the reflected sound waves from the structures that are being imaged are captured by the transducer, and this causes the piezoelectric crystals to vibrate. This grayscale image has some interference sometimes from speckle, noise, and refractive shadows. So modern ultrasound machines have certain technologies incorporated with an attempt to optimize the ultrasound display. Tissue harmonic imaging is patented by GE. Harmonic is nothing but a multiple of the fundamental energy, and the harmonic beam lies in the center of the beam. So if this portion of the ultrasound beam is utilized to project the image, then you would expect an image of much greater clarity. On the right, you see that there are multiple ultrasound waves that are imaging the structure so that they present a composite image, which is definitely better in resolution when compared to the image on the left. Speckle is something that crosses a granular interference with the grayscale image. So this is a speckled image, and this is a much better image in which the structures are homogenized for a better display. Modern ultrasound machines have adaptive speckle filters that work in the background to convert a speckled image into a homogenized image. But with this particular machine, you have a choice of either selecting this or taking this off. What about ultra high frequency ultrasound? This is available with the Sonosite Vivo MD machine, and many other manufacturers are also coming up with ultra high frequency probes. Now, this probe goes up to 22 megahertz. This probe goes up to 48 megahertz, and this probe goes up to a whopping 70 megahertz. So if you see the median nerve at the wrist, this is the image that you get with a routine 15 megahertz probe, and this is the image that you get with a 70 megahertz probe. So not only can you see the epineurium that surrounds this particular median nerve, you can also see the fascicles and the inner epineurium that lies in between the fascicles. At this point of time, ultra-high frequency ultrasound is a very good point of care diagnostic tool to assess the integrity of nerve fascicles and the intima of vessels in patients with hand trauma. And I believe that this would be an exceedingly good technology to use for superficial structures, because higher the frequency, lesser would be the depth of penetration of the ultrasound wave. Now, coming to 3D images. The currently available ultrasound machines give us images in 2 dimensions, the transverse axis or the sagittal axis. The third axis is the coronal axis. So if you have an ultrasound machine that will give you an image in all 3 dimensions, the transverse, the sagittal, and coronal, then that becomes a 3D image. But the problem with 3D technology at this particular point of time is that these are curved transducers. They are quite bulky. The frame rate is low. Therefore, these machines will reconstruct your volume of interest and then present a 3-dimensional image such as this. So this is not an image that you will see in real-time motion. If you were to be able to see a 3-dimensional image in real-time motion, wherein the 4th dimension is time, that becomes 4D imaging. Philips is now introducing this linear transducer for the first time, which is a 3D linear transducer for 3D images. So what 3D and 4D will do to the practice and improve our practice of nerve blocks as we go ahead remains to be seen. Manufacturers of echogenic needles, they do nothing else but actually alter the passivation layer of the needle insulation so that these needles are picked up better and are more visible on an ultrasound screen. There are certain needle guidance system as this one, which is a fixed guide, which is attached to the probe. This is useful for biopsies and central venous cannulations, but not for nerve blocks wherein we need to have a free hand motion. On the right, you have a laser emitting device that's attached to the transducer. It throws a laser beam, which creates a simulated path that your needle can take. Now, this is a magnetic field generator that is attached to the Sonic Touch GPS machine, and these probes are tracked. So while performing a block, this particular machine will throw a simulated path that the needle should take, and that is the actual needle that is approaching the target over there. Now, in this particular needle, there is a piezoelectric crystal which is embedded towards the tip. And when this needle is aligned with the ultrasound beam, the tip is highlighted by a green circle. And here you cannot see the needle because the needle is not totally aligned with the ultrasound beam. So here you will still be able to pick up the tip, but this is circled in red. This is a dedicated nerve block robo, which is called the Megalan system. You can see here that the assistant is holding the probe, whereas the operator, by using this joystick, will perform the ultrasound guided block through this robotic arm. This is frightfully expensive at this point of time, and when robos will replace anesthetists, as far as nerve blocks are concerned, is something we need to see, hopefully not during my lifetime. And to conclude, whenever we are faced with a failure, we need to be going back to the basics. The foundation of experience, which translates into success, is failure. While we aim to achieve excellence, we must keep in mind that success is not final, that failure is not fatal, but it is our ability to give off our best in all circumstances that matters most. So thank you very much for your attention. Over to you, Abhijit.
Thank you, Gopal. Thank you very much. You have taken us to the next level. Now, since we have been in ultrasound era for more than maybe 20 odd years, maybe 15 years. So what's your this thing like progress in ultrasound? Like we started with the handheld sonocyte, and then we started with Titan, then we shifted to Turbo. So how far we have reached?
We've come a long way, Sandeep. Do you remember in 2006, you and I were in Armed Forces Medical College, Pune?
Yes, yes.
Where we performed ultrasound-guided nerve blocks live for the first time.
Live, yes, yes.
And as far as I was concerned, Rushali was there also. I was doing an ultrasound-guided blind block. I had no clue what I was doing.
I know.
So, I mean, in these last 14 years, I think we've really progressed. I mean, not only have we progressed, but even ultrasound machines have made a great improvement. I remember you used to own a Titan. That gave way to the Micromax, and that was replaced by the M Turbo. And now we have the expertise which a rich man like Shiva affords, and the not so rich people like Bala and I have a downgraded version of the Exporte. And the same thing would also apply to several other manufacturers. So in terms of technology, ultrasound has definitely made huge strides in the last 15 years. And the addition of ecogenic needles has definitely made life much easier when you're doing blocks in plane.
Yeah.
And at the same time, there's been an explosion in terms of teaching avenues. So we've learned so much by participating at clinical meetings. And that is added to our knowledge. So yes, Sandeep, in the last 15 years, we did advance quite a bit.
So Gopal, do we come out with some article regarding this? Because we have been through all these things. You, me, Rushali, and Bala, Shiva, Amjad can also join us, Amit as well. So we can come out like 15 years of ultrasound, what you had depicted on your slide regarding one article. Why not make it through India as well?
Sure. I mean, that has been Rushali's passion for years.
Sandeep, sorry.
We will
try
to.
Yeah, Rushali?
Sandeep, do you remember the first ultrasound guided workshop was conducted in Mumbai, and it was Dr. Lakshmi Vas and me, and you had come in spite of torrential rains and all the trains were cancelled, and we had done it on pigs in Johnson & Johnson.
Yes.
That is how it got initiated, and I was totally surprised that you could come when all the trains were shut down.
Yeah.
That is how it all initiated. That's how then me and Gopal came to know each other, in fact. So
yes.
It's given us great friends as well.
Shiva, I have got a question to you.
Yeah.
You use the spinal needles, isn't it?
Yeah.
Many a times. But you use the most modern ultrasound machine. So what's the reason of this disparity between a very, a high-end ultrasound machine and using those spinal needles? Why don't you use the echogenic ones? What's your take on it?
If you remember the image what I have shown in sciatic nerve, in an electron microscope, the 22 gauge tip and the size of the fascicles.
Yes.
There is nothing that we can place in between the fascicles because the size is so big. So when the technology become advanced and you can see more precisely the targets, so automatically it is an evolution, your instinct that you will go more and more finer. And especially when you go below the fascia, then it is all the more important to use the smallest gauge when you could see it. When you're not able to see it, of course, you're not going to do it.
Right.
So understanding the size of the tip of the needle and the fascicles, the size of the tip of the needle is bigger than the fascicles. So, and when I can able to see with an advanced engine, it is an automatic evolution to go on a smaller size, make it more precise. So, which is invasive, you're going in between and injecting 5 ml or injecting 30 ml without seeing, the time has to tell us, and we don't know which is really safe. And we are cautiously looking at it. That is what I would say.
Yeah, because we also mentioned this in the Scud block as well.
Sandeep, if I can interrupt, Shiva is not telling you the actual reason. He spent so much on the ultrasound machine, his institute is not buying echogenic needles for him.
True. That's totally gone. Only for a deeper block we are thinking about it. Otherwise, the utility for superficial blocks is literally not there. True.
Okay. So can we move on to the next lecture, Gopal and all the faculties? Yeah. So I would like to introduce Dr. Abhijit Nair. Now, Dr. Abhijit Nair is... So Dr. Abhijit Nair, he's like a mentor to me actually in considering the research area, which I used to lack. So I thought I should hold on to somebody else. So he was a person who said that you could publish articles, and you could be in research area. Now he works in one of the Indo-American Cancer Hospital in Hyderabad as a consultant anesthesiologist, has more than 90 publications with 250 citations. His area of interest is acute pain and regional anesthesia. He works more in onco anesthesia and does a lot of medical writing. He's a reviewer of IJA, JOACP, Journal of Pain Research, BMC Anesthesiology, and Frontiers in Pharmacology. He is also instructor for essential pain management, and which is endorsed by WFSA, and is a faculty of pain medicine of Australia and New Zealand College of Anesthetists. So I think his lecture is already recorded here. So
Thanks for registering for PAC 2020. As you can see, the topic of my presentation is rejection of article, what next? Well, I believe everyone who have registered and attended have heard many of the esteemed faculty speaking about various kind of regional anesthesia techniques, what's new in that, what is the correct way of doing that, how to go about that. I'm sure after learning from all the big shots of regional anesthesia in India and abroad, everyone would try to implement it in their regular practice starting from Monday. So that's how the scope of this presentation comes. Once you start practicing things, you might end up doing a good number of case series, an RCT, or use it for some totally different indication. And that's how you will end up writing a paper and eventually submit it. If you submit it and it gets accepted, well, congratulations. Otherwise, what you face is rejection. And that's what I'll be talking about in the subsequent slides. Yeah, when I searched Oxford Dictionary for the meaning of rejection, I'm sure everybody knows that, but I was a bit enlightened further. It's a noun which means the act of refusing to accept, use, or believe something or someone. There are many things that we are not taught in our medical school, and one of them is medical writing, a systematic way of writing for medical literature. Basically, we do it for our thesis and all, but somehow we are not adequately or properly trained in doing so. And this is a notion which is now everywhere in India and abroad alike. You publish or you perish, which means unless you publish something, you don't grow in your department, in your faculty, in your fraternity, and thus you don't get promotions, you don't get pay hikes, and you are no longer considered a figure to reckon with in your specialty. So that's why this dictum, publish or perish. Well, the current situation in our country and maybe in several countries is like there's no training in medical writing. Somebody who is interested is not very much sure or doesn't know what types of manuscripts they can write. There are no mentors. The purpose is not very clear. There is lack of interest. And last but not the least, which is actually common in many places, there's no clear support. One good thing is the Medical Council of India has recently made it mandatory for all the postgraduate students to they don't have that certificate earlier. If it is a specialty journal. By specialty journal, I mean if you're talking about regional anesthesia, a regional anesthesia journal. But as we all know, there are very few journals which cater exclusively to regional anesthesia, although there are many anesthesia journals. So what you should find out is your area of interest, whatever you are planning to do, whether it is such kind of papers frequently gets published in a particular journal, go for that. Rate of acceptance is very important. Let me give an example. A journal has an acceptance rate of 4 to 5%, which means 100 papers per year, only 4 to 5 gets accepted. So maybe unless your work is exceptional and you have great confidence in that, don't waste your time in submitting that. There are hundreds of journals available all over the world. Selection of topic is very important. Once you plan to do something, do a PubMed search or a Scopus search or a Google Scholar search to find out if there are similar studies, whether the studies have similar methodology, what is different in your study. That is very important. Your research question should be proper. It should be up to the mark, and don't end up over-interpreting your data. It should be, your data should be interpreted, or your results should be interpreted with caution. Once you finalize the journal, the instructions are very important. Every journal has different set of instructions. For example, you take RAPM, you take DGA, you take Journal of Clinical Anesthesia, you take Indian Journal of Anesthesia. Everybody have a different way of instructions. Their abstract word count is different, introduction splitting is different, methodology, some they want it in subsections, some they don't want. There are fixed number of words for which you should be writing. So that is very important. Once such a paper gets rejected from one journal, don't submit it exactly in the same way to the other journal. Read the instructions, make appropriate changes, and only then do that. There are a lot of word count is very important. Don't pour your heart if you are very much interested, or if you do something very well. Don't just keep writing and writing it. You will definitely cross the acceptable word limit. So be right to the point. Abstract is something which is very important because it strongly influences an editor's decision to accept and a reader's decision to read. Unfortunately, everyone writes the abstract at the end. It is sometimes written casually, lazily, hurriedly. So what happens is they end up writing long sentences. Sometimes it doesn't make meaning. There will be grammatical errors. Some journals, they require abstract to be structured in separate sections. So even that is not done. One good thing about abstract is it is free. So everyone, even if it's a paid journal, everyone can have an access to the abstract. So abstract, spend time and write a decent and a good abstract. There, I'm not sure whether everyone knows about it, but this is Equator Network, which gives guidelines for writing separate papers of different categories. Basically, Equator stands for Enhancing the Quality and Transparency of Health Research. As you can see in this slide, there are 432 reporting guidelines, which includes RCTs, observational studies, systematic reviews, study protocols, case reports, series, qualitative research, animal research, etc. Once you plan what category of manuscript you are planning to write, you can search a particular reporting guideline and then draft your manuscript accordingly. Once you plan to do an original study, you should always make your research question in a PCOT format. PCOT stands for P is for population. The research question should define the population. It should define the intervention that you are planning. It should define the comparison group or the standard of care. It should define the outcome that you are looking for. It should also mention what kind of study you are planning to do. Review articles are usually written by experts and it is usually solicited by the editorial board. But if you have something in mind that you are doing a particular category of cases or a type of technique and you want to write a review article, and you have gathered all the available literature on that, I would suggest contact the editor-in-chief first and take an approval from the editor. But before that, do your homework. Basically, look for what kind of review article you are writing. Is it a narrative review? Is it a systematic review? Is it a meta-analysis? Based on that, plan your review article and write to the editor accordingly. You have the Prisma statement, you have the Prospero network. If it is a meta-analysis, it needs statistical analysis also. So everything should be planned and written. Introduction is very important because in introduction you have to write what is known, what is not known, what you plan to find out, what is the rationale of the study, what is the purpose of the study, and what is your hypothesis. All these things should be there in the introduction basically. Otherwise, again, the editor or the reviewer loses interest. Methodology is supposedly the most important part of the research manuscript, because if the methodology is not up to the mark, it leads to rejection of the manuscript upfront. There are a lot of points which should be there in the methodology, which includes ethics committee approval, registration of the trial, inclusion and exclusion criteria of the groups involved, randomization technique, intervention plan, sample size calculation, statistical methods, etc. So all these things should be covered in methodology properly. The design of the study is important. The design should be novel. So we find problems at times drafting a manuscript in English, but what is important is your manuscript should be grammatically correct. It should not have high-end English that you usually hear in English movies or you're reading novels. It should be grammatically correct. To help, in case you still struggle with your manuscript, you can take colleagues who are good in English. You can contact your friends to review your paper. And there are several softwares available like Grammarly, and there are other paid softwares like AGE and Editage. These are the softwares which can help you in preparing a grammatically correct manuscript, but these are all paid. Plagiarism is considered unethical. Plagiarism means you have taken, copied and pasted from other paper without giving any kind of credit to that. So whenever you write a manuscript, submit a manuscript, the journal editors, section editors, they do a plagiarism check using paid softwares like Authenticate, Turing Team. But I would suggest you should do your own plagiarism check using free software like Plagiarism X and small SEO tools which do the check for up to 1,000 words at a time and gives you a report also. So you have a fair amount of idea. So once you have done your written your methodology and now you have your data with you, now time is for statistical analysis. The statistical method should be appropriate. I mean, for categorical data, for numerical data, for continuous data, it should be properly used. I would suggest involving a biostatistician if you are doing a research article right from the beginning and take his or her help. Never over-interpret or wrongly interpret this also can. If you use a biostatistician, it will help. Don't fabricate the data. Don't put wrong numbers, because idea of research is not to prove what notion you have in your mind. Idea of research is to find out whether what you are doing, whether it is really significant or whether it is equal or equivalent to what is the standard of care. There are a lot of statistical software available, SPSS, which is usually used, data, and R usually is used for meta-analysis and systematic review, but can be used for original articles also. I usually use GraphPad Prism, which is free, and all the basic statistical tests can be done easily over there using a GraphPad Prism. Review of literature is what you write in discussion, basically. So there is, when you do the review, you should use the latest references, not more than 10 years of old, unless absolutely essential. Some journals, they allow usually not more than 5 to 10% of old literature, basically. There is a style of citing references. Every journal has it different. Some journal has it as a superscript, some journal has it as superscript in boxes, some without boxes, some journal have it along in the same line as you write the text. So you have to read the instructions and do it accordingly. And most of the journals, they have it in Vancouver style. So Vancouver style means the references appear in the manuscript in the order. You write the references in the order they appear in the manuscript. There are a lot of reference helping reference managing softwares like EndNote, Zotero, Mendeley. You can use any of them. Once you are a regular writer, you will know the importance of this, basically. Now you have written everything, your paper is ready, and now you have decided the journal, where to send, what to do now. You have submitted, and the editors and reviewers, they reject your paper. So what next? So basically, this initial part, I wanted to tell you what you should do right so that the chances of rejection are less. From here, I would discuss what to do if the paper gets rejected. Firstly, you should read the decision letter very carefully. Some editors, they make it a point to mention each and every flaws and fallacies of your paper. Take it with a pinch of salt. From the moment you get a decision letter, make a plan changes, identify reasons for rejection and flaws. These are the common comments when, like, a busy journal where the editor has to reject so a lot of paper, somebody which has a 90% rejection, they usually write such one-liners. As you can see over here, it's an interesting and unusual case. It does not act significantly to the subject. This is neither a systematic nor a comprehensive review on the subject. Or unfortunately, this is the most common one from especially the European journals. Unfortunately, we are unable to accept a few of the numerous papers that are submitted, and we regret maybe we could accept your paper next time. So once you start redoing your paper, discuss with your colleagues, with your friends in your institute, in other institute, discuss with other specialty friends also, discuss with your seniors, teachers, or you could identify somebody who is a regular in publishing in the area of your interest. You can contact him or her and take your help in reframing and redoing your manuscript. There is something called as bias in peer review. But this bias is nothing but a violation of impartiality in the evaluation of a submission. It is very difficult and to detect and quantify it. There are a category of reviewers, I believe, who outrageously reject a paper if they are doing a similar research. So bias is at 3 levels: before, during, and after the review phase, basically. So before is when, at the time of selection, like you are given a choice to select, or editor doesn't identify a proper reviewer for a paper. During the during phases, the editor has been identified, but somehow that reviewer is not very much well versed with the technique or the study that you have done basically. And after is a category of reviewers. I'm not sure whether such category exists, but I have taken that from a paper which was published, who delays or stalls a particular publication because they have something similar coming very soon. Now, I would like to give a couple of examples, not many. This is a paper by Dr. Diwan, which was published last year in Indian Journal of Anaesthesia. He had discussed this paper with me. I found it very interesting, a contrast study, CT contrast study involving quadratus lumborum block in nephrectomy patients. I found it very excellent, and we decided to send it to good international journals. So this was the journey. It was rejected from certain journals citing a valid reason, and from certain journals citing really silly reasons. I am sorry, I cannot mention that over here. But eventually we managed to submit it to Indian Journal of Anaesthesia, and we later on found out that this was one of the first radiological, CT contrast study involving a block, and it was accepted with minimal changes. And we were very fortunate to have an editorial accompanied in that edition by none other than Dr. TVS Gopal sir. It was a very good editorial written by him supporting the contrast study done by Diwan et al. This is one of my papers. I had written it as a viewpoint regarding dexmedetomidine in cancer surgeries. It's the problems with its use. I had sent it, wrote to several review editors of good journals asking them permission whether I can submit. I never got a reply. I sent it took a chance and submitted it to a prestigious Indian Journal of Cancer, where I was surprised. It was given an upgrade. From a viewpoint, it was converted to review article directly, and right now it is ahead of print, might come next month. So that is what I want to say. If your paper gets rejected, don't get rejected. There are a lot of options. Just improvise and plan to submit it sooner or later. So coming to the common reasons of rejection, most common reasons are as follows. They are not well written, they are grammatically incorrect, they are not as per the instructions of the journal. There are a lot of ethical issues that have not been sorted out by the authors. It is not within the scope of the journal. The conclusion is not up to the mark. There is no correlation between aim, result, and discussion. Hypothesis is not clear. The manuscript has nothing new to offer. There are a lot of similar papers in the databases, and it is heavily plagiarized. This one reason or several reasons put together are the common reasons of rejection of a paper. Now, as you can see over here, a lot of examples. You can see Steve Jobs, you can see J.K. Rowling, you can see Elon Musk. They were all rejected in their life, but now we all know what they have achieved in their particular field of interest. Basically, they are big names. So I would say take rejection with a pinch of salt and just try to improvise things, and don't become like the fellow which you see on the right upper quadrant over here. Don't try to become like that. So to conclude, when your paper is rejected, read the rejection letter carefully. Contact your friends and colleagues. Do a plagiarism check again. Reanalyze your data. Discuss with friends, seniors. Select the journal subsequently in a proper way. Read the instructions of that particular journal in detail. I suggest this point to join as a reviewer to many of my friends, because once you join as a reviewer, you get a lot of papers to review, and at the same time you also get to see what other reviewers write in comments. But that really helps. You see people writing in different way and other reviewers commenting on that. So it really helps you grow as a researcher and as a medical writer. And as far as possible, use latest references. Would like to end my presentation by quoting this by Mark Ament. Rejection doesn't mean you aren't good enough. It means the other person failed to notice what you have to offer. Thank you.
Yeah, thank you, Abhijit, for that wonderful presentation. And just for the audience, that we have an academic team actually, who along with Abhijit, we have two more, Dr. Divya from AIMS, and she was Sharmagam's fellow. She's with us, Archana, and we have a research analyst as well as we have a statistician. So we all form a team actually. And Shiva Shanmugam's team is equally very academic at the forefront. Any comments, Shiva Shanmugam? And then we have Arunangshu, and then we wind up with my lecture. But before that, we have a 5-minute presentation from Sona side. Thank you, Abhijit. Thanks a lot.
Thank you, sir.
Yeah, Shiva Shanmugam.
Yeah. Thank you, sir. I mean, usually when the article gets rejected, we will look at, is it because of the content issue or in the process? I mean, when we submitted, if there is a process, we are not meeting the guidelines of the journal, okay, that's fine, we can work on it. But if there is a question on the content, you have to look at what you wanted to say. And if the reviewers has got any different viewpoint on that, then we can take it. If it is very relevant that what you wanted to say, but how they are looking at, then we can work on that. Sometimes, as Abhijit said, if the reviewer has got not any experience, if you blindly comment, you should not keep on changing your write-up. So there we should stop and then look for some other journal. So you have to take it very cautiously, and you have to look at critically the reviewer's comment and then see, are they really guiding us? If that is there, then you can change your script. If it is not, you should look for some other journal. You don't change on your own methodology and what you wanted to tell about it. So that's what I wanted to just simply say. Thank you, Abhijit, for bringing a nice...
Yeah, point taken, sir. Thank you.
Yeah.
Abhijit, very good presentation.
Sir, thank you.
That was a great presentation, Abhijit. Very good.
Can I ask one question?
Sandeep sir, if you allow, I can add a few comments here.
Can I? I'm lost. I don't know. Should I wait?
Yeah, go ahead, Roshali. You go ahead. Can we ask?
Tell me, if a person wants to pick up a topic, how does the person be very, very sure that the research question is the one which they should be working on?
I didn't get you, madam. Can you say that again?
How to make sure that the research question you are asking is the one which a reviewer will or a journal will take? How to make it very sure about?
I had showed one point basically. It could be anything. It could be comparing a standard of care with a new technique, but it should have those 5 points. PICOT. Your question should involve all those 5 points. But before that, before planning a research question, you should do a comprehensive search of literature, like whether there are similar papers with similar methodology. If it is there, then you stand a lesser chance of going ahead basically. Unless you have something different to say, some different concentration, some different volume, some different indication, or a properly calculated sample size. Unless, I suppose previously there's an observational study which is limited by the sample size basically. Now you are doing a proper study with ethics committee approval and all, and you are framed your question as per the PCOT format. You have a chance, madam. I mean, you have a chance to proceed, make a question, and start recruiting your patients subsequently. I hope I have answered your question, madam.
May I add something?
Yeah.
Hello, this is Dr. Neha from Bhubaneswar.
Yeah,
sir, thank you, Abhijit sir, for such a nice presentation and outlook.
Yeah.
Regarding the ma'am's question, research question can be based on finer. This is a mnemonic for finer. Like it should be feasible, it should be interesting, novel, ethical, and relevant. Hypothesis will go by PCOT, that is population, intervention, comparator, outcome, and T is for time frame. So we can go for the whatever we are coming in our mind, we can go for a search that whether the things are going on somewhere, and we can search even the trial registry that some trial is going on. It used to happen so many times that things coming in our mind are already being taken care by somewhere else.
Arunangshu, can you briefly take on your question or comment?
Sir, I have basically two things to add. First of all, I would like to tell all our audiences that it is the clinical research that matters, that should be published. First of all, publication should not be the goal of doing a clinical research. So I would like to add here that Binting and West, they had only one publication, and that was a discovery of insulin. That was their only paper, and they got Nobel Prize for that. So the point that I want to make is that our purpose should not be publication per se. Purpose should be to find out solution to an existing clinical problem. So that should be the goal of the research, to find a solution. And if the solution is good, it will be published. It will be published in somewhere, somehow. So that is point number one. And I think, Abhijit, congratulations to you. You have covered most of the parts very well. So point number two is that nowadays, because of many regulations, doing a clinical research RCT is very difficult. So we can put some more focus on doing audits and retrospective audits, because RCT, there are a lot of ethical concerns coming up and IRP regulations coming up. So it may not be always feasible, and many times RCT that we conduct that end up being underpowered. So unless you can conduct a well-powered RCT, you can also try doing a retrospective cohort audit, which is easier to do, and it can find the answer to the problem that you're looking at.
Yeah, Arunakshu, this is the same thing that we did in the COVID era. We tried to audit and do a retrospective studies until we get clearance from the ethical committee for further randomized controlled trials. Right. Anyway, the cases are on a decline now, so it's very difficult to get the cases too. Shiva, what you mentioned about the upgradation after a rejection. So in one of the articles which was reviewed by one of the journals, myself and Abhijit, we put a lot of efforts into it. We reviewed once the reviewers put their inputs, and we updated and upgraded to such an extent that we never thought that we would be coming out with such an article. We learned a lot of this. Now, when we uploaded to one of the journals, only to get rejected from that particular.
Yes, yes. So that we know what is the viewpoint of the scientific community. Once we write, it is only our view. When it reaches the high critical reviewers, then we will have a different perspective. So that give us a lot of understanding for us how to project our data. So that is what we should take up.
Sometimes, but Shiva, even if it got rejected, yes, we had put in so much efforts that we were so much satisfied with the content that we came out with.
Yeah,
that we did not mind that it got rejected.
True. I mean, we are learning. That is also a learning process.
Yeah. Any other questions, Dr. Gopal?
No, nothing at all. That was a lovely talk by Abhijit.
Yeah, anyway, he has.
Okay, Sandeep, so when is AORA going to see its own journal?
Yeah, we will soon.
Know that associate editor is Abhijit, so it's in good hands, and of course Sandeep here is at the helm.
No, we will come out with it, Roshali. The next month we will do a meet again. We'll meet again for the IGRA. I know that it's pending. We wanted to do it right now, Gopal, but I'm sorry we could not go ahead with it. But we will come back all again on webinar, and we will do the IGRA thing. It's pending. Now, Mr. Hitesh is going to present a 5 minutes presentation on Sonosite. And if you don't mind, I will be doing the last lecture. I hope you all will wait to listen to it.
Yeah, sure, sir. Thank you so much. So I hope I'm audible and my screen is visible, sir. Yeah. So good afternoon, everyone. My name is Hitesh Singh. I'm the Senior Product and Marketing Manager for Fujifilm Sonosite MTV. And I'm deeply grateful to the entire Prague Society for providing us this opportunity to interact with you today on this platform. So now I would like to quickly navigate you through our journey and endeavors in the point of care space. So we are proud to say that we are the innovators and world leaders in the point of care ultrasound segment, and we are also the industry leaders in the ultra high frequency micro ultrasound technology, which Dr. Gopal mentioned about the Vivo MD. So our products are also used in the preclinical research purpose for that. Our head office is in USA. Sonosite became the wholly owned subsidiary of Fujifilm in 2012, and now we have more than 10 subsidiaries and more than 100 distribution network all across the globe. So basically, our North Star is that we want to empower the clinicians with the immediate answers to provide assistance to any patient, anywhere, anytime. So more than 2 decades back, we revolutionized the ultrasound technology, and we devised the first ultrasound machine which can be employed at the point of care environment, right? So it was basically used for the first machine was used for the US military purpose, from where which we derived the values for the hospital settings. And so like fluid resistant, seal, keyboards, our machines are quite rugged, reliable and responsive. So this is our current range of products. So this is like a tablet-based model. So it's like a quick look solution IVIS. M-Turbo, it's our versatile value clamshell model. It is also available in the reconditioned format. So to cater the needs of our price conscious or the budget constrained customers. S2, this is our zero footprint model recently launched with a touchscreen interface. It can be used wall mounted, ceiling mounted, or as a trolley mounted option. Then another, we have a premium clamshell model called the Edge 2. And then this is our flagship model Exporte with the inbuilt learning 3D tutorials. So, and all these products are made on 4 brand pillars, which are easy to use, reliability, education, and durability. So this is the product which I was talking about. So this is totally splash resistant, touch screen console, can be used wall mounted, ceiling mounted, or as a trolley mounted option, 1 meter drop tested, and with like around 2 hours battery backup. So all our products, most of the products are covered under 5-year standard warranty, and we have the service loaner facility also available, which is subject to PNDT permission if something major breakdown happens with your system. So this is the point of care ultrasound. It is basically like a Swiss knife army, which can be deployed at the different departments in the point of care scenario. So our machines are used in more than 21 medical specialties. I have mentioned few over here. So focus can also be utilized for doing the procedural guidance, which I think like all the topics have covered for doing vascular access, nerve blocks, cavity drainage. This is the core of Sonosite, like why you should opt for Sonosite, because we provide the entire solution. Our systems are the best fit for the point of care scenario. So drop tested, sanitizable, all the complete educational offerings are available, and our all products are made in USA. And like sir was mentioning about technology, so tissue harmonic, speckle reduction, compound resolution imaging, all those technologies have been incorporated in our systems. We provide complete online as well as on-site training solutions for our end users. So this Sono Access, this is free of cost mobile app, which is free to download on both Android as well as Apple platform. Sonosite Institute, this is a website available exclusively to our end users, having the extensive training modules, reference materials, right? So you need to have a Sonosite serial number to access this website. And then now we have a e-format for the visual medicine program, which is our standardized global training program. We have a good install base all across India and neighbor countries. This map is slightly older. So now we have more than 3,500 installation across all reputed government, corporate, private institutions. So the focus helps in improving the quality of care, the patient satisfaction, and it also helps the healthcare systems to improve efficiency and reduce cost associated with the clinical malpractices. So this is our dedicated COVID page. If you are looking for any COVID related training material, information on cleaning and disinfection, or you want to have access to any white paper, so please go and explore this link. So you will find all the extensive comprehensive training material available over here. So configuration, if you are looking for COVID scenario, then I would recommend that at least you should have 3 probes, the cardiac probe, the convex probe, and the linear probe, right? And you can opt for any of our systems along with the stand or without stand. So ladies and gentlemen, the future is here. Our machines are not confined to the indoor patient environment, but it is being extensively utilized for air ambulance, for sports medicine, for seeing the marine mammals. Our machines are being used in the submarines, in the race courses. So there is no limit to the technology, especially to the point of care segment as well as for the field requirement disaster scenario. So we don't believe in selling boxes. We believe in providing complete solutions for our customers with the highest degree of confidence. You want to explore more about Sonosite, please drop an email to ffss-india@fujifilm.com. So we are just one click away from you, and I would be glad to provide all the assistance. So that's all from my side. Thank you so much.
Thank you, Hitesh. Thank you, Hitesh, and thanks for joining us here at this point. Shall we move to the last lecture?
Yes, sir.
So, can you hear me?
Yes.
Can you hear me?
Yes, sir. Yes, sir. We can hear you.
Yes.
Okay. I hope everybody is there, or a few of you. So this was just what Dr. Bala was mentioning about the use of costoclavicular catheter for the shoulder surgery. What I do was I used to use a stimulating catheter, inserting in the costoclavicular area at the posterior cord, and then I used to stimulate the posterior cord and then insert the stimulating catheter and all the way insert it into the retroclavicular area and into the supraclavicular. You can see after injecting the contrast, you can see the catheter tip lying at the level of T1, at the level of C7 and T1, and 30 ml of contrast along with 0.25% bupivacaine. It reached the level of C7 and maybe C6, probably. But the tip of the catheter can be seen, and this is the catheter which goes from this area. So probably because he mentioned that the use for shoulder surgery, a single shot, I'm not really sure whether it really works. But if the catheter is directed from caudate to cephalad, stimulating it at the level of C6, where you get the biceps twitch or the deltoid, basically, then it's a possibility that you might be able to have a shoulder analgesia. But otherwise, I'm really unsure. We are now looking at the costoclavicular single shot injections, and we're trying to assess the supraclavicular spread by injecting contrast. And myself and my colleague Dr. Avinash, we are going to run a study in this particular area, because we do get a lot of cases for the below elbow surgeries. So this is what I got a question for the costoclavicular for shoulder surgery on the WhatsApp group. So I thought I will just clear this with the help of this particular slide. Coming to my talk, it's about the erectospinal plane block and where would you inject. This is in conjunction with Xavier Salablanche. He is a consulting anesthesiologist and anatomist at Hospital Clinic in University of Barcelona. Now we know that this can be done at various levels, the cervical, thoracic, lumbar, and sacral, and there are lots of indications. The sacral, we might present, Arunangshu is getting ready with one of the articles, I suppose, so we might present it or publish it sometimes. We have published several articles regarding the erectospinal use for multiple unilateral injuries, polytrauma of the unilateral ribs transverse process and the sacrum, you can see. We also mentioned that the erectospinal, it goes into the paravertebral space at the level of T5, while the paravertebral, it goes into the epidural space. We also mentioned that lumbar erectospinal plane block, you can see that it goes at the level of roots, lumbar roots here, and then you can see the oblique axial and oblique coronal. You can see that it bathes and soaks the dorsal and ventral part of the lumbar roots. This is the root which is coming out. So this is not an ambulatory block as we might suppose, and you need to be cautious when you put these patients on infusion pumps. We also published about the use of bilateral erectospinal plane block for the posterior cervical spine surgeries, and this was with Dr. Ketan, spine surgeon who was with us. And this is the contrast study which beats the dorsal of the dorsal rama and never goes into the epidural space anytime. And it goes into the paravertebral space sometimes, but without any phrenic nerve block and without the motor block as well. This is an article which we published in the Spinal Journal, and this is the case series of scoliosis. And this was done in 6 patients. In 1 patient, it was a catheter technique, and we mentioned the different volumes of local anesthetic used on the convex and on the concave side, where you can see large volumes on the concave side, while lesser volumes on the convex side. This is the catheter placement with the contrast study, and this was with Dr. Turan. Now, Turan is the chief of clinical research outcome in the Cleveland Clinic, and I learned a lot of things from him too, apart from Abhijit in India. We also mentioned the lesser requirements of intravenous anesthetic agents and dexmed, and these are the VAS course till 48 hours. And beyond that, then we put them on fentanyl patches or buprenorphine patches. Now, this is published in the Turkish journal, where we mention about the phrenic sparing block with erector spinae, and this arose a lot of interest, and has been mentioned, has been cited in the original anesthesia pain medicine. And there was a lot of debate between Bansui and Ashwarki regarding this. And we also have uploaded one of the letter to the editors, which is accepted and which might be published shortly as well. We focus on thoracic ESP, and we leave the other for the next tracks. The need to study is because there is a problem with standardization and nomenclature. Tulgar from Turkey. Now, he's in the department of Maltepe in Turkey, and his classification depends upon where you localize the needle tip. Like this is the at the level of the transverse process on the top of erector spinae. This is the mid between this the transverse process. This is the needle touching the superficial and deep part of the transverse process. This is the mid to transverse process, and this is the costotransverse block. Now, he has raised some relevant questions like, is it an in or out of plane? What are the boundaries of the transverse process of the costotransverse block? What are the modifications? And with the repeated manipulations, it will influence the spread of local anesthetic agent. Now, we have some answers with the letter to the editor by these people from Morocco, where they classified where you place the local anesthetic agent, and these are in 3 places. So this is the ESP, that is above this particular structure, and this is the CTS, or the costotransverse space between these 2 structures, and beyond this is the paravertebral space. So you have got 3 definitive spaces where you inject your local anesthetic agent. But again, to add to confusion, this is a study with 10 embalmed cadavers where they compared 20 ml of methylene blue dye injection into the ESP. MICTB is multiple injection costotransverse block, and this is the thoracic paravertebral blocks. What they found was the spread from ESP to paravertebral space is 60%, while the spread from multiple injections of costotransverse space to the paravertebral is 100%. And they conclude that the MICB, that is multiple injection costotransverse block, it stains the ventral nerve, the sympathetic trunk, and the dorsal nerve. And they have this tabulated form where they mention that the multiple injection paravertebral and the multiple injection costotransverse block, it really goes into the this goes into the paravertebral space and stains them at equal points. Now, what we would be looking into today is the needle tip placements, the planes and spaces, the volumes of injection, and the spread of injections. Now, this is the embryonic at the 23rd week, and you'll see that they are well formed. The erector spinae muscles, they are sheathed. This is the transverse process, that's a rib, that is probably the costotransverse ligament, and a deficiency here during the birth can probably lead to a deficiency in the adulthood, and then if you inject at this point, it might percolate. So this is the embryonic erector spinae muscle. Now, is it an interfacial, intramuscular, or a myofascial plane that we wanted to study with Xavier Sala from Spain? These are the fresh frozen cadavers in the prone position where we dissect until we get the erector spinae muscles. This is the spinous process. That is just by the spinous process, that is transverso spinalis, and these are the erector spinae muscles which go right up to the cervical area, and some they land into the ribs laterally at this point. So what you do is you have in plane, this is the probe which is kept right on the costotransverse junction. You find the costotransverse junction, you place your needle, it goes to the superficial erector spinae sheath, the muscle, and then the posterior erector sheath. and then you place your needle onto the costotransverse junction. You inject your local anesthetic agent. So it all depends upon how and where you place the needle. You can also go in a transverse plane, and you can insert your needles from medial to lateral, from lateral to medial onto the costotransverse junctions there. So that is exactly deep to this particular sheath. Now, this is very important to understand. We have reflected the erectospinal muscle. What you find is the erectospinal plane, that is the transverse processes, and this is the retrolaminar area. So if you position your needle just medial to the transverse process, it's going to be a more of a retrolaminar block. And if you position your needle just lateral to that, it's going to be a more of erectospinal plane block. So I think this is the one which is going to determine the position of the needle as well as the spread of the drug. Now, in between the two transverse processes is what we mentioned is the intertransverse ligament, and the costotransverse ligament will be between the rib and the transverse process. And this is the spinous process. So you are looking from medial to lateral on that side. Now, how can we simplify? We have 4 specimens. We look into the anatomical structures, plane and spaces, contents of spaces, and the barriers. So we are more looking into what are the barriers. So how it is important, the sagittal section. Now, if you look into a sagittal section, we take this section in this form. At the level of costotransverse junction, it goes vertically, and we have 4 specimens. Now, what you see here, one is the superficial thoracolumbar fascia. This is the superficial thoracolumbar fascia. This is followed by the superior erectospinal fascia, and then this is the erectospinal muscle, and then what you see is the deep erector fascia. So this is very important for us. Deep to the erector fascia will be the connective tissue here. These are the transverse processes. So this is transverse process 1. This is the second one, and that's the third one. So the structure joining these two transverse processes is called the ITL, or the intertransverse ligament, which is a thick one. It has got 2 fascias and a muscle between. And this is the rib. Structure joining the rib and the transverse process is the costotransverse ligament. So this is the costotransverse ligament there. Now we have the ITL and the CTL, and the area between these two is called as the costotransverse space. So this is called as the costotransverse space. And the area beyond the costotransverse ligament is the paravertebral space. So now what you have is, you have deep to the deep erector is the erectospinal plane. We call it as a deep erector plane. Then beyond the intertransverse, you have the costotransverse space, and beyond the costotransverse space, you have the paravertebral space. Now, when we went into loop dissection of these spaces, what we found was you have the dorsal root in the costotransverse space, and you have a ventral root in the paravertebral space. So this dorsal root, it emerges into the erector sheath, and then in the plane here, and then it goes on to innervate the skin and the subcutaneous tissue. So whenever you deposit your local anesthetic here at this point and deep to the intertransverse ligament at this point, it's going to be a dorsal rhamite block until it crosses the costotransverse ligament and it soaks the ventral nerve. This is the paravertebral block. So I think it's going to be very difficult for the local anesthetic, even if you inject 40 ml, to percolate from this through barrier 1, this is barrier 2, and this is barrier 3, and then it comes into the paravertebral space. So what we conclude from this is that if you position your needle this way, like this needle is right on beyond the deep erector in the erectospinal plane, this is the local anesthetic. It is going to traverse all these spaces, and then it has to percolate to this barrier 1, barrier 2, barrier 3, and then the paravertebral. But instead of that, if you insert a needle into the costotransverse space, and if you inject a local anesthetic agent here, it's going to be only one barrier to block the ventral root. And this is the paravertebral block proper, where you traverse barrier 1, 2, and 3, and then inject a local anesthetic into the paravertebral space as well. So we have to remember we have got just 3 spaces and we've got just 3 barriers. That's not the levels, but we have just three barriers. So the three spaces are the deep erector space, the costotransverse space, and the paravertebral space. And the three barriers are the intertransverse ligament, the costotransverse space, and the superior costotransverse ligament. So you do not get confused with so many of these positioning of the needles and the local anesthetic placements. So you can just remember this way. Spread of the local anesthetic, they mention about the soaking of the epidural as well as the foramina in the coronal plane and the transverse plane. And this study by Xavier Sala and Luc Seremius, which came in the Canadian Journal, they mentioned that at no time does the dye exceed the posterior limit of the bony structures of spine and trunk. So that's it. It's just a dorsal rami block. So this is what they have dissected, and they found that the ventral rami is totally sprayed, while the dorsal rami, it gets blocked in all these cadavers. Unpredictable inject spread in erectospinal plane in human cadavers. So they have studied 11 cadavers. They have come out with some schematic table, but they have not shown the pictures here. So this is what they mentioned, which they mention is unpredictable, and I agree to some extent. Now, sometime back, we demonstrated ESP at a level of T5. Now, it's important to understand that T5, the costotransverse ligament is deficient anatomically. So the cadaveric and contrast spread, what we find that there is no difference between erectospinae on one side and paravertebral on the other side. So perhaps this was a mistake because we never understood that it could spread on both the sides. This is a formalin-based cadaver. We should have injected at least different color injections, or we should have had at least 4 cadavers where we have 2 injected paravertebral on one side, and then we take transverse sections, and 2 injected ESP on the other side, and then you take a transverse section of this. So this can be inconsistent. Now we also showed in that the contrast in live volunteers or live patients, it spreads from the erectospinal plane through the dorsal rami and through the costotransverse junction into the posterior epidural space and then onto the other side. And probably this is the reason why many of us, we have seen that in spine patients, because we do a lot of spine. We have got 3 row spine units, and we do a lot of spine surgeries. And we in the past, we saw that when we injected 10 ml on one side and 10 ml on the other, the patient used to go into hypotension. So it's probable that this could be because of the epidural spread as well. So what is the evidence for local anesthetic volumes? Now, this study from the Journal of Clinical Anesthesia has studied several articles injecting 20 ml of volumes, and they conclude that the mean volume of local anesthetic would be around 3.4 ml per dermatome. Now, this is basically for the thoracic erectospinal plane block. We are not yet concluded to the cervical and the lumbar as well. Now, does it produce surgical anesthesia? Amit kept on asking me every time when I sit here whether it's whether it really produces a surgical anesthesia. I doubt. There are some claims of surgical anesthesia for mastectomy, but I'm not sure whether it blocks the LPN and the MPN nerves, and the hip, whether it blocks the sacral nerves, or how consistent they are in blockade of the ventral nerves. Now, these studies, which have been appearing in many of these journals, there are some missing variables. Now, these missing variables, they never mention the sensory delineation. They never mention the total dose of intravenous anesthetic agent, like they have been using propofol, but they do not mention the mean volume of propofol used for these cases. And they never have come up with any contrast studies in these particular cases. So I cannot really say that you can use this for surgical anesthesia. And I'll just say, yes, I can consider that. So what is the critical analysis of these studies? It is a superficial block. You can use it in patients with coagulopathy. We have used that. And in patients in whom you expect postoperative anticoagulation, we have used that. Now, if a TEA or TPVB are contraindicated, for example, if you have a patient with multiple rib fractures and spinal cord injury, you cannot use a paravertebral, you cannot use a thoracic epidural. And in the same patient, if they have a posterolateral rib fractures, we see a lot of hemorrhagic collection in the paravertebral space. So it's a contraindication. This can be used as a risk analysis here. So it can be best used for minimally invasive surgery, and it has been classified by this author as a minimal invasive regional anesthesia. So we are all honored to have you on PRAC. I missed this particular picture of us. I wanted to insert that as a moderator sitting here in this PRAC studio. And this is the end of PRAC session as well as my lecture. So thank you very much for your kind attention. So if you have any questions, we can take those.
Sandeep sir, this is Ritesh here.
Yeah, Ritesh.
You told about the CT costotransverse ligament. Okay, that part you explained about the thoracic erector spinae. But what about the lumbar? And regarding the cadaveric staining, that you are telling that the ventral rami doesn't get stained, but the clinical picture is different from what the cadaveric staining has shown, because in clinical practice we have seen a good amount of because in laparotomies there right now in our institution we hardly use epidurals. It is all erector spinae, and if it's a very big incision we give a erector spinae bilateral catheters, and the pain relief is just fantastic. So the cadaveric picture, what is reflected, the clinical picture is different what we are seeing in our clinical practice. And regarding the hip surgery, regarding the sacral plexus, one of my article is in editorial in Journal of Clinical Anesthesia in sacral plexus. We are doing a lot of sacral plexus in aerorectal surgeries, and we have done few cases combining 2 days back we did a acetabulum fracture. It was under spinal, but for post-op analgesia, we gave a combination of lumbar ESP and sacral ESP, and the post-op pain relief was just fantastic. So what's your comment on that regarding the ventral rami staining?
So Ritesh, regarding the, we were discussing just the thoracic ESP, and this was just the sagittal sections. We are not discussing the transverse, or we are not discussing the coronal. So these are going to be different sections which we are coming out with. So we are looking into each of these very minutely. The intertransverse ligament is very thick. The costotransverse ligament is very thin, and it's very easy for the drug to percolate costotransverse to the paravertebral, but it's very difficult from the erector spinae into the paravertebral. What you mentioned about the pain score, I think you need to quantify that. You cannot just say fantastic. It has to be something in a like VAS, or the amount of analgesic, or what is the time to first anesthesia. All these things have to be mentioned. So it basically what we see into is the ESP at the thoracic level. If you say if it works for the abdominal, it is through the lateral cutaneous nerves. So that we have seen it, the drug going as far as the lateral cutaneous nerves and going right into the area of the SAP. So it acts through that. So it cannot go into the paravertebral multiple spaces. It can go just in 1 or 2 levels. So that is my take on that. This is one thing. The second thing, what you mentioned about the sacral, about the lumbar ESP and the cervical ESP, these all are different anatomical structures. You cannot classify them into one single group. So if you have a cervical, it has to be separate. A thoracic, a lumbar, and sacral has to be separate. I agree that at the level of lumbar, we have seen that it almost acts equivalent to a lumbar plexus block regarding the analgesic effect, not the anesthetic effect. Regarding the sacral plexus, I use it only for certain surgical procedures. As you mentioned, you have used it in acetabulum. I have seen Arunangshu mentioning to me he has been using it for anorectal surgeries as well. Under spinal and general anesthesia, we are also conducting a study along with him, because I have got a lot of CT contrast studies, and I'm running a cadaveric study as well regarding the sacral erector spinae with Dr. Nitin Gawai, who's also here on the screen. So this is my take on the whole of the erector spinae. Ritesh.
Sandeep, can I just put one thought here? Although the cadaveric studies are elaborately telling us and clearing the entire concept right in front of our eyes, perhaps when it is a living being, we have pulsations of the blood vessels, and we have the pressure changes of respiration. So maybe Ritesh, this is what probably you are trying to point out. But Sandeep, my direct question to you is: you have thousands and thousands people watching your lecture, and we are at a crossroads where so many techniques are getting implemented and introduced every day. Tell me, if you want to choose one, because it's very difficult to really say this is retrolaminar or this is, the TP, or this is the costoclavicular. I know it's easy for us because we do it day in and out, but give them one clear message. If there is one block you want to pick up, say for unilateral chest wall, one block to pick up, say for unilateral abdomen, or one block to pick up for hip and lumbar, unilateral, what would be your answer for that?
Roshali, it's really difficult to say right now because Shiva is you're just smiling. It's very difficult to say right now because here in our department we are running so much of research and clinical trials. For example, ESP versus interscalene for proximal humerus and all these things. So it really becomes difficult right now to mention that this block would be suitable for this particular surgery. But that's a very nice article written in Astra newsletter where they mentioned that this is a minimally invasive regional anesthesia which can be used for a minimal invasive surgery. So people have been using it for like extensive surgeries. I'm really surprised that a dorsal nerve block can be really utilized for a ventral surgical procedure. I'm really amazed at this. I'm not sure how this goes into. Yeah, Shiva.
Sir, now this analgesia, there is no monitor, and 10% also is analgesia, 90% is also analgesia. When we know in brachial plexus, we all of us seen, even if you miss your needle out, if some of the fascicles are not soaked, surgical anesthesia is not going to be there. Unless we have such a end point. Comparing studies is our own imagination. You may say fantastic, I may say it is not at all working. So till that sort of a monitor is available with us, I mean, analgesia studies we have to look at very critically. And when you say that, yeah, precisely, sir. When you put your local anesthetic just above the fascia iliaca, it is not going to work on the femoral nerve. When such a 1 mm fascia produces such an amount of impedance, and putting 1 centimeter away in the erector spinae block and then thinking that it is reaching the paravertebral spaces, I'm really sorry, I can't just even imagine that. So analgesia is, this is the deficiency. We have to look at, I mean, I don't know how to, even if I say that your local analgesia is because of systemic absorption of local anesthetic, how you are going to defend it? Instead of putting 50 ml into the ESP, if you give, say, 5 milligram per hour of xylocaine infusion, we may have a better analgesia than putting into the muscle plane. I don't know, I'm just saying. So analgesia is a vague terminology. There is no quantification. Still, we have such a monitor and tool. Comparing is really is an imagination of the performer.
Yeah, Arunaksha, you had something to say?
Yes, sir. The one thing I want to say that regarding this costotransverse block, it is anatomically we can assume that its effect will be more similar to the paravertebral block because it is closer to the paravertebral space. But if we look at the drug spread, because we know that in paravertebral block, that drug will not spread more than probably 2 or 3 levels. But erector spine, you can see that if you give 20 ml, the drug spread is much more, much more longer. So probably there's a difference between the drug spread and the difference between the drug, whether the drug reaches the ventral roots or not. So depending on where you put the injection. So probably your cadaveric studies will answer those questions. But what I want to say that since you already mentioned that at thoracic 5 level there is this membrane is deficient. So is there a possibility that if you put a really high volume at thoracic 5 level, and then the drug may actually reach the the nerves that innervate the chest wall and give a good analgesia for a breast surgery? Because I have also experienced what Ritesh was saying. for chest wall reconstruction surgeries, breast reconstruction surgeries, electrospinal unilateral, it works. So
I'm not sure why you push on giving very high volumes of local anesthetic and try to reach from the one space to the other space and the next space. Why don't you make it very, very easy? Like if you have an ultrasound, if you're seeing the needle, why don't you put it into the paravertebral space? If you really want that particular block for that particular surgery. We have been doing paravertebrals without ultrasound with a loss of resistance technique. Gopal may not agree to this because the last time we had a pro-con session in AIMS. But we have done it in the past and in the neonates as well. We have done these blocks and they really used to be wonderful blocks. But now, since ultrasound has arrived, the needle has been moved retrograde from the paravertebral into the costotransverse and now into the erectospinal plane. You're moving more backwards with improved technology.
Right.
It's quite disheartening to, yeah, Harshal, please.
Yes, I just actually put the question in the chat box. You mentioned about the erector spinae in scoliosis surgery. I just wanted to ask whether does that not alter the SSCP if you're monitoring? Does that make any impact on?
Yes, we did monitor the SSPE as well in all these patients. I agree with you, Harshal. That was a real good question. What we did was briefly, before we, just after induction in supine position, we had a ESPP on both on the left and right side. Then we made the patient prone and then we had monitored the SSP on both the sides. Then we gave the block on one side, we monitored the SSP again, we gave the block on the other side, we monitored, and then intraoperative and post-operative. We have all the records. So that will be the next article which needs to be now uploaded because we saw that at no point of time the SSP were affected with the local anesthetic agent. So that was very important. Yes.
Right. Thank you. One more. How do you manage to convince patient and surgeon about dye studies, and how do you manage the cost of CT and dye if you have to do it, say, in a patient? You've done so many patients after realizing that the dye would have gone somewhere else or local anesthetic. How do you manage those?
So yeah, Harshal, that's another question that I need to answer. So the convincing the surgeon is not a problem here in our hospital. They are very much with us for all these studies. The contrast studies I have been spending on my own since last 25 years of my practice. So I do that on my own. So I don't charge the patients, and so that's it.
Right. Thank you. Thank you.
Another way to convince the surgeons are to make them your co-authors.
Yeah, they are always. So you will find in all my articles there is a co-author. They are the co-authors.
Yeah, get them involved in the study.
Yeah. So we have, if we don't have any questions, we wind up.
Yeah, just in concluding statement, Sandeep, I think you and your entire team
will answer more, sir.
Deserve all the plaudits for conducting a wonderful webinar.
Thank you very much.
Ali and Satish Kulkarni to take a leaf out of your book and look actively at conducting the AORA 2021, which is scheduled for April in Mumbai, as a webinar. I mean, as we know now, it stands cancelled, but let us take a leaf out of this book and have the AORA 2021 as a webinar next April. Yes, Roshali?
Yeah. Yes, actually, we all five had already discussed about it. And now the nitty-gritties can be learned from Sandeep and his team. And we probably should look at the live relay feasibility as well, if at all it is feasible. I totally agree with TVS here.
Sir, Gedu sir, do you have any remarks?
Nothing. All I am saying is something, for me also, this is a big learning process, I can say. It just suddenly changed me also. I'll start taking active interest now into this also. I think you people have changed me also now. All I can say that. And of course, last but not the least, sincere, heartfelt thanks to all of you, your prac team, and of course, all the speakers also, wonderful one. The active participation by everybody was well appreciated. Thank you very much.
So let me conclude with this. I thank my team, Dr. Amit and Dr. Sachin over here. I also thank Dr. Bharati, Dr. Madhuri, Mamta, Ganesh, Nitin, Himanshu, Lakshmi, and Dr. Abhijit Lonikar, who is not here with us. I thank you, everybody. Amjad, Shiva, Harshal, Roshali, Malati, and everybody up to Gopal is always there, Ritesh and Azam, Neha too. Thank you very much. Let me finish this. I once again thank Dr. Parag Sancheti and K.H. Sancheti for giving us this platform, and immensely thank Dr. Ashok and Rahul Chaube. Not to forget Pallavi Lande. She is the chief editor of this Anaesthesia TV as well. She had messaged me. So thank you very much.
Thank you,
Abhijit, Lord, Arunangshu. Bye-bye. Take care. And
bye-bye, sir. Take care. Bye-bye, sir. Bye.
Thank you very much. Thank you all. Bye-bye.
3 cheers. 3 cheers for Prague team. 3 cheers.
Hooray!
Ritesh.
Hip hip hooray! Yes.
Thanks a lot, Ritesh. Bye-bye. Take care.
Bye-bye, sir.